for this. So this is just a little aluminium bar with a peel away sticky bit at the back. So you literally just peel that off, okay, and you just stick it onto the bridge of the nose, and when you put it on, you get a much better seal on it. Okay, but it still steams a little bit. Okay, so you can get a better seal.
Hi there, my name's Louise Shepherd. I'm the CEO of Alder Hey Children's NHS Foundation Trust, and I'm absolutely delighted to welcome you to our stage here at the Giant Health Tech event. It's a real honour and privilege to be joining you today from our innovation hub here at Alder Hey, which has been with us for about 5 years now, and has been a crucial part of our journey as one of the leading healthcare providers for children and young people, not just in the UK but across the world. Our vision is to deliver a healthier future for children and young people, and we recognise that to do that we have got to be absolutely at the forefront of all the latest developments in terms of healthcare and providing a really important service for children and young people to enable them to solve the problems that they face every day, not just here in the UK but around the world. We're passionately committed to that. We've got fantastic clinicians who've worked collaboratively for years now with industry and with academic partners to enable those innovations to happen, and we're absolutely committed to working collaboratively with everybody across the world in this endeavour. So today we wanted to share with you the journey that we've been on, why this is so important for us, but crucially for children and young people, the many problems that they face, as I say, not just here in the UK, but around the world. And we want to share some of that learning with you and learn from you too about how we can make this even better for the future. So thanks again for joining us. Really looking forward to having you with us today and going on this journey together.
Hiya, my name's Ian Hennessy. I'm a consultant surgeon at Alder Hey, and I'm also the clinical director of innovation. And I just want to try and get across to you not just why a hospital would want to do this, not just why the chief executive wants to do this, but actually why do clinicians want to innovate? And what's the driving force behind it? What's the thing which pushes us along? Because obviously we know we have a busy day job. So I'm going to use my story and my thoughts on why it's so important for clinicians to innovate. So my job, to give you a bit of background about me, is so I'm a paediatric surgeon. I operate on this bit. That's me in an operating theatre. They're actually testing a bit of kit out. And I operate on, big kids, well kids like Ted here, and operate on some really, really unwell children, and tiny babies. I think the smallest I ever operated on is about 400 grams, so you can fit that type of baby inside your hands. There's an incredible diversity of what we do, and technology is a very key part of how we deliver care. But the other half of my job is I'm the director of innovation. My job is to go out finding newest and latest technology and trying to apply it into healthcare. And this is me with the latest type of operating microscope, which has a 40 times optical zoom and actually has got 3D. I can put 3D glasses on and it will recreate it in 3D, and I'm operating on a custom printed operative model there, which has been 3D printed out and with tissues to mimic what real children's tissues are like. Now, I'm going to use this picture here to get across to you why I spend half of my time doing that technology piece. Why is it that, because it's an important job, being a paediatric surgeon, I really enjoy doing it, but why do I spend 50% of my time working on technology? So this here is a painting by a Liverpool native called Hulas, who lived at the end of the 19th century. And at the time, 50% of children wouldn't see their 10th birthday, 50% child mortality. And he had a child die at the age of 1 from tuberculosis. And he painted this painting in response to that. It's called The Doctor. It's an incredibly famous painting. And people, when they look at this painting, they see lots of different things. Some people see the good and caring doctor, who's clearly been there all night, concentrating and doing everything he can to save the child. Other people see the beautiful child in the centre, clearly gravely unwell. Other people's eyes are drawn to the parents in the background, the emotionally shredded mum with her head in her hands on the table, and the dad there. And that look on the dad's face, that's not changed. I don't care what you do, pal, but just get on and do it. And I think I see something personally different when I look at this painting. He's just doing it all wrong. Her airway's in the incorrect position. She's got no oxygen on. She's got no intravenous fluids running. She's probably got bacterial infection, not being given any antibiotics, so IV ceftriaxone probably good. No oxygen saturation monitoring, no point of care testing. Not the right sort of bed, chair for goodness sake. He's got unlabelled medications there. It's not bearable with the elbow. It's all wrong. It's all wrong. If I could, get a backpack, went into the hospital, filled it with kit, got in a time machine, jumped back, came out here, I could fix this. He doesn't stand a chance. He's got no chance at all, but I could jump in there, fix that, like that, right as rain by tomorrow. Maybe I've not even thought of antibiotics there yet. I'd be like a magician. How could you possibly have fixed that? And what knocks me out is I'd love to have a chat to this doctor. Because imagine the questions that would come back. It's like, how do you do this? How do you fix this? How do you cure this? I'd love it when they ask in the smallpox, how do you treat the smallpox? Well, we don't have to. We've destroyed it. We eradicated it from the planet. But what really frustrates me is that, let's jump forward to today. Let's imagine we have a gravely unwell child with a stage 4 tumour that's got poor cytogenetic profile, and we throw everything at it and it doesn't work, and you just feel so futile. And you know that we will figure this out, that in 100 years' time there will be a doctor, a smug doctor, standing there going, well, that's right, that's easy, just get a meta-ion infuser, be right as rain by tomorrow. And for me, what drives me, what drives the innovation at Alder Hey is that we can't wait that long. We must be faster, we must accelerate towards it. So I'm going to give you another story about the power of technology and how it is, in many ways, magical. I'm going to speak about Leah. Leah, this is Leah. This is Leah the day before her diagnosis. And unfortunately, Leah had a terrible tumour. This is huge. The white bit is the tumour, the black bit is the rest of the child. In her abdomen, huge, enormous. And it had been assessed by national panels and didn't think we could get it out. We thought we were going to have to palliate this child. We're not going to be able to treat this tumour. And her dad had worked at Alder Hey, and he came to us and he said, look, could you get this tumour out? Would you be able to excise it? Now, these are two of our top oncology surgeons, cancer surgeons, Joe and Fiona. They weren't sure. And they came down to our innovation hub, and this is where we do all the tech development. It's very similar with a great big microscope and all the rest of it. And this is where I'm standing in the prototyping part of it. They said, look, could you print, they knew I printed out complex things, could you print out this tumour so that we can get a better idea of whether or not we can take it out or not? So we did that in partnership with 3D Life Prints, who are our embedded 3D print hub, and we printed this tumour out. Now, the white bits are our hip bones, the red bits are really important vascular supply, the yellow bit is the tumour. And what was so fascinating was they started building this case, they started building this team to take the tumour out. Could we do it? Because it also had this so I'm one of our urologists, we're looking at the ureters, which is what connects the kidney to the bladder, went right through the centre of it as well. It's like, how are we, how can we get this out? And Joe Fiona, they built a team, they built a consensus of people that are going, yes, this is reasonable, we can take this out. And the day of the operation, again, using a bit of sci-fi, it felt like the X-Wing fighters taken off to go and do Battle of the Death Star, because they actually closed, they locked the doors to stop people from sticking their heads in and out, asking all the time, how's it going, so not to be put off by it. And after a very long time, not only had they got most of the tumour out, they got 95% of it out. But she was still incredibly unwell, sort of straight after the operation, still requiring chemotherapy and all the drugs, and to get over the actual operation itself, which she just did spectacularly well. So from that little girl who had that massive tumour inside her abdomen, which, if taking that tumour out, they could have cut off the blood supply to her legs, they could have done all sorts of things, but they managed to get all the tumour out, 95% of it. And this is her 6 weeks later going back to school. And this is her and her family ringing the cancer bell at the end of treatment.
Look at this telly down here, Leah. This is a picture of you ringing the bell in the hospital, which people get to ring when you finish your treatment. I know you'd heard that bell being rung by lots of other people, so can you tell us what that was like to ring the bell in the hospital?
It was like the best day of my life, because I was there with some of my family, and they were standing there with me, and what I've been through, I think my family would have appreciated.
So what was the worst day of our lives was immediately became the best day of our lives, and Joe and one of the other surgeons, Fiona, came up to see me and my wife on the ward. I think it's fair to say there was a few tears, wasn't it?
There was, and a big hug, biggest hug.
You said it before, Dan, it feels like a miracle. It just feels like a miracle. We're so blessed to be able to sit here and tell Leah's story. The three reasons we want to tell Leah's story. We want to give credit to these guys. But without them coming into our lives, Leah probably wouldn't be sat here now. And we want to give hope to other people who maybe find themselves in a similar situation now or in the future. Miracles can happen, and never give up on that.
So I'm sure they agree that is a pretty good reason why we need to innovate, why we need to push the boundaries, why we need to achieve these things which beforehand would have been regarded as magic. The classic Arthur C. Clarkeism, any sufficiently advanced technology is indistinguishable from magic. And that's what we want to happen at Alder Hey. We want the children to get better as if by magic. Now, that was a powerful story, but innovation doesn't always have to be life or death. Sometimes it's the little things which make an enormous difference. And I'm going to hand on now to one of our superstars of the hospital, Lewis, and a project which he recently challenged us with, and one of our innovation consultants, Jack, took up that challenge. So I'm now going to hand over to them as to why it's so important from a patient and parental point of view.
Hi, my name's Jack Morton and I'm an innovation consultant here at Alder Hey Children's Hospital. This morning you're going to hear from a lot of my colleagues about the amazing work we are able to do to help the children and their families that come through our door. I was privileged and humbled to work in collaboration with Endura to help one of our young ambassadors, Lewis, get the cycling gloves that he deservedly wanted. But instead of me telling you about his story, I will let him and his family tell you.
Hi, my name is Lewis and I'm 7 years old.
Hi Lewis, why did you want some gloves?
Because on my bike, the handles hurt.
My hand's hurt.
And your hands hurt?
Yeah.
And why do they hurt?
Because on the handles.
Okay. And why could you not wear normal gloves, Lewis?
Because I got 4 fingers.
Oh, and what about your other hand? And why have you got 4 fingers? Why is that?
Because I have a piercing deep.
Okay. And have you had any operations on your hands?
Yes.
How many?
16
16 on your hands or in total?
in total.
Okay. Can you remember having operations on your hands? What did they do?
Then put a bandage on
Yeah.
and then made me some fingers.
Okay. So, we needed some gloves. So what did we do? Can you remember what we did? Who did we write to?
Alder Hey.
Me and my wife contacted Alder Hey Innovation Centre to ask if there was anything help they can give to Lewis. We just wanted Lewis to be like everybody else and have a pair of gloves that fitted him. Over several years we've been buying gloves and having to stitch a finger up or cut a finger off of the gloves themselves. So it was really important that Lewis felt just like one of his peers. So when he was cycling on his push bike, when we were teaching him to cycle, we used to have to put masking tape on the handlebars because the way Lewis's hands couldn't grip the handles well, and they would really hurt him in several areas. So when Alder Hey came back to us and said, look, we're looking at it as a project, we felt some real hope and we put everything towards that way to help them. So then, Lewis, when you wrote to Jack and Ian at Alder Hey, you asked for some new gloves. Can you remember what happened then?
We sent a photo
You sent some photos.
on my hands.
You sent your photo of some hands. Okay, and then what did we do here? What's this?
We measured my hands.
You measure your hands. Okay, put that down. So we measured your hands. Put your hands in them now. Turn it round. So what did we do? Can you remember what Daddy did?
Dad tore around.
Dad drew them around. And then what did we do with this piece of paper? What did we do with it?
We measured my hands.
Measured your hands. And did we send it to somebody?
Yes.
Who did we send it to? Can you remember?
Jack and Stephanie.
Jack and Stephanie. Now Stephanie works at Endura. Yeah, and Endura make gloves. So we had lots of information backwards and forwards, didn't we? Lots of emails. And then Stephanie from Endura got in touch. And after lots of emails, we came back with a pair of gloves, which made my wife and I overwhelmed with joy that all we wanted to be was Lewis, just to be one of the crowd. So he got his first pair of gloves and absolutely loved them. And then, unbeknown, we then got another pair sent, which Lewis likes to use as his goalkeeping gloves. So we can't thank Alder Hey or Endura enough. They've been absolutely brilliant. They listened to everything we asked for, and nothing was too much of a trouble. But really supportive, and we put the faith of what we could give to our son in their hands. Many thanks.
Fit like a dove. Thank you, Alder Hey and Endura. Bye.
Hi there, and welcome to the Hacks workshop, basically. This is our rapid prototyping centre at Alder Hey Children's Hospital. It's not particularly fancy, I'll be honest. It's basically just some worktops, some hand tools, some drawing boards, some things just to kind of get your creative crafting juices going. But essentially, it's like a solution centre. You've got an idea, you've got a problem, you come down here, you've got some members of staff, we'll just sit here and try to work things out. And I thought I'd just kind of go through some of the simpler things we did. Not necessarily the big AI projects or data projects, but the simple hacks and tricks which we used to solve the problems which were getting thrown at us every single day while we were in the hospital. Now, I'm pretty sure everyone else will have been plagued by the problems of having your glasses fog up. This is actually something we spent a lot of time on in our rapid prototyping centre trying to fix. So, straightforward mask, one of the terrible ear loops. Problem is, you don't get a very good fit with the wire that comes with a lot of the masks, so that when you put your glasses on, lo and behold, they steam up so you can't see a thing. Now, there are many ways around this. One way is to get a better fit across the nose. A really cheap way of doing this is you can actually buy extra nose bridges for this. So this is just a little aluminium bar with a peel away sticky bit at the back. So you literally just peel that off. Okay. And you just stick it onto the bridge of the nose. And when you put it on, you get a much better seal on it. Okay. But it still steams a little bit. Okay. So you can get a better seal. And the way to get a better seal, and this is the ultimate way, and this is actually not a new thing, because as surgeons, we have problems with masks fogging up our safety glasses all the time. So we would just put a bit of tape across our nose, but that looks a bit weird. So what we've found is you can actually get double-sided sticky tape, which is designed to work on skin. And I think the official name is maybe lingerie tape. So just get a section of that, stick it onto the back of the mask, across where the nose bridge goes. See there? Yeah. And the difficult bit is peel that part off. And then, close your eyes when you're doing this. You can stick it on your face, and you've got a complete seal now, right the way across here. So that when you put your things on, doesn't matter what you do, you will not be able to steam up your glasses because you have sealed it off completely. Okay. That works well. The other advantage to this is that take the ears off, you can eat with it on, and it stops people from taking their mask on and off and messing with it, because once it's on, it's on. Because the only problem is, obviously, is once you take it off, it is a bit sticky. So that's a thing you can do. Now, another area that we looked at was anti-fog. How can you stop your glasses from fogging up? Now, we actually found that snowboarders have got this sorted, and that they have special sprays which you can get, which you can spray onto the back of the glasses. You don't have to do maybe once or twice a week, just to treat your glasses there. Just do it on the inside, and then that, if I just put this on upside down so that you can see so it doesn't really steam up as well either. So those are some simple hacks and tricks from stopping yourself from getting steamed up glasses, which actually was a big problem, because if people aren't wearing their eyewear and they're in contact with someone, and they've been doing this classic thing that people do, is they wear their eyewear on their top of their head because of steaming, then that means they have to self-isolate for 2 weeks. Whereas if they'd had their glasses down, then they don't, because they're wearing the appropriate PPE. So, simple tricks, but potentially could have a large effect. We've got hundreds of them, from how to make isolation hoods not exhaust out the front, and we could go on all day. But simple hacks. It doesn't have to be complicated. You don't have to have an artificial intelligence platform. You can have quite a big impact in a hospital just by doing little simple workarounds. So I would thoroughly encourage this type of solution centre in any hospital, because it's not just during the COVID crisis that we have problems all the time. And a lot of them could actually be solved in quite a simple way.
Hi, my name is Chun Kwok. I'm one of the specialist registrars training in paediatric surgery. I'd like to talk to you about the Handover app, which I've developed with Mr. Partridge in the paediatric surgery team. The Handover app is an app where we wanted to create something that we could access as a team. So we used to have a paper handover like this, and we wanted to go to something like this. And there were two reasons why we wanted to do this, make this app. And one was just the amount of printing that we needed to do. So each morning we would go into handover, and there would be 15 of us. We needed to print 15 pieces of paper. And we would hand over maybe at 5 p.m. and 8 p.m. so that would mean more printing. And it wasn't just the printing, it was the coordination. You had to coordinate who updated the Excel spreadsheet. So once somebody had it open, you couldn't access it. So we needed an easier way, a more dynamic way of updating the handover list, basically. The second reason was that the COVID-19 pandemic just spurred us on and pushed us to make this app on the phone, which you could wipe down, because it's the most sort of frequently accessed thing that I would put in my pocket, and on a piece of paper you just couldn't wipe it down. So we had to have something on the phone where you could wipe it down and access it in a safe way. So what did we do? Well, we developed an app where you could access all the patients of the day. You could update it in a dynamic manner. You could share the information with the team. You can basically see all the new admissions. You can see all the patients who are listed for emergency theatre. And it was really fortunate that we already had the platform in place at Alder Hey, which allowed us to do this. Even somebody like me with very little programming experience, I could use the Power Apps platform and develop the app in the way which we wanted it. So I could visually develop the front end of the app that met our requirements. And the Power Apps platform provided the back end, which was secure. So that met the information governance criteria that we had. What really made a big difference was the way that the app was visually very similar to the previous handover that we had. So there wasn't much of a mental jump or transition into using the app. We even had a mode on the app that was essentially looked exactly the same as the old paper list, and that made it easier for people to just jump into using the app. I think the other thing that really helped was the fact that even a user of the app myself, I could make changes to the app in a quick way, so the development cycle was shortened essentially. So somebody could find out a problem that we had with using the app and I could change it straight away. That meant that you could tailor and tweak the app in a way that made it much easier to use. So let me show you what the app does on the presentation. The app allows us to look at all the patients who are currently inpatients and even patients in other hospitals, and you could quickly at a glance see the hospital number, the date of birth, why they've been admitted, what our management plan is, and you could see where the patient is. So if they're in a ward on a certain bed, all that information is at the tip of your fingers, and all that information is updated in real time. The information is color coded, and it automatically updates the color based on which team the patient is in and whether they are booked for emergency theatre. It allows you to quickly add a patient onto the app by tapping on the add button, and you can easily fill in all the boxes in about a minute, and there you go, your patient is added onto the handover list. There are ways in which the app doesn't quite match up to how we could previously use the paper list. So for example, it's easy to write on paper lists, but on the app we still don't have the technology where you could easily write on the app. But there were ways that I tried to counter this by making a notes section where you could quickly type quick notes and that would be saved onto your app. What I was really pleased with was just the rapid uptake and adoption of the app by the various members of the team. The original plan was that we would try the app with a number of staff and see whether they liked it and make suggestions and changed it. But what I found was basically I launched it and the next day everybody used it because it was just a much easier way of dealing with information, the amount of information that we had. So I really want to thank the Trust and the team for providing this environment where innovation really thrives, where we could develop something that the clinicians developed and adopt it and use, and is really supported by the IT team, the staff here, and it's something that has begun to spread in other departments as well. We are developing apps for referrals with the cardiology team. One of my colleagues has developed something for the logging in critical events and incidents, and working in Alder Hey has really allowed for this kind of thing to thrive and to develop. So we hope that many other professionals would pick this up and develop their own apps, meeting their own requirements and benefiting the patients that they care for as a result.
Well, hello, my name's Dr. Richard Cook, and I've got a few minutes now where I'm going to talk to you about hand hygiene in hospitals and what I've been doing with the Innovation Department at Alder Hey concerning a product called Hygiene. So, a little bit more about Hygiene. Hygiene is what we call a personalised hand hygiene support system to improve patient safety, and I'll explain that over the next few minutes, what that means in practice. So in terms of people, the history and how we got to where we are, so as I said, my name's Dr. Richard Cook. I'm a retired consultant medical microbiologist and was the Director of Infection Prevention Control at Alder Hey until the summer of 2017. And I think the reason the Trust asked me to become Director of Infection Prevention Control is I have a passion about healthcare associated infections and of people avoiding preventable infections, and hand hygiene is a key part of that. And because of that, I was invited a few years back now to talk to the Innovation Department about how we could try to tackle the problem of improving hand hygiene in hospitals. And at that time, Alder Hey had an innovative relationship in terms of getting these sorts of ideas off the ground through their innovation department, linked to a company called Nova, that's a startup consultancy to develop potential ideas, and of course for financial backing, the support of Deep Bridge Capital. And it's those three parties that have made it possible to get to where we are now. I should also say, of course, we're living in a pandemic. Everyone knows about COVID-19. And on one hand, hand hygiene is the first line of defence, as we all know, against COVID. But in hospitals, the best figure, if you look at independent assessments of hand hygiene in hospitals, is at about 15%. But these are extraordinary times, and because of that, we've had to look at hygiene and adapt it to COVID-19. And in terms of the technology, for the NHS and the COVID crisis, whatever we produce has to be simple, low-tech, and have a low-cost infrastructure. It, of course, in terms of busy staff, has to have no impact on workflow, and it's got to be objective, non-judgmental, and provide data in real time to help staff. And it's targeted at improving that compliance rate. Currently, as I said, at best 50% in hospitals, and we wanted to see it at the 80, 90, 100% mark, which is what the public expect. But it's got to deliver in terms of confidence to management, staff and patients, and it's got the ability to be rolled out across the hospital. The system, when it was first designed, had a number of key components. The beacon, which is basically the link with the individual through their ID, NHS ID badge, the pickup station by the soap or gel dispenser to pick up the hand hygiene event that's taken place, a base station which allows the information to be downloaded through the iCloud onto a database and ultimately brought back to the user through some form of user interface. The COVID response has been to say, actually, to get this system up and running, we will leave the beacon and the individual staff feedback to one side. We'll come back to that, but we'll focus up on the pickup, the base station, and the display back to staff. And that's what we're currently evaluating in pathology at Alder Hey. It works very simply. It applies to all soap and gel dispensers. So whenever you use a soap or dispenser, that information goes through the base station and through the iCloud and gives you then counts of hand hygiene events on a hourly or by minute basis 24/7, and that information is then displayed back to the individual, or with COVID now, to the department to demonstrate where they currently stand, and then we put in targets, probably a 20% improvement target, to raise the bar to encourage staff to improve their hand hygiene performance. The design has to be smooth and simple, unobtrusive in the NHS. So this is an example of a sensor by a soap or gel dispenser. As you can see there, it can be applied to any manufacturer. It just sits below the dispenser. And the base station, again, simple, unobtrusive, in a busy clinical area. You don't want any large piece of kit. And then the key point is the feedback to staff. And this is a very rough and ready diagram looking at from time 0 to 10 in the evening, wash counts being picked up by the minute so that you can get an idea of the total numbers of wash counts per day. It also has, of course, some indirect consequences. So hotel services, the people who fill up those dispensers, at the moment it's just done manually. There's no artificial intelligence, but this sort of system will identify the hotspots in a clinical area. It will give you a better idea of strategically where those dispensers are being used most. It will help with stock management and maintaining information. And of course, it will give automated alerts when those dispensers are nearly empty. And an empty dispenser should be a never event in any hospital. And that is Hygiene. Thanks for listening.
Hello, my name's Roland Partridge. I'm a consultant paediatric and neonatal surgeon here in Alder Hey and a member of the Innovation team. I'm going to talk to you just now about this mask, something that on the face of it, no pun intended, is a very simple product, but it's actually taken a huge amount of effort to get from concept to application. The story's really got three elements. Firstly, how we developed the product. Secondly, how we rolled it out within our hospital. And thirdly, how we have expanded the reach of this product to the wider public at large, and in return are bringing in some financial benefit back to the innovation department. So it started when in May we realised that face masks were going to become a very important part of the battle against this pandemic, and I cut up an old t-shirt, had some straps made of string held together by staples, evolved that through a number of different design styles, using different materials, even a Gore-Tex based one, which actually worked surprisingly well, but wasn't quite breathable enough. And then found an industrial partner to work with. And this is probably lesson one of the design process. Is my ethos has always been to engineer a product, to design it for manufacture. Simply designing a product on a piece of paper can look very nice, but unless you understand how that's going to be manufactured and the complexities of producing it, that product may fail. So design for manufacture, working with the factory that's going to ultimately end up producing, or at least has the capacity to potentially end up producing your product, is hugely important. And that's what we did with this. So I took my designs to a factory that we found nearby who manufacture cotton. They have a significant experience in the cutting and the stitching and the dyeing of cotton materials. And with them, rapidly prototyped and hundreds of iterations with minor changes over a very intense couple of week period. I would meet with them every day. They would give me 4 or 5 new product prototypes. I would test them, get feedback from colleagues, meet with them in the evening. They would feed their feedback back to the factory. In the following morning, they'd start working on updated versions. And through that very intense period of rapidly turning over hundreds of prototypes, making tiny little design changes each time, we've come up with a product which is being very well received. It's got really 3 key design elements. Firstly, there's a nice flat aluminium nose bridge that is very malleable, sits onto the nose very well, and if you're wearing glasses, when you exhale it doesn't mist up. It's got a nice channel around the side in which the elastic runs, which means it fits very closely against the cheek. And thirdly, it's made from a really high quality, ethically sourced, washable 400 thread count cotton. So the product, through a process of design for manufacture and rapidly prototyping, has become brilliant. The second part of the story is how we rolled it out to the hospital. Our original driver was that we wanted to provide face coverings for all staff and visitors within our hospital. And that actually became a huge logistical challenge in terms of providing enough masks at the right time, in the right place, ensuring that stocks were maintained, managing the flow of that, ensuring that the factory could supply enough at a sufficient rate to mean that we didn't have people going without. And that became, over about 3 or 4 weeks, a very, very significant management task. And the third part of the story is how we realised that it's a good product, it's fulfilling a significant need for us within the hospital, but there's great potential for this to benefit wider society and the public at large. Initially, we worked with a few retailers who carried the product on their site alongside other products, and we very quickly realised that actually that probably wasn't the best strategy. What we really wanted and needed was a lightning conductor site, a website that was just selling these masks. And through a number of channels, we have developed that, and we now have what's called brilliantmasks.co.uk, which is that lightning conductor for this product. It just sells this product. It's collaboration between a number of different parties, and it provides the product in a number of different designs and styles, and it's focused solely on getting this product out there. It's been very well received. I think we're at about 82% 5-star rating on Trustpilot at the minute, and we've been able to market it very energetically through social media channels. Have been particularly successful at spreading the word, and it's something that we're really very proud of. The estimates are that it's probably secured about 26 jobs in the manufacturing process and supply chain. We're selling currently around 30,000 a month, all being manufactured in the UK. And that has brought back in a significant number, in the multiple thousands of pounds per month, back into the Alder Hey Innovation Department to help drive innovation in the future. So I hope that's been an interesting summary of this development of a product, right, through rapid prototyping and working with industry, the logistics of ensuring that it fulfills the need within your hospital, and then expanding that to be able to help society at large, and at the same time bring return back to help drive innovation in the future. Thank you for listening.
Hello, I'm Rachel Harwood. I'm a paediatric surgical registrar at Alder Hey Hospital, and I'm also a research fellow. I'm going to be talking to you today about some of the work that we did around PPE during the beginning of the COVID-19 pandemic. As I think we're all probably aware, there was a real need for PPE, especially during the beginning of the COVID-19 pandemic. And there were multiple news articles about how this was a really critical problem, particularly in hospitals, where people were stockpiling PPE, where there wasn't enough for people in hospital. And so we wanted to think of a way to address this and find solutions for it. And there are really three approaches that we thought of. So we thought of alternative solutions for PPE. So for example, using different types of masks or different devices. We thought of ways that might be possible to reduce the amount of PPE that we were using. And we also wanted to look at ways that we may be able to reuse the PPE that we already had. The area that I focused on was the reuse of PPE. So first of all, we wanted to define the problem. We wanted to know how many masks are used every day, and the answer is it's very hard to find out, but hundreds in every hospital. They're used for every patient who had an aerosol generating procedures, and at the beginning of the pandemic, the list of procedures which were classified as aerosol generating were huge, and so a huge number of masks were being used. We also wanted to look which masks were most commonly used, and the pictures here are the ones that we most commonly used in Alder Hey Hospital. And particularly the mask at the bottom is the one that was most commonly used and the one that was most difficult to get hold of. And so that's one of the masks that we focused on particularly. We then wanted to consider the options of how we might be able to reuse them. And we needed options that were safe, that gave consistency of cleaning, that were easily available and were cost effective as well. Because these are all important aspects when we were considering how we could implement this properly. I put up a number of options there. We actually thought through a whole raft of things, but some of these seem very obviously not appropriate, and some of them were things that we considered and then ruled out, and some of them we went forward with. So autoclaving, applying heat treatment, was very clearly not an option. The masks are made out of plastic and it would have melted them and they would have deformed, so we didn't use that. A 7-day quarantine was considered quite a good way to be sure that COVID had disappeared off the mask, but we weren't just concerned about COVID. We also know that patients in hospital have other bugs around them, and so we wanted not only to be able to clean the mask from SARS-CoV-2, the virus that causes COVID-19, but also the other pathogens that were around. We considered ethylene oxide, which is a gas treatment, but this is actually noxious when you breathe it in, and whilst after cleaning it should have dispersed, we didn't want to run the risk of exposing staff to potential noxious agents, so that was ruled out pretty quickly as well. And that left us with hydrogen peroxide, which is really commonly used to clean in lots of locations, and particularly in animal units where they clean food and bedding and things like that, so we know it's very safe. We considered ultraviolet irradiation, which again can very safely be applied, and plasma, which is an up-and-coming technology. That's a really interesting area, but it's not available in enough quantities to have been able to address the problem in the way that we wanted to. So we looked at hydrogen peroxide and UV irradiation. With UV irradiation, we actually thought about how that may affect the chemical properties of the mask, and so we did less work around that, and I'm going to focus from here on in about the hydrogen peroxide treatment that we looked at. So we then wanted to think, well, what are the really important aspects of cleaning a mask that we need to look at? And these are the four main areas that we thought of. So we wanted to see, did we see any structural changes within the microstructure of the mask, because it has really important filtering properties. And that affects the way that the mask effectively filters and protects the healthcare worker from breathing in viruses. We wanted to think about chemical changes, because not only is it the filtering mechanism of the mask that provides protection, but the chemical properties of the polypropylene, which the mask is made of, mean that provides additional protection, particularly because it has a charge associated with it, so the virus becomes attracted to those charged particles and can't pass through the mask. We then wanted to think about some of the macrostructural changes. So I'm sure many of you have seen masks, but they have elastic bands around the back, and we wanted to see whether they would be affected by the cleaning. And really, most importantly, we then wanted to see how they were fit tested. So did they still fit, and were they still effective after they'd been cleaned and worn? I'm not going to talk you through the details because there's a lot of data behind this, but you can see here some really nice scanning electron microscopy images which look at the filtering layers of the mask, and we find that masks are made of different layers. And we can see the picture A shows an unclean mask. It's got really smooth fibres, there are no real deposits on there. Whereas on picture B, we can see that there are little depositions between the fibres, that the junctions are less clearly visible, and we can see deposits if we really zoom in. And so we do see some microstructural changes as a result of the cleaning process. I mentioned that the fit test is the most important aspect of this, and you can see here that we looked at fit tested masks in 2 groups. So we looked at 12 masks in total. 6 of them had actually been worn previously, and then 6 of them had been put through 3 cycles of hydrogen peroxide. We actually find that both groups don't fit very well after they've been treated. So the masks that had been worn previously, 3 of them passed the fit test and 3 of them failed a fit test. We also looked at the way that they've been stored to see if that makes a difference, and it doesn't seem to. But this really shows that having worn a mask just affects the way that it acts as a mask for the future, with or without cleaning it. When we look at the masks that had gone through cleaning cycles, we also see that 60% of them failed their subsequent fit test. So this, in combination with the finds that we had around microstructural changes, the chemical changes that we did find as well, and some changes with regards to the elastic bands, have meant that we haven't felt that we were able to go forward with reuse of PPE. And so at this point we made a stop decision to stop looking into reuse of PPE in this way, and the other solutions have become much more important. So we're now using alternatives for masks. We use hoods, we have reusable respirators which are intended to be reused, and we're significantly reducing the amount of PPE that we're using. The number of aerosol generating procedures that are classed as high risk have been massively reduced now that we know more about the disease and how it's spread. And we're much more able to stratify the risks that patients give to us through the testing methods that we have now. And so whilst it's been a really valuable area to look at, and it's a shame that we haven't been able to go forward with it, we feel very comfortable in the decision to put a stop to it at this point and explore the other solutions appropriately.
Oh, hi, I'm Ian Hennessy, one of the directors of Innovation here, and I'm going to be chatting to you about our distancer. Now, first of all, I'm going to talk about the problem. Now, the problem was, at the start of COVID, was contact spread. We were worried about people coughing on their hands, contaminating surfaces. How could you avoid touching door handles when you're in the hospital? Now, the genesis of the idea has actually been in the making for a while, because months and months before COVID broke out, we'd actually been experimenting with our partner 3D Life Prints on this copper-infused 3D printing material, which was antiviral. And there was a competition about how would you reduce spread of infection in the space station, because the space station, believe it or not, has got a real problem with bacteria. They love growing up there. And I came up with an idea of, what if you could carry around your own door handle, or if you use your own personal door handle, which would fit over the pressure doors in the space station, and you'd be able to therefore only ever touch one handle to reduce spread. But it was a children's competition, so I thought I probably shouldn't enter it myself. And parked that idea, but when COVID broke out, we had this problem. Don't touch door handles. The expression was, the door handles are lava, and I'd find myself, I'd be trying to grab a door in an unusual place, thinking, oh, people have touched that bit less. So the concept went like this. We thought, right, what do you carry around with you a lot that could be used? And we thought, what about your ID badge? What if you could use your ID badge to open the doors? So we started thinking with our 3D print partners, we drew a few sketches out, and we thought, what if you could attach like a hook and a push plate to your ID badge? So here's a picture here of one of the prototypes of it, of the distancer, which is just an ID badge which was attached, just I've got here on my hip. So you've got an ID badge there, you've got a hook on it, you can open the doors and you can push them open and you can beep your way through the contact ID, and then it just sits at your hip there. So you're only ever touching this part of the handle. So this is one of our nurses modelling one of the prototype versions there. Now this process was quite involved. We didn't just make this. The very first one was enormous, actually. So it's up on the shelf over there. Had a huge hook in it. The hook was too big. The hook kept on breaking off. And then we made out the wrong type of material. It was too brittle and too fragile. And then we found actually it's better to put the hook on the other side. And then we made the handle slightly smaller, and then we started experimenting with different types of material. We eventually figured out that 3D printing wasn't the best way to do it, and we came up with an injection molding technique. And I love it. In fact, I'll show you a video of how the injection molder. This is where you inject kind of hot plastic into a pre-made mold, and it can create them at an incredible pace, really knock them out. So we had this idea. We'd gone through lots of iterative designs using initially rapidly created 3D printed prototypes, and then eventually moving to an injection molding technique. Now, the next thing was, well, one, how do we get into everyone's hands? So we made 4,000 of them using the injection molding technique and started distributing it to all of our staff. And I've got a picture actually of our reporters and everyone else when they started to get their own ones. And then we thought, can we sell them? Can we commercialise this? And the answer is yes, because people were desperate for this type of thing. And we started selling it to KPMG, we started selling it to other people who had big office buildings, so that they could have a bit more security around getting into their building. And we even started creating these videos just to try and demonstrate how, using UV light, you could reduce contamination using the distancer, and that was an important part of the commercialization strategy. We even got into how do you do specific type of targeted social media ads. We got it onto Amazon, which is incredibly difficult. All the legwork for this was done by our partners, Life Prints. And it was great to see it out there, getting sold, bringing resource back to the hospital. Great partnership with a company. We even patented it. We put an application for a patent in, 50-50 with 3D Life Prints. And it was amazing to think that from idea to commercialization and IP protection, that was all done in a 3-month period. And it just goes to show that you can actually do this thing quickly if you really put your mind to it. So again, happy to answer anything in the chat about a distancer, about where it's gone and any questions that you might have.
Hi, welcome to today's talk. We're going to be looking at how we developed a teleneonatology program in response to our COVID-19 pandemic. We're also going to describe how we managed to do that in 4 weeks. The challenge was a big one. Our neonatology consultants were struggling. The size of the challenge was not insignificant. They normally run at a low level of consultant staff sickness and cover both work at the Liverpool Women's Hospital and at Alder Hey. However, just prior to lockdown, they had 3 of their consultants off on long-term leave, and as soon as lockdown hit, this quickly increased to 7 out of 14 of their consultants either off with sickness, isolating due to COVID, or shielding for protection. This equated roughly to a loss of 40% of clinical facing time, and the real bottom line here was the service wasn't sustainable as it was. They were going to have to cut back on what they could offer, and that was not something they really wanted to do. So that was a big challenge. If we take a small backward step, we can see that the neonatology team were already embarking in conjunction with the neonatal surgical team on a journey on how they would build neonatal services for the future. And as part of this work, they held a virtual care symposium on the 2nd of March, and presenting at this was Dr. Jennifer Fine, a neonatologist from the Mayo Clinic, describing how she used telehealth to support the care of neonates across her state and how they improved outcomes, and was really showcasing that to us. And it really resonated with all of our staff and left everybody buzzing with ideas. However, this work towards the neonatal unit has been years in the making, and it'll be a few years yet. But in the background, COVID was starting to really ramp up in the UK. After the presentation on the 2nd, on the 5th of March, the first death from COVID was announced in the UK. Very quickly this sharpened people's minds, and essentially Chris Dewhurst said, we need to get this. So we started working that up, and as time progressed, COVID started evolving. By the 12th of March there was 590 cases in the UK, and already by the 18th of March the government made an announcement that all schools would be closing. So in that short time we looked at what we needed. We saw our staffing challenges coming, and basically looked at the challenges, looked at the needs, and said we need to get this in, so let's start testing and training. We located some equipment, and essentially by the 27th March we had our first telemedicine robot installed and working in the Women's Hospital. Now interestingly, on the 23rd of March lockdown began. So from having a bit of an inkling of what was coming at the beginning of March, by the end of the month we had got the project in with some loan equipment, got most of the staff trained and developed by the end of the month. Throughout the April we continued our training, and by the end of that month we had got all of our neonatal surgeons and neonatologists trained in using the equipment. Use of the equipment increased and increased. Very quickly it became apparent that we needed better equipment. Our clinicians said, this is great, but we need more. So very quickly we identified that and ordered ourselves some new equipment. By the 1st of June we had 4 new devices arrive, and as our journey progressed, by August 2020 we were delivering about 130 consultations a month. So very quickly, from nothing in March to high usage in August, it really saved our bacon. So who did this? Well, the team involved are really the reason why this managed to happen so quickly and at such pace. I was the project lead, ably supported by our IT wizard, Layla, and I think one of the key components of the success of this project was the strong clinical direction, and that was really championed on the women's side by Fawzia Pays and Chris Dewhurst, and on Alder Hey's side by Joe Minford, the clinical director for neonatal surgery. But this cascaded out. The IT team, both at the Liverpool Women's and the Alder Hey sites, were integral in getting this up and running, and everybody just worked together The standout difference in this project is there were no blockers that anybody wasn't tackling hard, and those blockers disappeared fast. The paediatric and neonatal surgeons jumped on board really quickly, and the nursing staff on both sides just engaged so quickly in something that was so different. All of the staff were clinicians. They look after babies. What they are not is IT wizards, and they hold their hands up and say we're not. But despite that, they engaged the topic with gusto and really ran with it. All the while, in the background, we were getting really good support from our colleague, Dr. Jennifer Fine in the Mayo Clinic, and the delivery teams and the company at InTouch and Teladoc were great. So this is where we started. This is with our loaner equipment. And in the bottom picture, you can see why Dr. Yoxall was called Bill on a Stick. He was at home shielding, I believe, and was up until recently was our #1 user of the telehealth services, delivering neonatal rounding at the surgical site. And you can see here one of our ANNP nurse consultants and a member of the surgical team going on the ward round with them. In the top picture, you can see Ms. Minford delivering a very, very modern consultation. She's there with the dad of the baby in the neonatal unit of the Women's Hospital, assessing this surgical baby, but mum also joined in with FaceTime. So it was really was a true full family affair, and this was all done on equipment loaned. The clinical impact was significant. We were able to deliver services that would have otherwise just have had to been reduced, relocated. On Alder Hey site, we were able to deliver daily neonatal ward rounds, urgent ad hoc advice, and also had the capacity to deliver a neonatologist within minutes' notice to any deterioration of a neonate. All the while, they were also available there to support any of the ANNPs on site in the clinical care of the surgical neonates. On the women's site, there was delivery of a regular surgical ward round of the babies identified by the neonatologists, and also ad hoc reviews. And even during that initial period, when there was significant concern about transport and transfer, and there was significant pressure on NWAS, the Northwest Ambulance Service, there was also virtual support for some interventions, and I know the surgeons were supporting the neonatologists to do minor procedures to prevent any delay or reliance on transport during that initial pressure. But very quickly we moved through that stage, got to the part where we needed new equipment, and then it arrived, and it was awesome. And what you can see in our next slide is an example of one of our neonatal surgeons reviewing the baby from home. So if I just play that for you.
Hello, my name is Chan. I'm one of the surgical registrars. So I've been asked by the nurses to have a look at your baby, and I've brought along a robot consultant. So if you don't mind, I'll bring the robot in, and it's Mr. Hennessy. He's the surgical consultant. Is that alright? So this is Mr. Hennessy.
Hi there. Hiya, hello. And then we can answer any questions that you have. I'm just gonna look at the observations here. Okay, so that's observations which are looking good. And I'm going to look down at the tummy.
He's handling quite well, Mr. Hennessy.
Yeah, it looks very good actually. So looking at him just generally from the end of the bed, it looks good. And the examination's looking very settled as well. Good. The dressing looks intact, nothing else going on. Well, I'm happy there. I'm happy. So just to reassure you there, I think that tummy's looking nice and non-distended, and I think we'll just carry on with the plan just as we are.
Yeah, thank you.
Do you have any questions or anything to ask?
No, we're happy with the offer.
And there we have it. A nice little consultation video. You could see in that the level of detail you could see, and whilst in telehealth you can't lay hands on the baby, the surgeon could quite obviously see his registrar palpating the abdomen and could see the movements of the baby, all very clinically useful information. But we had to sense how we were going as we went along. And how we did that was twofold. First of all, our parent evaluation. All of our early feedback was very positive, and in some cases better than we were previously able to deliver, which was a surprise. All the parents felt that they could see and hear and ask questions of their consultant, and no parent left not knowing the plan for their baby. And this was a bit of a departure from the norm, because typically what happened was that the referring neonatologist examined the baby and then left and phoned the surgeon and had a clinician to clinician referral discussion. What changed with this service was that that discussion became part of the consultation, and the parent and the family were part of that discussion. And despite PPE, you didn't need to wear it on telehealth, so that the parent could see the face of the surgeon that they were talking to. And despite all of the challenges with everything going on, no parent was dissatisfied with the quality of service received, and everybody got how important it was during a pandemic. So the parents really saw the value in it, which is great. The other half of the coin is the staff evaluation, and there was obvious anticipation, and I've alluded to it previously. A significant proportion of the staff are long-serving NHS veterans and generally rate themselves somewhere as below average or poor with IT skills. Yet despite all this, 90% of them saw value in using this, and 94% identified that they were going to support the system in the future. And they've also identified that this will become part of the new normal in the future as well. And they also identified that they could speak at length with parents in a way that they hadn't been able to do before, and that this had a lot of value, especially in the realms of consent and understanding of the clinical situation for the parents. And generally, despite their initial reluctance and nervousness about the technology, really took hold of it. Staff feedback, these are direct quotes supplied by the teams involved. They rapidly identified that we could benefit much more if it wasn't just the neonatal surgeons, but our other speciality and tertiary colleagues could really help, really bring the decisions around the care to the bedside, regardless of the geography. We have to be open and frank about it. There are some things that you can't do in telehealth that you need to do in real life. Sometimes there still needs to be that face-to-face and physical interaction. And one of the disadvantages was it's much better than I expected it. And again, there's this feeling for the need for a physical connection with the patient, and I don't think we'll ever get over that. I think that's an essential part of the examination of a child, but it's good that despite this disadvantage, it was identified that it would help them target when that was most needed. So that's where we got through, and now that it's in use and being used regularly, we're looking to see where else we can adopt this to help us get us through wave 2. And our eyes are now on paediatric high dependency care in the region. So the consultant presence on the ward isn't 24 hours. So what we're proposing using the devices for is to support our high dependency consultants and critical care consultants coming into our high dependency unit at any time of the day or night to support a deteriorating child, to review children that are admitted out of hours, to make sure that a senior decision is made at the outset, and also to potentially build in a little bit of staffing resilience. If there is a consultant that is isolating, they can dial in and really support their colleagues. And what the telehealth device allowed them to do was contribute to the team effort that was getting people through this huge demand on healthcare. And as you can see there, they identified being part of nighttime huddles, supporting deteriorating children, even outside of HDU if the need was there, and also to use the device to potentially shield other members of staff. So that's sort of our use cases for HDU in the future. But we're exploring lots of other use cases and using it to prioritise staff groups, to look at which teams are vulnerable, how we can protect them, use teleshielding to protect them, and lastly, how we can take this learning and share it regionally. And we're just in the process of starting up a pilot with one of our referring sites on how we could use this technology to support the care of deteriorating children across the region, and also to support one of our rail drivers, which we're calling InReach, the ability for not only Alder Hey to go to other hospitals, but for other hospitals to come in and support paediatricians from surrounding district general hospitals to be part of their child's care whilst they're not in their hospital, and then repatriating the child back to their local hospital and being part of that transition and being part of their care all of the time. Well, that's the end of today's talk. I do hope you enjoyed it, and if you have any questions, if you could just email simon.linford@alderhay.nhs.uk, I'd be happy to address them. Thank you.
Good morning, everybody. Thank you for the organizers of the Giant Health meeting. I think that is an amazing opportunity for us to show you what we're doing. I'm Rafael Guerrero. I'm a heart surgeon for children and adults, and then a center and a medical director of healthcare innovation at Alder Hey. And today I'm going to talk to you about immersive technology in healthcare. And this was kind of unleashed when all COVID-19 started, and COVID-19 around February or March started, and we needed to find different ways of working. And we have, in the heart center, we operate probably about 400 to 500 little babies with very bad conditions every year. And we needed to carry on providing the service. So we were thinking in different ways to do it. And we were come across with HoloLens many years ago. Now we were coming together with new technologies of using augmented reality for that. And so I'm going to talk about the evolution from how to use it during COVID-19, how we develop our service, and how we protect the patients, and the use of the immersive technology. We have Alder Hey Heart Center it covers about 8 million people in the population in the northwest of England, the Isle of Man and North Wales. We cover all the babies and adults with malformation of the heart. We are born with malformation of the heart. So it's a big team, and we needed to have a very strategic, proactive plan when the COVID-19 pandemic arrived, because there was no chance for us to close, because half of our patients are newborns, and they needed immediate care as soon as they are born. So we needed to carry on with the service, and we needed to have a plan. And sometimes the best accelerator is a crisis. So in these moments, you probably have heard during the morning the amazing team of the innovation team of Alder Hey with so many incredible ideas of how to help to provide this and during the crisis. And we were part of that. And we have several goals of the P number, if you want to call it, of protection, which are described in that area. And in view that we were involved in developing immersive technology with the augmented reality with the HoloLens, we say, how can we use this during these times, and not just during the COVID-19 crisis, but beyond this? How can we adapt to do that? And as a background, and probably you have heard from all my colleagues before about how big is Alder Hey, how care for so many people around the country. And the challenge was we wanted to reduce, the number of people in the war rounds. We needed to keep the expertise available 24/7. We needed to share information, collaborate in time, and communicate remotely for that. And the solution to become is using HoloLens 2, which is a device which produces augmented reality, no virtual reality, or mixed reality, you want to call it. But the key change was the appearance of an application called Dynamic 365 Remote Assist. And this allowed the communications lacking probably 2 years ago. This was a game changer between a completely different device, in which was more with better visuals, better technology, and the use of remote assist, which allow you a hands-free communication, and using Microsoft Teams, which is available in our hospital and probably in most NHS hospitals, you could be able to communicate with each other very rapidly 24/7. You were able to visualize holograms in front of you, in which you show the X-rays, the CT scans. So in summary, we were able to use this one person visualizing the patients, and the rest of the people were remotely. And I'm going to show you some examples of how we've been using this technology. And how it works is a device required, it could be an iOS or Android remote device, and you can have Microsoft HoloLens number 1 or number 2. You can collaborate who just need a device and need a Teams license. Not necessarily a Teams license, but that will help. So this is is a package with Microsoft will help to develop this. But it was very rapidly put into place in the hospital. So let's go right to the actions, I think, because a part of that introduction, I think, is important for you to visualize exactly what we were. And this is just the beginning. We have developed more, even further from that. But this is a normal war round will take about 10 to 15 people, in between student doctors, student nurses, the senior doctors, etc. And in this case, one of our senior registrars was going to run the war round with the HoloLens, and the rest of the consultants were going to be remotely, either in their office or, and you can see that one of the colleagues was completely linked, which they will be in charge of the EPR. So they will be showing the EPR as holograms in front of him, so he will be able to have all the information in front of him, and at the same time be able to communicate with the patient. And in the bottom part, the screen, you can see that 2 or 3 consultants and 2 of my colleagues were in an office, and we were just following the war round from our computer, from our laptop, with the view of the HoloLens, with the EPR as a hologram floating in front of you. And this is just working, and we are in just open laptop, or could be a phone, and you can see exactly what he's doing in there. The other procedure is the other application is in clinical settings is, if we think about the 3 main applications that we are going to talk, is the clinical or direct medical application, is if you require in the middle of the night an expert advice, instead of them coming or being next to you, one for COVID, but in the future, at any time, quite often it's a phone call, describe the problem with the patients, then please send me the data of the images of the X-rays, then you discuss. It's it's not complicated, but that's the way that it is. With this, it's a complete revolution, because you are, as an expert, being far away, or essentially you are part of the solution there. So this is a patient who we are going to guide him to do about the HoloLens. So he's very briefly going to decide what to do, and so you can see the view of the echocardiogram with the heart beating, and the expert consultant is guiding him how to do it. So you have to turn the probe into the right side, to the left side, and to make a decision live, immediately, about what to do about these patients. And sometimes are life-saving decisions. So this completely changed the way that you communicate. And to be complicated for specialties, but if you apply this to being in the A&E department, and you need very rapidly the expertise of the neurosurgeon, at the same person assessing the patient, and everybody will join remotely in a team situation, all together, and a little MDT. So I think the potential is tremendous. I don't think that we are just scratching the surface, and I think that the more that people will use, they will find a lot more different ways to use it. So we actually did a little bit of a questionnaire, of a survey, because we really wanted to measure was that making a difference? Because one of the main challenges that you have when you implement technology or anything like that is change. So nobody likes changes, and I think that this is a change, a significant change, and I think that it's important to measure what it was. And we did a survey, and actually from people who have never seen the technology, that they found it useful. And I think that our challenge for the future will be not just for this type of technology in general, when we are doing these things, is how we maintain the change, how we can not convince, but how can involve the people to carry on with this. And that's because I think another, again, is a very complex baby in which have, as you can see, in intensive care, following a heart procedure. And we needed to make decisions that probably was around midnight about another operation is going to need it. And our colleague is using HoloLens, and he phoned me to make a decisions about this. And then you can see in the right-hand side, and I answer with my phone, and I can see the scan of the heart that he's performing at the same time. And then we can make a decision about what to do with the heart. And that's his view. I mean, this is not practice, or, we just decide, film it and see what happened. And I can see the monitor with the vital signs of the baby, and if we can see, obviously, the baby. But once again, the mid decisions between a group of clinicians without being there, and you can see exactly it's like you being there and being the eyes and the ears of the person who is actually in front of the patient. We try, because when we were in the pandemic, can we use it with PPE, and the truth, like, not just us, but other centers around the country have been trying, and it's more than possible. So the Wi-Fi and the communication is still the same. It doesn't affect anything like that. So you are able to use this with PPE, and the cleaning process is very simple. So I think that that's good news, because it means that you can. This is not going to stop. Whenever we have through one pandemic, might come the next one, or if we want to reduce infections around the country, we can still use this, and we don't need to be. You reduce significantly the number of people using PPE, which was a massive problem, a few months ago, because you just need one person in front of the patient. The rest of the people will be remotely, and the headset will take it out, and you just wipe it, and it's clean for the next person to use it. So I think that is terrific from that point of view, and it's portable, so you can walk from anywhere, from one part of the hospital to the next part of the hospital to an office, etc. So this is another example in which one of the things that we hope is how can we have a more accurate information from the patient. And this is why probably it's about precision medicine. It's about how can we have a bit, better imaging to make decisions. And in this case, we have the cath lab. Cath lab is like the catheter where they do catheter for the heart. And in this case, one of our colleagues is wearing the HoloLens, and is able to. We are going to do a procedure in which they are going to place a stent inside the heart, and we went outside in another room, and we can visualize in our laptop exactly what he can see. This is phenomenal, and this is just the beginning. We have so many ideas now on how we are going to develop this, from even using augmented reality with haptics to be as a part of training and simulation. And then the next is advanced visualization, and I think that one of the two left areas that we need to talk about is how can we visualize in a much better way the body, not necessarily the heart. In this case, we are using holograms, as you can see, floating in front of us when we are going to do the operation, and the aim is to overlay the hologram or the image on top of the heart, so we can make a much better assessment of the problem. So there is many advantages. So it will reduce the number of staff needed in the operating theater or even in the intensive care in the ward. It will lower the risk of infection, prevent disruption. It reduces the number of people in the ward rounds, as we have seen, and make it more efficient, because you are doing that rather than being distracted. Consultants or the clinicians can consult colleagues without waiting, for them to be available. So it could be any time. And many things in our specialty are time critical, and that does need to be done. And it's hands-free, so you can move around anywhere, in the hospital. You don't need to carry, push it, or anything like that. So I think there is potential, and I think that the more people that are involved, the better that will be developed. Normally the downsides, because we need to talk about these things, is in nursing is the face-to-face communications. Naturally, as humans, as doctors, and people working in healthcare, we like to be in communication with each other because genetically that's how we've been designed to be. But with immersives, obviously that doesn't happen. But the truth is that we probably need to think about it right. Most of our communication nowadays are by a screen, so it's rather than face-to-face, and this is in normal life. And I'm not justifying that, but it is something that we somehow have adapted to that. And finally, education and training. This can be used, I'm not going to put because this is from one of our other companies who is producing already videos already tools to learn and to do simulation, either anatomy in the left-hand side or a simulation of a patient having a heart attack. And that's phenomenal. So there is absolutely no, this can go for a long time. As you can see, we just place the holograms in the atrium in the hospitals, and people can walk around. The students can be at home and they follow that. And in the other side, they can see a patient, which is a hologram of a patient created to simulate a heart attack. So, and learning, as we always say, I think that I'm completely convinced that it have to be now anytime, anywhere. I don't think that the students or anybody want to be sitting in a room, maybe go for a coffee, but people are learning anytime, anywhere, and that's what is happening nowadays. Thank you very much, and I hope that you enjoy this, and we're happy to answer any questions.
Hi, my name is Ben Sainsbury, and I'm the CEO of Marion Surgical. And what we're going to show you today is a little bit about our existing simulator, and then I'm going to talk about our exciting collaboration that we have with Alder Hey that's in the works. So what you see here is my partner, Dr. Rajiv Singhal, who's a urologist at the Michael Garron Hospital in Toronto, and he's wearing a VR headset, and so he's fully immersed in the operating room, and he's got his hands on a real surgical tool that's attached to our proprietary haptics robots, and these robots are providing force feedback so that it actually feels like when he's making the puncture into the skin to go down to the kidney, that it actually feels like you're touching real tissue. So a lot of our R&D has been working with surgeons to get that realistic feel. So I'm going to let Rajiv talk about the clinical application of this tool, because he's much better at talking about that.
Essentially, I'm a surgeon. I've been a surgeon for many years, and I've really seen over that time a magnitude shift in how we train our patients, how we basically learn procedures, and how we get better. You need to, even our trainees today need that period and that experience of being in an operating room. But operating room resources are expensive. We have to be first and foremost mindful of patient safety. If we can create opportunities to allow our trainees to practice and develop some skill acquisition outside of the operating room, by the time they come into the operating room and work alongside of us, they'll be starting at a higher level. That makes sense. It's safer for patients. It's cost effective because we can shorten the time that we use in the operating room to teach, and I think these things are all very exciting. So the Marion Surgical platform, this immersible virtual reality platform, not only can we potentially simulate a whole variety of procedures to allow trainees to work themselves up to a certain skill point. You could actually even have someone like me take real images. So I'm in the operating room tomorrow, for example, and I could put up the CT scan of what I'm planning to do tomorrow, and what I would normally do is just a chart review in the office. And but wouldn't it be great if I actually have the ability to look at that man's or that woman's scan, upload it into the Marion surgical server, and essentially do a trial run and a practice run of that procedure. It's got to make us better surgeons, and ultimately I think that's much better for our patients. This idea of essentially being able to do tomorrow's case tonight or tomorrow's case the day before. So that's the real exciting piece, this idea of being able to rehearse surgical procedures in advance of actually doing them. And ultimately we're all looking for ways to improve our patient outcomes, to do it in a way that's as safe as we can make it for everybody involved. And obviously in an era where healthcare is increasingly expensive, and certainly surgical care is increasingly expensive. So I'm very excited about what we can do and where we can go with Marion Surgical.
We've expanded our team and we've opened up an office in Manchester, and we're very excited about this collaboration with the Alder Hey to add a cardiac procedure, so a children's heart procedure, to our simulator. A lot of the development that we have been working on for the PCNL simulator, especially the part where you are using a wire to navigate to the ureter, is applicable to cardiac procedures, and also the X-ray view and wire behaviors. And so while it's not going to be easy, we feel like we're not starting from scratch. We're basically adapting some of the things, some of the learnings from the PCNL over to the cardiac procedure. We think what Alder Hey is doing with innovation is remarkable, and we're happy to be along for the journey.
Hi, so my name's Darren Gates. I'm one of the paediatric intensive care doctors and clinical innovation consultants here in Alder Hey. And I wanted to tell you a bit about our work with digital assistants and chatbots. So back in 2016, we started a collaborative project with partners at the Science and Technology Foundation Council, Hartree Centre and IBM on utilising AI for patient benefit. The first problem that we arrived at was an interesting one, really. Coming to hospital can be intimidating, frightening or anxiety inducing, and that's true for the children and the parents that bring them. This picture is from a film called A Monster Calls, and it's often the experience that children have coming into hospital. The monster could be the disease or the procedures, the treatment or the environment that they're coming into. And there's some fascinating research about when we're scared, pain is heightened and memory is enhanced. Potentially phobias developed and the retention of information is impaired. A significant amount of anxiety is caused by unanswered questions that people have coming into hospital. Where do I go? Who will I see? What happens if I need a blood test? And what's involved in an anaesthetic? We saw that the ability to access answers to this information anytime, anywhere could be hugely beneficial in improving patients' experience and relieving anxiety. So we started on a project to build an engaging virtual assistant that would be accessible before they arrive at hospital, during their time here, and then after when they've gone home, to answer any particular questions that they had along that journey. A bit like a friend who's been there before and can tell you what to expect. So the benefits of this include facilitating appointments and understanding where people get stuck in the process, gaining insight into the questions that matter most to patients and providing answers to them along the journey. We also get stats around the frequently asked questions that they have put into the system and can then address any particular issues they have. We believe that this also empowers children to ask questions that they wouldn't usually feel comfortable doing and engages them in their care. Our first version, called Ask Ollie, launched in 2018 and was available through a custom-made patient experience app called Alder Play and later via our website. We invested time in making responses context-specific, so handling things like an aphora, that is a question where the preceding statement is needed for context, as you can see here with the question, will it hurt? We built a robust way to iteratively improve the system, so tracking questions and analysing confusion matrices and k-fold tests to assess the precision, the recall and F1 scores for our natural language processing model. And we're continually improving the logic within the system. In addition to this, we're able to track the performance of the system on a question-by-question basis and allocate tasks for improvement, such as improving the answer or adding a new response. Obviously, 2020 has been a particularly unusual year for all of us, and the way things flow in the hospital has changed. So we've had to adjust the assistant to respond to this. We recently launched version 2 of the system with an improved UI and adaptations for the rapidly changing COVID-19 pandemic, such as details on the visiting restrictions in the hospital and how parents and other visitors can attend. We've named this second version ARTI, as in Artificial Intelligence, and we've made it even more accessible on our website. We're continuing to expand it with new knowledge domains and features. A small patient impact study prior to the pandemic identified at the time that the tool was being underutilised. The link was rather buried in the website, and we've addressed that by making it more accessible to people. However, of those that engaged with it at that time, 100% felt it improved their experience. They felt there was good information provided and would like to see continued development and more content added. And they'd certainly recommend it to others attending the hospital. Through it, we've spotted multiple issues and bottlenecks in patient flow, such as finding specific clinics or car parking issues that has led to other improvements within the hospital. With our growing experience in building digital assistants in the past year, we've also applied it to the problem of staff information. So we built a digital assistant called Sally, Staff Advice and Link Information, to answer frequently asked questions ahead of contacting the support team. We've tried applying a more generative response in this version, searching a repository of documents to generate answers. This has had some mixed results, and it's not always surfaced the relevant information.
Sally was created as part of our rapid response at the start of the COVID-19. Our biggest challenge was being able to keep pace with the evolving advice as it was being delivered to us. Questions were also being submitted by staff that were outside of the limited scope of the assistant's depth of knowledge, which was also a challenge. We did look at how we would evaluate this against this hierarchy. We clearly created a stable platform, and it was easy for the users to use and interact through. And therefore we've been able to demonstrate that a digital assistant for staff use is useful to augment against other communication channels. So going forward in 2021, as a part of our future development, we will be collaborating with our staff advice and liaison service, you can see where we've got the name Sally from, to develop the scope and content and then relaunch it into the organisation.
However, we've learnt a great deal from this process and are looking at future adaptations that will enhance functionality on this and other projects. There are many potential features to enhance hospital digital assistants in the future, including voice interaction, integration with other services to support tasks, and further personalisation. And we believe that there will be a valuable part of future healthcare, both for patients and staff, to improve experience and enhance the delivery of care.
Hi everybody, my name is Kevin Woodward and I work for STFC as the Innovation Manager at the Hartree Centre, and today I'll be talking about the work that we've been doing with the Alder Hey Innovation team. So I'll explain briefly about STFC. So STFC are the Science and Technology Facilities Council, and we have large-scale national facilities and research and innovation campuses which are spread across the UK. Part of the mission is to develop advanced technologies and innovate to solve real-world challenges. And I work at one of the facilities which is called the Hartree Centre, which is based in Daresbury in the northwest. So the Hartree Centre is STFC's high-performance computing, data analytics and cognitive technology centre, and provides businesses with access to powerful technologies, facilities and scientific computing expertise. The main purpose is to apply the latest capabilities in computing technologies to industrial challenges, And like I say, we're based at Daresbury, which is in the northwest of England. And we're not too far away from Alder Hey Children's Hospital. So at the centre, we have some very impressive platforms and facilities. We have high-performance computing platforms, IBM data-centric platforms, access to IBM Watson, supercomputer, quantum learning machine, and some very impressive visual computing facilities. We also have some excellent people from all the science backgrounds, plus software developers, mathematicians, data scientists, technical architects. My role is within business and innovation development, and we work with inventors and innovators to realise the technology's potential via commercial and industrial application in the real world, particularly in the UK. So why are we working with Alder Hey? Well, a few years ago, in 2016, a collaboration between Alder Hey and the Hartree Centre was established with the aim of becoming the world's first cognitive hospital, applying cognitive computing to transform working practices and enhance patient experience. The aim is to enable clinical staff to spend less time on paperwork and more time with patients. During the relationship, Alder Hey have demonstrated that they are an ambitious industrial partner who recognise the potential and value of applying innovation, not only at their hospital, but also looking for wider application elsewhere in healthcare. So what are we doing with Alder Hey? Well, the main activity that our team has been involved in has been establishing the chatbot service, which was formerly known as Ask Ollie and is now called Artie. This involves the application of IBM Watson to answer patients and their families' questions to reduce anxiety prior to visiting the hospital. This results in less cancellations, better healthcare procedures via improved sentiment analysis, and more efficient use of clinicians' time. As a result of the COVID-19 crisis, the Hartree Centre were approached by Alder Hey to look into whether the chatbot could be repurposed to answer inquiries from staff regarding relevant information to the crisis. For example, working from home, regarding personal protective equipment, and also other information regarding staff well-being. STFC responded quickly to this request, and within weeks, a new chatbot was established known as Sally, Staff and Link Information. This proof of concept has proved to be valuable during the crisis and raised important technical questions regarding the logistics of keeping the chatbot up to date during a rapidly changing situation. We've been involved in several other activities with Alder Hey. One of the ones that I've been involved with is investigating the potential for commercial opportunities, looking at how we can potentially form a spin-out company or license to a third party the technologies that are involved in the chatbot. I'm also involved in an ongoing proof of concept where we're looking at rolling out the chatbots to a non-children's hospital, i.e. Warrington Hospital, in partnership with Alder Hey. We've looked at enhancement of the chatbots. For example, we've adapted it to increase remote working as a result of the COVID crisis to guide staff around remote services. And we're also looking into linking to other hospital information and management systems, and looking into how we can get more value from the chatbot text, particularly around staff issues and concerns. We're also investigating other potential healthcare use cases, for example, a mental health chatbot. We're also looking into further use of natural language processing to process textual reports from doctors to aid clinical coding. In summary, the relationship between the Hartree Centre and Alder Hey has been very beneficial. STFC Hartree Centre have the ability to develop exciting computing capabilities, but the real benefit comes from applying these in the real world and creating impact. The relationship with Alder Hey enables us not only to test out and develop the technical capabilities, but more importantly to create worthwhile impact in providing smarter and more effective healthcare to children. Thank you.
Hi, good morning everyone. My name is Ian Sinner. I'm a consultant, a respiratory paediatrician here in Alder Hey, and it's been a real pleasure to work with the innovation team on a project where we've been aiming to map health inequalities in children with asthma, and I'm very honoured to be able to share some of that with you in this brief talk today. So firstly, by way of background, asthma is the commonest chronic condition of childhood. It affects over 1 million children in the UK and over 350 million children worldwide. There's a real urgency and a real need to improve outcomes for children with asthma. They die more frequently than they should, and they're admitted to hospital more frequently than they should be. And one of the key problems that we've seen is that there's huge inequality around this. So looking around the United Kingdom, the map always looks the same. There are huge areas where there are quite high rates of hospitalisation and mortality, and other areas where things are much better, and the inequality between the two is rife. In Liverpool and in other parts of the northwest, the outcomes for children with asthma have typically been very poor. We've got high rates of hospital admission. And one of the reasons for this, one of the key reasons for this, is socioeconomic deprivation. So the healthier you are as a child and the better you are at accessing care and taking good care of yourself, the better your asthma will be. But a lot of children in socioeconomically deprived areas have got restricted opportunities to be healthy. So we need to start thinking a lot more creatively about how we use our health services around paediatric asthma. We need to start thinking how we can tailor what we do to empower children. And one of the things that we need to do is to focus our efforts and our attentions in areas that could be better. And part of that involves looking at the environment and looking at air pollution and other problems that can make asthma worse. Part of it involves making sure that we're linking well with primary care and with schools and with pharmacists in that area to make sure that we've got the health services set up exactly as they need to be for children. And part of it involves just making sure that we stick to guidelines of care and make sure that we're giving the best care possible. And that's what we were trying to do with this project. We were trying to map so that we could focus our inequalities. And we used routinely collected data to do our mapping. We've realised over the years, I think, that data is so important to drive high standards of care, and we haven't really used data the way that we could be using it and the way that other industries are using it. So we use routinely collected data from our business intelligence services here to identify postcodes where there were high levels of morbidity in children. And you can see on this map here how that looks. And so it was almost like hotspots of areas. And from that, we were able to start to identify key parameters that needed to be changed. For example, things that could be done in primary care, and we're starting to see patterns in things like air pollution and antenatal health and other public health issues. So this is where we're at with the process so far. We've needed a lot of input and a lot of hard work from various people, including people from the innovation team, particularly Holly, and people from the business intelligence team, particularly Kevin and Chris. And we found that once we set up the processes, it was much easier to roll. The difficulty comes with what happens next. As with all things in healthcare and certainly all things in innovation, the key thing is, well, so what? What are you going to do with this? And our next step really is to feed this into a process of identifying high-risk children in high-risk areas and thinking through data-driven strategies to ensure that they get the best quality of care. So the project is relatively early in its natural history, and we've identified that we can do this, and we're identifying trends to show that it can work. One of the other problems that we find, as well as identifying the so what, is identifying how do you actually prove the so what. What is the research strategy that you need around this? This won't last well, or this won't lend itself well to a randomized control trial. We need to think of more appropriate and responsive natural experiments to see how this goes. And that's really where we're moving to in the next field, is looking at doing that research to identify how well this works. But even though we're in our infancy with this project, as you'll see here, Holly has already won an award for this. This was a regional award for reducing health inequalities, and I think that goes to show that people are already starting to see the benefits of this approach.
Hi, I'm Kevin Bell. I'm Interim Associate Director of Data Insight and Automation at Alder Hey. I just want to talk you through how we've been utilising Power Platform here with the help of the innovation team. So, as you can imagine, like many organisations, COVID-19 was a huge catalyst for change for us. We were presented with a lot of new time-critical challenges, which gave us actually a lot of new opportunities for new approaches. We've been talking about using the Power Platform, Microsoft, for quite some time. We've been doing a few bits and pieces, but the opportunities that this gave us were immense, so we really jumped on it quickly. We started in rapid design and development, doing some apps within days, weeks, rather than months, and sort of more traditional development, and doing some real rapid deployment out into the organisation as well. The challenges were massive. We had a hospital essentially that were used to working in one location, pretty much, and they all of a sudden had to shift to remote working. So that was a big change. We had large data collections that were required for external reporting and internal reporting activities as well that we need to coordinate with staff members. So there was a lot of new challenges, which was really interesting. So one of the problems we obviously had to solve was how in the pandemic did we well, it was about 3,500 plus staff, and we want to make sure that they're well looked after. There was also the staff availability and planning for the organisation. Wants to give staff access to supportive tools and information for staff. Again, external reporting requirements, all of that had to be met. The journey into creating Team Track, our first real Power App, took us 124 versions released to get that live. Very quick iterative development, but we sort of moved from the early stages. The project was we tried Excel files to try and capture it calling around people before the working day to find out where they'd be, with huge teams doing that, all very, very labour intensive. So we quickly decided we needed to do something else, and we moved to do Team Track, and that's the Power App essentially that would allow us to get the individuals and staff members to record their availability for we normally ask for the next couple of weeks, offering the quick links through to staff help, chatbots, etc. So we built a lot of functionality into it very quickly. And the great thing about this was it brought us a framework to start working with. So we had started off with, we need to capture some data from a user in Power Apps to, well, let's now do a dashboard. So we did that, and we pushed the data from the Power Apps into the dashboard. We then decided we need to do notifications. So we introduced Power Automate into that to start sending notifications to both the member of staff and to the wellbeing team as well, to let them know that somebody had actually completed something in the app. And then we, as a bit of more of a bolt-on, we started putting chatbot links in as well. So it really became a one-stop shop for the staff. That was all deployed across multiple devices as well. We had to allow for mobile, tablet, desktop, etc. We also looked at embedding it in Teams as well, and that all works really well. So the next app that we did on scale was the flu app. It was real evolution. There's a lot of stuff we could reuse from Team Track because of the new framework we developed. Same problem, paper, Excel files, people calling around was the normal way of doing the flu campaign. and we move that to Power App again. Same principles, but we need to now collect consent from individuals. We have to book appointments, schedule appointments, and we did all this with the Power App, which was great, and it really has driven the compliance of the flu vaccination program to a real high level now. So we now have a number of solutions. The latest one being lateral flow testing, which has allowed us to start looking at things like QR scanning, taking photos of test results, etc. So doing lots of things we couldn't have done, and it's again spinning these out in weeks, really. So it's been fantastic for the Trust to start using the Power Platform.
Good morning, everyone. My name is Olufemi Olajide, and I'm the Senior Data Scientist for Alder Hey Hospital. Today, we'll be looking at the impact of data science within the healthcare. What impact data science has had on us in our trust. First of all, data science is, we can simply define it as the using data science or using data to solve problems. Considering the amount of data we have now, the amount of data we generate daily now, it's massive, and it's best to make sure that to ensure that we actually use this data productively for the benefits of our patients. And that's what we have been doing in Alder Hey, using all data that we have to be able to make the right decision, and such that our patients are properly managed. In a data science workflow, there are some things that need to be in place. First of all, you need to understand the business question. That's the first thing we do in Alder Hey. We try to sit down with the department or the project owner to try and understand what exactly they want to get out of this and see where we can support this service. So we need to get the right data, model the data, then communicate the results. If that result is something that is actually what the business owner is also looking into or considering, then we deploy and then monitor this data, ensure that it continues to work as into. Before we came up with the kind of project we can run, so we did like a process mapping of how our patients come into the trust. We know usually that what will usually happen is we probably provide them with an appointment, or they come in via our ED. So these both ways we actually model. So if you're looking at a patient coming that we have given an appointment, the possible things that can come up from there is that the probability of patients not taking up that appointment, not coming. So we looked at predicting our patients not being brought to hospitals. Then we looked at our outpatient daily attendance predictions. And then if our patients are coming from ED, then we have a model that actually predicts the daily attendance of ED. Then we have a model that helps us to track these ED attendances into serious or not serious cases. That's a decision tool that helps clinicians. It can be like a second opinion, when you're trying to understand, when a clinician is trying to say where is this patient best fit. And also a third one actually is the risk of being admitted from ED. Then from there, we also developed a model that helps us to determine how long our patients are going to stay in hospital. That helps with our modeling of bed, so we know how many beds we need. Some of the other projects that we are also looking into that I have not discussed, we've looked into medication errors. This is where we actually looked into our incident case reporting, and then because this is actually free text, and it is a rich data that prior to data science it cannot be evaluated. And because of the amount of text, we don't have the capacity for any human being to be stationed to do this. So developed models using the natural language processing, where we, through the incident reporting, and bring out themes, common themes that we can now discuss with clinicians where they can look into, and that has helped them to be able to address, if there are common themes, to make sure that things are put in place that to prevent medication errors. We have also developed a model that helps us to rescore our patients regarding development of hospital-acquired infections. So that has the potential of managing our patients properly, also reducing the amount of antimicrobials that we provide, making sure that the right people get the right kind of treatment. And also, finally, we are currently working on developing the length of stay our patients stay in hospital. Thank you very much for listening. I hope with this we will be able to encourage hospitals to take more of data science within your trust to be able to experience the good impact data science can have within hospitals. Thank you.
Hi, I'm Sharif Hosni, Innovation Consultant at Alder Hey. One of the projects I work on is Alder Play. Alder Play is Alder Hey's patient experience platform funded by Alder Hey Children's Charity. It's been successfully deployed within the Trust since October 2018. The purpose of the app was to give children and young people a digital tool to familiarise, distract and reward. Everything we do relating to Alder Play comes back to those three themes. We're continually iterating to make Alder Play fresh and relevant. One such iteration has been its transformation from a standalone native app to a versatile web platform, and this allows us to add, update and modify content onto Alder Play. Going to hospital can be an experience filled with anxieties and worries, particularly for children. Therefore, through Alder Play, we wanted to ensure that patients can familiarise themselves with the hospital environment and particular procedures that they may be having. Alder Play has an Explore section. This is where a range of the main areas of the hospital are shown in 360-degree images. And this allows patients to see what the area they're going to will look like, giving them more control and more knowledge on what they can expect when preparing for their hospital visit. This has also been really useful for parents as well. Alder Play also has a Watch and Learn section, and this is where videos of particular procedures are hosted. These videos show patients explaining what it's like for them to have that particular procedure, such as a blood test or an X-ray. They talk openly about how long it takes, what they had to do, and it enables them to gain a degree of reassurance from patients who have experienced the same thing. One of the overriding objectives of Alder Play is to improve children's hospital experience by enabling staff to reward patients for bravery. They do so by providing them with something meaningful and special. To do this, Alder Play uses its unique Forever stickers. This enables patients to receive a sticker from a member of staff at a clinic, and then once scanned, these stickers are brought to life using augmented reality. And what's more, they can also be added to their bank of collected stickers to reward their courage. This is a form of gamification that's been really effective. Alder Play acts as a tool to make Alder Hey a positive and fun experience for patients. In addition to the rewards and familiarisation, distraction is also achieved through games and videos. Through our evaluations, we've found that Alder Play has had a hugely positive effect on the children and young people in reducing anxiety, and that this in turn has made procedures less stressful for them and more manageable for clinicians. Because of the autonomy that we have over the CMS of the system, the sky's the limit in terms of the content that can be included. We're really excited about the future of Alder Play and enhancing interactivity, gamification and personalisation, whilst ensuring that everything comes back to its guiding principles of familiarisation, distraction and reward.
Hi, my name is Chantel and I work as one of the UX UI designers within the design team at Mindwave. I'm going to take you through a very brief overview about who we are and what we've been working on with Alder Hey. So just some background on us. Mindwave was born out of the Biomedical Research Centre at the Maudsley. We design and develop digital products and services that have a positive impact on people, and we work with healthcare, academia, startups and charities. Fortress develop products that help organizations with the demands of data, with the focus being on efficient, simplicity, secure and intuitive. They have a good understanding of and relationship with trusts across the UK and other digital partners. So in this instance, they connected us with Alder Hey in the knowledge that we could provide an effective and efficient solution for the Alder Play platform. The project was handed to us with the aim to transform Alder Play into a new and improved accessible experience through the evolution of design and expansion on the original platform. And there were some goals specific, so building on existing content and characters, bringing them to life, making them more interactive and dynamic, so games, more videos, utilizing and improving on interactivity, so building on what's already been built and plugging in new interactive experiences, and expanding on all areas, so an extensive expansion that allows additional content to be put onto the platform by admin staff. So this is just a look at our approach based on the Design Council Double Diamond approach. It just begins with broad thinking, so a lot of research and empathy into understanding the broader context of the problem, the who, the what, the why, and then from that narrowing down and establishing and pinpointing exactly what it is we need to do to resolve the problem. And once we've established that, we broaden out again. So this involves a lot of ideation, a lot of prototyping and back and forth. We do this as much as possible so that from there we can further validate and narrow back down onto the specifics of what the best solution is. So Play Canvas is another digital partner involved in the project who are at the forefront of browser gaming technology. And they allow users to access platforms using browser-based interfaces, so without the need for downloading apps. And with this innovation, they've been integral to the expansion of the Alder Play platform and allowing it to be accessible by browser, which is really important because we want more children to have access to the platform, as many as possible. So this, alongside the Alder Play work, we have a wider vision working with Alder Hey and its digital front door. So this is a visual representation or metaphor encompassing all aspects of what the digital front door for Alder Hey looks like and how it could work. So just addressing all the functionalities that we would need to integrate, the development and design requirements and how they sit together. And having a shared innovative vision across the platform just also helps the wider team who will not all be as digitally focused understand the process and the aim. So just looking at what specifics we have achieved so far and what we are planning for the future. So I touched on accessibility. So the more accessible, the more people, the more children can engage and benefit from the platform. And moving it onto browser allows for that. More security, so there is now a sign up and login functionality on the platform. So that allows users to kind of set up, save accounts, save their progress, and just encourages them to use it more. And personalization, so another incentivization for users to use Alder Play. So custom skins, using nicknames, and just allowing a more personal experience. And the future. So we're currently working on chatbot, or incorporating a chatbot function. So allowing the user to interact, ask questions, and navigate around the platform better. Additional resources, so more specifically updating the learn section of the platform to watch and learn, and adding a lot more videos. And CMS functionality, so and also Hasbro content, so setting up secure video access of Hasbro content so that it works within the hospital Wi-Fi when a user scans an interactive sticker, for example. So yeah, we hope to continue working with innovative, future-thinking trusts like Alder Hey, and companies like Fortress, with whom we have a shared vision so we can improve the life of patients and service users.
Hi again. This is one of my pet projects that I really enjoyed during the code thing. Was around materials and material science. And we found lots of different things out while we were going through the thing. But one thing which was interesting was how copper, how COVID really doesn't like copper at all. Now, there are lots of different potential mechanisms for how copper can actually kill the virus, but it's been shown that the half-life of COVID on copper is something like 2 or 3 hours, compared to in some other surfaces up to 24 to 48 hours. Now, the thing I find fascinating is that we like to think this is fancy and new technology, but it's not. If you look back all the way through history, copper has been used as an antiviral, antimicrobial surface for thousands of years. If you just got to look at the old copper kettles, because people knew that if you had a copper kettle or you carried water around in a copper vessel, then your chances of getting a nasty bug were a lot less. So in the outbreak, there was this option of what if you could use copper on some of the materials and surfaces around the hospital to try and make it more virucidal. And what we found was that there was a local company who could create these nano coatings, so incredibly thin coatings of copper, which could be applied to almost any object. And we were really interested in thinking, right, okay, how can we get involved? How can we see if this new process, which for applying these really thin layers, could be used in a hospital? So we did some really early stage trials. And I can show you some of the things which we made. Now, one of the things that made me really sad about the whole COVID crisis was that we couldn't, normally we have toys out, but obviously we couldn't do it. So I thought, well, can we copper coat toys? So I'm just going to show you a quick video now of us copper coating this helicopter. Here we go. So okay, so this is a copper coated helicopter. So now it has completely antiviral surfaces all the way around. Also, you may have noticed a bit of a Star Wars theme. We did a copper coated Chewbacca. Now I don't know if you can see how Chewbacca looks a little bit metallic. Yeah, we kind of overdid it slightly on the copper Chewbacca. But amazingly, if you get the right formulation, it can be completely see-through. So these are just some PPE. So we're thinking, the trouble is like cleaning PPE all the time, really harsh chemicals. Could you make the surfaces a bit less conducive to viruses staying on them? So that's a copper coated set of goggles. I can even do it to fabrics. Now this is the Alder Hey mask, which there's another talk about, which we created. Now our Alder Hey mask is antiviral coated, not with copper though, but this one here is one of our experimental copper coated masks. So that stays antiviral and antibacterial as well. I did lots of things like touch screens and phones, tablets, because obviously these things apparently are dirtier than your toilet. And for those of you who listen to the distancer talk as well, we even blinged up one of the distancers, fully copper coated as well, and mine has a copper handle. But material science really is fascinating. You never really fully appreciate just the breadth of tech which is out there, which is built into the materials which we interact with every day. And the thing that my take home from this is that now material science is one of my key areas of focus. I'm going to write, okay, how can we make a surface, a material, the thing that our operative instruments are made of, how can we make it do its job better? It's not just about its form and its function and the cool digital tech which is built into it. It's kind of its actual very physical substance have an effect. So an example is that eyewear was very important at the start of COVID. We quickly found that these actually aren't completely clear. They're only about 73% clear, your standard polycarbonate set of glasses. And we did lots of looking around, and then it's clear is a very subjective term. So look at these. So this is clear. So for PPE eyewear, and you see the difference between this and this. I can tell you, you can notice the difference when you're operating. So material science, one of my take homes from the COVID crisis is we should be questioning what the environment is made from, what our kit's made from, and it's definitely for me going to be an area of exploration.
Hello, my name's Roland Partridge. I'm a consultant paediatric and neonatal surgeon and a member of the innovation team here in Alder Hey. Now this talk's going to be a little bit different in that I'm going to gradually take what I'm wearing off, but don't worry, not all of it. It's a tale of 3 products and the 4 ways in which they've helped the hospital and the UK more widely. So as promised, I'm going to take that off because it is a little bit harder to hear when I'm wearing it. The journey started in late March when the hospital here, as most other places in the UK, had an acute shortage of PPE, including full face visors. I contacted a company that I'd worked with previously who I knew had plastic manufacturing capacity, and over the course of a week we developed a very simple, reusable, washable product. The original phone call was I think at 4 o'clock on the Monday, and by lunchtime on the Friday we had the first batch of 300 of these arrived, and ultimately the hospital has used 20,000 of these over the ensuing months. It was a really interesting process. At that time, companies, SMEs were incredibly keen to work with and for the NHS, and so this product was developed with no upfront costs or development fees. That was all absorbed by the SME. They were prepared to do this because they wanted to help out. It was interesting in that the cost of plastics at that time fluctuated hugely. This is made of PETG and polycarbonate, and the price of that in April compared to March was increased by a factor of about 5. But the company produced it at the cost that they'd initially quoted in late March. And so whilst Alder Hey, we have a focus here on really trying to get some degree of financial return for our intellectual property and effort. We didn't receive a financial benefit from this, monetary benefit, but what we did do is we had a product that was much needed at a challenging time at a static and stable cost with no upfront development fee. This led, though, to the next product, which is this hooded visor. Now, it's not really a hood as we've come to know them. It's a visor plus. It's a visor that gives a little bit more protection to the hair and the neck. Say if you're taking blood from a child who's coughing and sneezing, it provides you with just a little bit more protection than just a face visor. It's not a replacement for a hood, a formal hood with a venting system. You have to wear an FFP3 mask and things under this, but it does just give you that little bit extra protection. The other benefit of the time spent developing that hood was that it put us in touch with the clothing manufacturing capacity within the UK that led to this gown. And this gown is a really interesting sort of story of open book development between tens of different companies and institutions, a number of different universities and design houses around the UK, a number of different hospitals, a number of different factories. All have had some input into this gown. It's in the advanced stages of being readied by 2 UK manufacturers with the aim of providing a fully UK manufactured gown to help achieve the government's target of the vast majority of our PPE for the next few years being made on these shores. I mentioned earlier our drive in Alder Hey to receive return for intellectual property and design inputs to products. Now, this is a really interesting one in that because it's been done in such an open book manner with so many different people contributing, it's virtually impossible to actually track down every different department, every different university's individual contribution to this. But the aim is that the benefit may not be directly financial in return to us, but a wider benefit to society, to the United Kingdom, in terms of having quality product, securing supply chains, securing jobs, and maintaining our PPE independence for the next months and years going forwards. The fourth way in which this design process has benefited us was actually the face masks that you may have seen in my other talk earlier in the conference. It was our contact with clothing manufacturers through the hood and then the gown that led to our relationship with the industrial partner who ultimately ended up producing the face mask, the Brilliant Mask, which has been a great success. And that has yielded financial returns into Alder Hey. So I think my learning points from this would be stay hungry, keep pushing doors, start with something simple, be open, talk to people, accept people's help. My philosophy is you don't always have to have the clear end point, certainly not a clear financial end point when you start a project or start working collaboratively with industry, but you push doors, you see what happens, and sometimes you might start with a very simple piece of plastic that might evolve, you put in contact with material manufacturers who you then develop a gown with, and ultimately you might end up with something like the brilliantmasks.com that will provide a financial return for your institution. So I hope that's been an inspiring little whistle-top tour of that journey. Thank you for listening.
Hello, my name is Henry Pinchbeck, CEO of 3D Life Prints, and I'm going to give you a quick introduction to our company and also our special relationship with Alder Hey Children's Hospital. Now, 3D Life Prints is a medical 3D printing company, which means we design and manufacture patient-specific, custom-made medical devices. That would include anatomical models, which are simply a copy of a patient's anatomy, cutting guides, which are used by surgeons during surgery, and patient-specific implants. Now, 3D Life Prints was formed back in 2015, and actually we were a founding member of the Alder Hey Innovation Hub. So we very much followed the template that we set up at Alder Hey with the rest of our business. So what we do is we set up our facility within a hospital, which is exactly what we did at Alder Hey, where we have some staffing, some hardware and some software within that hospital. And that allows us to provide our services at something that we call the point of care. Back to one of my colleagues to tell you all about our relationship with Alder Hey and the work that we've done there. Thank you.
Hi, my name is Paul Roberts and I'm the Business Development and Project Manager for 3D Life Prints. Our embedded hub here at Alder Hey is actually our flagship hub, which we opened up in 2015. What began as a relationship with two surgeons who had a big interest in health tech innovation and 3D printing to help their cases has grown into us having a permanent residency here at the hospital's Innovation Centre. 5 years later, now in 2020, we're now supporting all kinds of surgeons and clinicians across the hospital from different fields. We work with Alder Hey because they're committed to applying health technology to improve patient outcomes and the entire healthcare system on a regular basis. There's a whole innovation team here committed to doing just that. Alder Hey want to stay among the best in the world when it comes to children's care, and we want to help them do that by supplying our 3D printing services. Here in the underground bunker, the Innovation Centre, or the back cave as some people call it, we've got our space to work on site. Our printers are here, and so is our biomedical engineer, more importantly, who is the real talent behind the devices we supply. Being here, we're immediately available to clinicians and surgeons as a result. Sometimes urgently available when complex or life-threatening cases come through, and they need that additional insight that 3D visualization and haptics can provide. Sometimes when they need certainty in surgery, we can also provide things like cutting and drilling guides. Being here also helps us support the more adventurous among the staff who want to explore new procedural techniques or research ideas. And in situations like the COVID pandemic, which has happened over the last year, we can look at easing new challenges that arise. For me, I'm passionate about getting this technology in front of as many people as we can, those who can benefit from it, the clinicians and surgeons, because then that knocks on to the patients who will really benefit, especially in some cases when what first seems impossible is opened up by what we can provide, whether that's through insights from visualization or through confidence in surgery from our guides.
Hi, my name's David Collins and I run 3D Lifeprints embedded 3D printing facility at Alder Hey Children's Hospital. Based in the hospital's innovation hub, our unique business model places engineers such as myself and 3D technologies on site to provide medical 3D printing services at the point of care. In doing so, we can find effective solutions to clinical problems by combining my background in engineering and science with the world-class medical expertise and knowledge of the hospital's clinicians and innovation team. Much of our work here is driven by needs in the medical and surgical care of children, and we aim to meet these needs by utilising 3D technologies to develop and manufacture on-site personalised medical devices, often in response to complex cases. These personalised medical devices take many forms, but often fall into 3 categories. These are patient-specific anatomical models, patient-specific surgical guides, and patient-specific implants, all of which use patient anatomy as their foundations. They aim to aid the pre-surgical planning process, help surgeons in theatre, and ultimately improve patient outcomes. To give you an example of how these different devices work, well, our patient-specific anatomical models, they act as visual aids for the surgeon so they can really understand the patient's complex condition, and by printing these in tissue-like materials, it also offers them the chance to simulate surgery prior to theatre. In addition, our patient-specific surgical guides and implants, well, they're designed to fit exactly on a patient's anatomy and also predefine the cutting and drilling vectors they're going to use in theatre. Through these personalised medical devices, we work across the full range of disciplines, including orthopaedics, cardiology, oncology, general surgery, and beyond. And we also use 3D printing here to create medical imaging phantoms and simulation models for medical research, education, and training. These models often detail normal or complex pathologies and really give medical professionals a chance to familiarise themselves with difficult conditions, procedures, or protocols. Many of our projects begin life here when clinicians approach us in our hub with challenges they're facing in their clinical practice. But by being on site and working alongside clinicians daily, we're also sometimes able to preempt and offer solutions to some of these challenges too. Either way, we aim to solve these challenges in a collaborative way using short iterative cycles and quick turnaround times, which can actually be really beneficial for urgent projects requiring a rapid response. And pleased to report there have been many positive outcomes for both surgeons and patients as a result of these collaborative efforts. The most rewarding part of my job is helping to empower clinicians do the things that they need to do and working with them to improve the lives of children in their care, the latter being something I'm very passionate about. 3D printing inherently lends itself to complexity, and as such is a really innovative space, and I'm privileged to be at the forefront of using this technology in Alder Hey Children's Hospital to improve paediatric care and outcomes. So that concludes our talk. Thank you very much for listening. If you do have any questions or you're interested in our work, then please feel free to reach out to myself or Paul, who are around for the rest of the day, or you can contact us using the information on the slide here. Thank you very much.
Right, so hi, my name is Ian Hennessy. I'm the Clinical Director of Innovation here and also one of the paediatric surgeons. And I'm going to be speaking to you about some of the work of the Rapid Prototyping Centre, which is the place that I'm standing in right now. But instead of talking to you about all of the amazing and cool things that we've done, I thought it would be better to talk about some of the failures and some of the things that didn't work, because that's the nature of innovation. It's not all about things working every single time. In fact, it's actually about the majority of our ideas not being rubbish, but maybe not being the right thing. Maybe they were addressing a problem that wasn't there, maybe they just don't work, maybe they're dangerous. So these are all things which you have to embrace as part of the innovative process. And this really got brought home to me, and my first ever innovation project was a complete disaster. It didn't work. And it was a shame because I had such high hopes for it. It was this project, and it was about putting these telehealth things in children's homes, and they'd be able to avoid going to their GP, they'd be able to communicate direct with the hospital. We would have all this sampling and testing done in the comfort of their own home. Great bits of technology, CE mark technology, we put it all out to them. And then it fell apart because it hadn't actually engaged all the stakeholders properly, and hadn't engaged the clinical teams properly, and they didn't want to use it. So even though the patients loved it, we had to withdraw the service. And I felt terrible because I just, although I thought it was a great solution, I hadn't thought it through properly. So I learned an awful lot from that failure, and I'm hoping that by talking through some of these failures, it will encourage you to learn from failures too. So this is the picture, of our rapid prototyping centre, taken at the height of COVID, when we were really knocking out quite a lot of prototypes. In fact, over the period we knocked out 32 prototypes, 8 of which actually got deployed, 3 of which got commercialised. They were the successes. I'm going to talk about the majority of the failures and things that were parked. So here's one of my favourites. There was one of the problems we were having was around FP3 face masks. How could we have filtered air coming to our face? And the problem with FP3 face masks was that you couldn't see your mouth move. So we were trying to come up with a clear solution, a way that you could see through the face masks, you could see people's faces that were talking, and it would make communication better. So I thought, what if you could connect a filtered air source, that's one of our Papper air supplies for the hoods that we used to have. What if I could just apply it directly to your face, and you could have a jet of fresh filtered air? And this is me after having knocked it together, in the lab testing it on our port count machine, which is how we test our FFP3 masks. Now, I'd had this brilliant idea that to get around the problem of when I took a deep breath in, of sucking unfiltered air around the edges of the masks, I would put this reservoir bag on. So they see that green thing. Put the reservoir bag on, and then when I take a deep breath in, it would add an extra bit of air, so it would stop me from entraining from the sides. However, what I was actually doing was pooling carbon dioxide, which meant, you can see I'm looking a bit giddy in that picture. I think that's because I was a little bit hypoxic. So, good thing that we didn't use that, and that got binned as being bad. And when I showed it to the anaesthetist, they were like, well, we probably could have told you that. But anyway, so that was an interesting failure of mine. Here's another one. This is me in one of the Papper air hoods. And one of the problems that we had was when you're in these air hoods, you can't hear very well because that thing's blasting air down the front. And we thought, right, okay, could we create some kind of throat mic setup? Could we have earphones so that I could speak to the persons in front of me and it would relay the sound waves? And then we thought, we can't have things in our ears all the time because you want to be able to hear. So we thought, right, shall we use these bone conduction earphones? And when we're in theatre, we'll have the bone conduction, and that will leave your ear open, and the sound will just get vibrated straight in through the hard bones inside of your head. And so we got a load of these, and we started testing them in a simulated setup, in a simulated theatre. And what it transpires is that Bluetooth has a lot of latency and lag in it because of the way that things get compressed. And then I've got another system which would theoretically have got rid of that latency and lag, but it didn't. And then what would happen is when my mouth would move, about maybe a second later, the sound would come through to the other person, so it was really off-putting and really distracting. So it got binned. I actually believe that someone has solved this. I've heard that there's a Formula 1 racing team that seems to have got a solution to this, so I'm looking forward to that. But we had to park this and bin it. Here's another one. I was getting really annoyed when I was operating because I was really thirsty and I couldn't take my FP3 mask off. So I tried to create a valve in the mask that would allow me to drink. So that's like a tube going through. The thing with this, though, is that actually you completely invalidate all the warranties, and there's no way you're going to get this past medical devices people. So we binned that. It was an interesting thought at the time, and it was quite fun, but never got used in real life. We thought about how we had a big problem with we couldn't measure kids anymore because they weren't coming to the hospital. So we thought, could we use some of the LiDAR that's built into some of the new tablets to measure their height? And we did this, and we did a really quick evaluation trial with members of staff, and it wasn't accurate enough. So we got rid of it. Killed it quick. That's the important thing. And I'm sure it will actually come of use in the future, but for a quick, fixed our problem, it didn't. So we did a very quick evaluate. We tried with our research guys and got rid of it. So that was good fun. Here's another one. This is actually a nuclear suit we got from the nuclear industry when we're trying to create isolation suits, and I thought, wouldn't it be great if I could get a tube and just have it coming in the back, and I could fire clean air into the suit itself rather than just the hood. Well, apart from the fact we got the medical devices regulation thing, is it caused the suit to blow up, so it was like a Michelin man walking around. So it just, that was really silly as well. This was another one, because at the start we were really convinced that we were going to be overrun with not having enough oxygen points. So we came up with this 3D printed, in partnership with 3D Life Prints, who are on site 3D printers, oxygen splitter. It's one of our respiratory team came up with it. So that for every oxygen point in the hospital, we could turn it into 3 oxygen points. Now, the thing that was really interesting about this is we did all of this. We actually got it through the fast track sign off for a medical device. So it was really good that we managed to get all that done. And then, and only then, really did we have a properly good discussion with our medical engineering department, who said we had 710 oxygen points in the hospital, which could be run at 400% of our maximum capacity of people that could be in the hospital. So this wasn't a problem at all. So someone else might want to use it, but it wasn't the best thing for us. So this is the thing. I've talked about a lot of failures there, and this is one which I actually thought was a failure. We created these thermomolded masks, so masks that could be made at an incredibly high rate. So we could make 90,000 of these per day. It was basically like an Easter egg type wrapping type thing. But when we rolled them out, people weren't really sure how to use them, so the uptake wasn't great, and we ended up just using the normal old-fashioned visors. But then what we found out, and I've only just found this out because I had actually parked this for a bit, what we found out was that the kids love this mask. It looks like a stormtrooper mask. So the kids are now, when they come in speech and language, this is the visor that they get given. So although initially I thought it was a failure and I had parked it, it actually turned out to be a win. So that was a nice little thing. So that's a little kind of walk through some of the failures that have happened over the past 8 or 9 months. You learn a lot from these things, but I think the key thing that I've learned over all this time is that failures are absolutely not a bad thing. Absolutely not a bad thing. In fact, if you're not having any failures, then you're not doing it right, and you should be having more failures than successes. And I've got more failures I could go through if we had more time for the talk, but it's just keep on throwing it out there. And one of the things I like about paediatrics, and I think why it's a good and fertile ground for innovation, is because we're used to looking a bit silly, because we'll monkey around for the kids, and we'll get on our knees, and we'll draw faces on them and stuff. So we're not as, maybe not as precious about making a mistake. And that's why I like working with children, because they've still got that mindset, and it's why I think they're natural innovators. So all I'm saying is celebrate your mistakes, learn from your mistakes, and view them just as part of the process. Thanks, I look forward to speaking and answering any questions you have on the chat. Hello, I'm Phil Jennings, the Chief Executive of the Innovation Agency. The Innovation Agency is part of the National AHSN network, and we're the innovation arm of the NHS. We help organisations to identify and adopt the best healthcare solutions, and we support innovators with great products. The innovators we support may be clinicians, businesses, charities or social enterprises. It's our role to make sure that the best innovations get the help and the support that they need, and for us to introduce them to health and care providers. At Alder Hey Children's Hospital, we've been involved in a range of different ways. In fact, most of our teams at the Innovation Agency have worked or are working with Alder Hey. They are a fantastically ambitious, innovative hospital trust, and we're always excited to be part of their strategy, helping to build a better future for children and young people using digital tech and innovations. Now, in our early days, we gave funding to 10 innovation hubs throughout the North West Coast region, and one of those was Alder Hey, which at the time was building its new hospital in the park. It's really gratifying now to visit the innovation hub at Alder Hey, which our funding helped to set up. It was originally nicknamed the Bat Cave, and you can still see the odd image of a bat there as a reminder of its humble beginnings in the basement of the hospital. We also part-funded the hospital's Institute in the Park, which is a great conference and learning centre. I myself worked at Alder Hey quite some time ago now. I was a junior doctor in the original hospital in the A&E department, so when I visit now, it's really breathtaking to see what Alder Hey has become. It's a real asset, not just for the city, but the region and indeed the country. And we at the Innovation Agency are very proud to be one of their partners. Our most recent involvement with Alder Hey has been to develop a system using an online portal which links NHS trusts with prospective commercial suppliers. This started at the outset of the pandemic when the team at the Innovation Agency offered to act as a contact point for suppliers on behalf of the region's trusts who were being bombarded with offers of support, largely around PPE, and they simply didn't have the capacity to respond and check out all the different offers. Our work led to a collaboration with Alder Hey and the Cheshire and Merseyside Healthcare Partnership to create a COVID-19 supply response team. This used Alder Hey's existing platform for innovations and collated and assessed all the offers, matching them to the needs of the trust. There are some brilliant entrepreneurs, clinicians and businesses working at Alder Hey on products which are absolutely transforming the lives of patients. We've been supporting some of these, whether that's through an initial introduction to the hospital or ongoing help with funding bids, evaluation, connections with the wider NHS and AHSN network, and the various schemes that exist within the NHS to help health innovators, such as the Clinical Entrepreneurs, the NHS Innovation Accelerator, and funds like SBRI Healthcare and Innovate UK. An example is 3D Life Prints, who print 3D anatomical models from scans, enabling teams to plan better for surgery. Later in this event, you'll be hearing from Alder Hey surgeon Joe Minford, who carried out an operation on a 6-year-old girl to remove what's described as the impossible tumour. That operation only happened because the surgical team had the benefit of examining a 3D tumour model. Without it, they didn't think there was any chance of success. It's very difficult to evaluate the benefits of creating 3D prints of body parts before surgery, which means it's hard for a company to present a compelling business case. It's the sort of barrier that often stops or slows down innovation, the request for evaluation and evidence, which, while it's good practice, can always not be that simple to achieve. It's our role at the Innovation Agency to help a company with a great product or service to overcome any barriers, and we've supported 3D Life Prints since they set up their base at the Innovation Hub. We introduced innovation leaders from other organisations to the company, when we organised a visit to the Innovation Hub from our community of Innovation Scouts. They met engineers who were producing the 3D models, and they heard about the difference they were making to both surgeons and patients. And that led directly to 3D printing expanding throughout Liverpool to the Heart and Chest Hospital and also to the Royal Hospital, with the help of a grant from ourselves, which was match funded by those hospitals. So finally, as anyone in the NHS will tell you, fantastic tech and digital innovation on its own can't improve healthcare. It's the people using it that will make the difference to patients. At Alder Hey, we know they have both the tech and the people to deliver fantastic care, and we are proud to be their partner.
I am one of the surgeons here at Alder Hey, and it's going to be my job to make sure that you do this operation well and safely. Now, being a surgeon is difficult. Being part of the operating team is difficult.
My name's David Powell and I'm the Development Director at Alder Hey, and I'm here to tell you a little bit about the development of the Innovation Hub, how we started the service and where we came from. So this goes back to early days in 2012. My job coming to Alder Hey was to develop the new hospital, and as part of that endeavour we were talking to lots of the staff and patients about what they wanted and what opportunity they saw with the new hospital. And as part of those conversations, Nick Barnes, one of the radiologists at Alder Hey, came to see us and said, well, he's had this idea with his daughter, Eve, about bringing a digital friend into Alder Hey and what the benefits of that might bring in terms of making children feel more comfortable in the environment and trying to reward children for compliance and fitting in with the system and the services as they came, etc. So that was the initial conversation, and with that we thought that was a really cool idea that we decided we would launch an innovation competition. So we launched a competition to find an innovation partner to work with Alder Hey to develop this idea from Nick and Neve, but also to look at what else we might do with the opportunity to innovate as we develop the new hospital. So that was, I suppose, an example of how Alder Hey works in a way, because it's this innovation system is a cultural thing which came about because Alder Hey has that inquisitive mind and is able to move quite fluidly, in my opinion, to think about new ideas. So with the backing of the board, we then launched a competition. We had a lot of interest. A lot of the big players came to work with us, and we showed them Nick's idea, and everyone got very interested in it. And we awarded a winner, which was BT, and they put some investment into the service. So they put some investment in to back it, and for a year or so we worked with BT developing the idea. What that allowed us to do was to create a team. So we created a team which started off with Ian Hennessy, one of the surgeons who became the clinical director of the service, and then we started to grow a small team around Ian. And with that small team, we then started to reach out and to explore who else was out there, what they might want to do with the opportunity to work with Alder Hey, and all kinds of people started coming to our door with ideas. So that was extremely interesting in its own right. We then started to develop it internally, so started to think about how we might grow it internally, and started to find some really interesting individuals in Alder Hey. So, for example, Rafa, one of the cardiac surgeons, I was chatting to him in the gym, and he had this great idea around use of sensor technology, and became involved, therefore, in the very early days of the creation of the hub. And what Rafa then did was put us on to Boston Kids, and so he had a colleague there who was able to talk to us about how they developed their service there. So a deputation from us went to talk to Boston Kids, and we were struck by how open their system was and how they were opening up their system to anyone who wanted to come in and develop an idea. So it was an open source system, not very rules based, so it had this idea of being able to stimulate creativity without too many barriers. And so we took that idea and started to work with that. The next happy circumstance was that in building the hospital, we were on our way to completion when walking around the hospital with the project director from the builder, Lang. We found this big empty space. He had a guy sawing wood next to the theatres, and I asked him what that was, and he said, well, it's leftover space. We were going to put plant in it, but it's no longer needed. So we had a conversation about whether or not we might be able to use it as an innovation hub. And so that was the first happy circumstance. And then the second one was the builder needed some help with us as the project started to come to completion. So we did a deal with the builder whereby they fitted it out to a basic industrial setting. So it had industrial aesthetic to it, but it was something that we quite like the idea of, something that had this idea, this feel of something new and industrial and sort of bothany. So we created the hub with the help of the builder, so that when we opened the hospital, we had this big space of 1,000 square metres, which we called the back cave, underneath the park, underneath the hospital, which we could then put the team into. And once we were up and running with the back cave and we had our home, we then started to build on some of the ideas we had earlier on. So we had, I remember, a Chinese meal with Nick and with Ian, where we were talking about how we were going to do it in Alder Hey, and we had this idea of fluidity, so something whereby we could go out into the organisation, harvest ideas, not have barriers, not say no. So this idea of not saying no, but to put things into the system whereby we could then find a way of getting those ideas pushed out into the world. So that was one idea. And then the second thing was we thought, well, talking to Rafa about what Boston did, is we needed to have the outside world come to us. So we needed a way of bringing the outside world to us so that we could then do things with the ideas. So we ran a hackathon, one of these hackathon enterprises, which I didn't know about. I didn't know what it was, but where we got loads of people from inside the hospital and loads of people from outside the hospital. We got it facilitated by Boston, and then we were able to put together ideas with people who were interested in the ideas to create sort of first stage inventions or potential inventions, and that brought this idea of can do and an opportunity. So it was very interesting doing that. We've run 4 of those now, actually, those big type events. We had help from the Innovation Agency, who were very helpful to us in the early days. They helped put some money in to fit out the back cave, but also to connect us up with partners and use their networks to help us piece together a network of ideas and participants. And so that started to build this this connectivity. And Ian, who was our clinical director, and Rafa had quite a lot of connections, a natural way of working whereby they'd be out and about, pulling in connections, pulling in companies, pulling in universities, people outside of interest. And so we were able to build quite quickly a network of ideas, opportunities. And what that meant is if a member of staff had an idea or a patient had an idea and they were presenting the idea, we had somewhere to place it, which is one of the most difficult things, I think, is trying to find somewhere where the idea could get placed. So we had this sort of system whereby ideas were being created and then were starting to be placed with partners in this open source system. And then the next stage of development was bringing in, we had Emma and Claire and Rachel and some of the guys from the organisation who had with a commercial or financial background or a more professional innovation background, coming in there to try and turn that what was a very loose opportunity and a loose idea into a system, so that then became systemised, and it was then taken on to the next level. So what the guys then have been doing has been taking that sort of very early fishing in the pond type idea into a big systemic endeavour whereby the innovation culture is being spread throughout Alder Hey and the organisation, but is also being spread out outside and into the wider world, with the idea being that the more partnerships you can develop, the more networks, the more individuals, the more people you can get to contribute, then obviously the thing grows. And it's trying to keep that sense of the original spirit, of that pioneering spirit when we started, of keeping it open and keeping it an opportunity, along with the idea of trying to systemise it so that ideas can be taken, looked at properly, resourced and investigated. So that's the sort of story of how we started and how we got into developing this innovation system, innovation culture, innovation and team at Alder Hey. Thanks very much.
Hi, I'm Emma Hughes. I'm the Deputy Director of Innovation. I'm going to talk to you today about a little bit about the history of Alder Hey, but also how we've progressed our innovation strategy. So, Alder Hey, as you know, is a globally renowned specialist children's hospital. It's inspired by children, and our plan is making it a better place, a healthier future for children and young people. We're world leading in cardiac, neurology and respiratory, and we've got a long history of world firsts. We are well known for our innovation and our research heritage. We've come from an old workhouse in 1914 to now having this iconic digital hospital. And again, innovation and research has been in the blood of Alder Hey, and now we have a dedicated innovation centre and research institute and treating over 300,000 patients per annum. I'd say our innovation activities started over 5 years ago within that innovation centre, and we've got a really well-established, lively and productive innovation centre and activities. We're engaged with staff, working on their problems and ideas, and working with the children and young people, securing that healthier future for them. One of the challenges about our innovation activities is the number of fantastic projects that we could be working on, and that's one of the things we needed to really look at prioritising. So we spent the last 6 months looking at our strategy, trying to understand how that fits to the trust priorities and ensuring that innovation becomes embedded as part of the trust strategy and within the divisions themselves. So one of the things we've been working on, as I said, is around what is our mission statement. What is the thing we wanted to achieve as an innovation centre within Alder Hey? So our innovation dream, today's child, tomorrow's healthier adult. Our dream is we dare to use innovation to achieve the dream by becoming the world's most advanced healthcare innovation system. We're going to do this by harnessing emerging technologies, ensuring that all our children and young people are safe, well, and grow up to be healthier adults. We want to have global impact, challenge the present as it is, and set the standards globally. So with that vision set, we wanted to look at how do we achieve that. We felt very strongly that our mission is to provide equitable access to Alder Hey care and expertise wherever our children and young people are located. We want to be co-located with the clinical services and our innovation team to be embedded with what's going on in the real world on the healthcare challenges. So we want to utilise emerging technologies, providing that synergistic healthcare innovation ecosystem, advancing safety, ensuring access to care to ensure that healthier future for children and young people. So utilising open innovation, working with industry partners and co-creating the best solutions. So we bring leading edge digital sensors, big data, AI, immersive health to enable that equitable access for our children and young people, but also expanding the reach in terms of education on future clinicians. We want to create a model of care that is scalable nationally and globally. So with our mission and vision in place, we really also need to look at operationally how we structure our innovation centre to grow from where it is today. As I said, we've got a number of activities ongoing, but to really build that innovation centre to reach those children on a global basis, we need to look at our operational structure. So recently we have now executive lead on the board for innovation. I'm the deputy running the day-to-day with the team, where we have our innovation consultants and commercial teams, as well as our AI and business intelligence group. And we also are very clinically led with our co-founders, clinical directors Ian Hennessy and Rafael Guerrero. As I said before, we've got a great innovation centre. We're an innovation hub was actually founded in 2014, and it's bedded in the hospital here. It's 1,000 square metres of co-create space. And what we bring together industry, academia and our staff to really co-create the solutions of the future. We've brought in a best-in-class kind of open innovation methodology and system. We've got a rapid prototyping centre. We're building our AI HQ and our user experience lab. And then we have a real multidisciplinary team of experts run clinical, nursing, research, as well as our commercial and innovation technology scouts. As I said, in addition to building those teams, it's really looking at what are the foundations for a long-term innovation strategy. And there's 4 things we believe are very important: a culture, the resources, having a process, and also being sustainable. So growing a culture, we have a very active engagement programme where we really show the benefits of innovating to our staff and children and young people, daring them to come up with the new ideas and to innovate. We're also looking at making sure that our innovation is embedded in the strategy of the trust, in the divisions and the departments, and most importantly, allowing our staff to truly innovate and co-create and be rewarded and incentivised to do so. Second element that's really important is ensuring you've got the right resources. It requires investment financially as well as in terms of people and skill sets. We have a multidisciplinary capability, as I mentioned earlier, and it's really important to have that diverse skill set within innovation department. And also the space. You need an innovative space for people to think creatively and co-create and come up with those new ideas and solutions. But also it's really important once you open those doors to innovation, you have a process where you can bring in those ideas from staff and children. And we've adopted an open innovation methodology where we are collecting the needs. We're very driven by the problems in the real world. We are looking at the challenges faced day to day and then matching those with those fantastic emerging technical solutions out there and co-creating with those industry partners. So we have a pipeline process where we work through, we validate those problems, we validate those solutions, and we wrap around that with the required intellectual property and legal paperwork that's needed. For us to continue and to grow this, we have to be sustainable. So we are very sharply commercially focused on many of these problems in terms of how we might take them also out to market. As I said, our focus is about the care and improving health for our children and young people. And that's our number one goal, it's impact to care. However, money isn't a dirty word. You know, for us to be sustainable, there's no reason why we shouldn't also make money, because the money we make on any of these innovations is fed back into the hospital. So we look at how we set up our partnerships and our co-creation approach with bear in mind the potential then for commercialisation and bringing much better value and return on investment for the hospital in terms of innovation. Another really important factor in that terms of being sustainable is growing our brand and having a real position nationally and internationally, and that's something we are very keen on developing further. Just to recap, innovation's here to stay in Alder Hey. We're building a really exciting, sustainable activity. We're setting the foundations over the last few years around creating that really daring to innovate culture, rewarding and incentivises our staff. We're driven on the real problems and solving those real problems they face every day. We've brought in multidisciplinary teams and finances and resources, and we've really got a robust process to be able to prioritise and filter the things we work on. And finally, to also then look at the commercial opportunities and create the business models around those opportunities. Thank you.
Hello, lovely to be here today to present on making innovation make sense to hospital executives. My name's Claire Liddy. I'm the Managing Director of Innovation at Alder Hey Children's Hospital over in Liverpool in the United Kingdom. In today's presentation, I'm going to take you through a few things from my personal perspective around how to make a world-class innovation centre work. First of all, I'm going to reflect on my journey and how it can feel a bit like a roller coaster. And then I'm going to take you through what I think are the secret ingredients to making a global innovation centre work. And then I'm going to wrap up and summarise, and happy to take any questions from the chat. So first of all, to introduce ourselves, we're a specialist children's hospital over in Liverpool. We were actually built and designed and inspired by children and young people, which makes us a wonderfully special place, and it's a place of true innovation. We've got lots of world firsts, and we've been leading the way with innovation for over 5 years now. We've got a really strong research heritage, but what I'm going to talk you through today is very much the journey we went on, which started over 6 years ago, to get us where we are right here, right now today. So here we are today, and we're really proud to be able to showcase and tell our story. We have an established, lively, productive and world-class innovation centre. However, to get to this point, it took us over 6 years, and it felt like a roller coaster to get there. When we very first started, the Innovation Centre was just a room in our old hospital in a Victorian building. But now we have a dedicated facility. It's over 1,000 metres squared, co-creation space, rapid prototyping, and a team of over 14 dedicated innovation consultants who help the hospital make innovation happen. We're really proud to be here today to tell you how it felt. And my big thing today is going to be to tell you how you get executives on board with making an innovation centre in a hospital. So moving on to the roller coaster, that's my analogy of how it felt. So I'm going to tell you a personal story actually. I've not been the Managing Director for Innovation for the whole of them 6 years. I actually started in a different carriage on that roller coaster. I used to be the Deputy Director of Finance at Alder Hey. So for 4 years of them 6 years, I was in a different carriage, and I certainly wasn't in with the innovation team. And back then, it felt really different. I was definitely oil, and the innovation team were definitely water, and the two didn't mix. So it felt really, really tricky, because we knew that strategically, Alder Hey wanted to be this global centre for innovation. It was on our strategic plan, it was in our board objectives, but actually trying to find that missing piece of the jigsaw puzzle was really difficult. Me sat there in finance with my calculator counting all them beans. I just couldn't quite figure out or fathom out why we should be investing in innovation. It didn't make sense to me at all. And for a while the Innovation Centre really felt a bit rogue. They felt like they were going off-piste. It felt like they were needing to beg, borrow and steal. And the board and the executive team and even the finance department started to get a bit impatient. So what happened on that roller coaster ride? We had the Innovation Centre core team, which was actually only 2 people when it started, but it had a really strong clinical lead who made sure that that roller coaster kept going, and they kept building the bridge and building them double dips as they went. So moving on then to how did we make it happen? How did we move away from feeling like we were on the roller coaster? I call it the secret ingredients. So what I'm going to talk you through now is the textbook answer to how you make innovation centres work. So in our opinion, there's 4 key ingredients to a successful innovation centre, And this isn't something that Alder Hey, has made. This is actually, what would be in a textbook. But for Alder Hey, actually, even though we knew all of this and we had that intelligence, our innovation centre was getting to a point where it hit almost a brick wall. It got to the best it could be, but it wasn't going to the next level. So what actually happened was, when I was sat in my finance department working on my month-end results, is the chief exec said to me, actually, what we'd really like to do, Claire, is for you to go in and to do a reset process to take innovation at Alder Hey to the next level. So when I did that, I wasn't sure, because as I say, I was really unsure actually whether I believed in and whether I had faith that innovation could really be successful in the NHS. But I did it, and the minute I started to work with the innovation team, my eyes were wide open. I was inspired, and from day one, I was absolutely caught in that innovation trap. And what I did during that reset process is really think in an Alder Hey way and in our way, something that was meaningful to us, how we were going to kind of enhance what we already had to take us to that level, to be the global innovation centre that we need. So the 4 things that we actually did, and it did actually in hindsight follow the rule book, but we didn't know it at the time, is we worked really hard on embedding innovation in the culture at Alder Hey. So I worked really hard as part of the executive team on linking our innovation strategy to be hand in hand, hand in glove, some people say, with our core hospital strategy. So it didn't feel like it was something going on the side of a desk or a third wheel. So that was a big piece about embedding and including innovation as part of the core. The second thing that I did with the help of my team is we really looked at what we needed in terms of key resources, key capabilities, and we had a strategy to expand the team. And we made the team really multidisciplinary with a real wide variety of skills. Any innovation centre needs a variety of skills and not just one particular skill set, and that's what we've done. And I'm really proud to stand here today that now we've got 14 members of the team who are great talent. The next thing we did was spent a long time actually moving away from a randomised approach to innovation, where it was whoever shouted loudest got the attention or got the money that we had, to putting in a process, and we put in a healthcare specific open innovation pipeline and process, which has been really, really successful, and we're still using that today. The final thing that was really important in that reset was finding out how we were going to be pitching to the board that we would be sustainable, and that the board should invest in innovation now because we bring sustainability in the future. And that's where probably my skills and my approach really came into play, because I understood the money, I understood how the NHS would invest to save and how return on investments would work. So I played a key role in bringing that more commercial focus to the team, but also being able to describe to the board why we should invest now to make savings and to make benefit and make impact in the future. So the next thing we did was we really wanted to get innovation, its own identity and brand at Alder Hey. And I think we've always been really proud at Alder Hey that we don't just want to be standard NHS. So I wanted to share with you today our new strategy, our elevator pitch. I'm really delighted and excited that we've called our new strategy Daring to Innovate, because it really epitomises who we are and what we're about. In Alder Hey, we want to be brave, we want to be different, and we want to be able to move at pace. So our new strategy is all about daring to innovate. When we thought about the why, the so what, why do we want to innovate, what we've landed on as our strapline is today's child, tomorrow's healthier adult. What means a lot for Alder Hey and for us in the team is that if we can impact children now, 30% of our population are kids, but they'll be 100% of the future. So our big goal is to have an impact for every child and have innovations that touch every child on the planet, all 1.9 million of them. And if we can do that, that's when we'll get the champagne glasses out. So I wanted to tell you a little bit more about the executive hook, which was really important to us. If I'm really honest, when I look back on that roller coaster, especially when I was sat with my finance boots on, we were very much considering innovation to be a commercial activity, something that was going to help the bottom line, something that was going to bring revenues into Alder Hey, and it might do, but actually what we were missing was that hook. And I think what we've redone now and reset is our main hook, our main focus is about having impact to care. We're really clear now that our strategy, our innovation strategy, delivers this trust strategy, and our trust strategy is to have the best, most outstanding quality care for children and young people. So I just wanted to share today, one of our impact stories that we're really proud of. This was a girl with a cancer, a really rare cancer actually. I don't think a cancer that's even got a name because it was so rare. But we used our innovations, specifically our 3D printing, to really help with that preoperative planning to make that really dangerous, complicated surgery successful. And now that little girl, she's back at school, and that's what it's all about. It's about having that impact to care. The final thing I wanted to share with you today is just my advice from my journey, my personal journey, moving across from a finance, a business role into an innovation role. I'm not sure it's a career path I would have thought of 5 years ago, but it's where I am, and it's, I'm delighted about it. But my 4 pieces of advice really from that journey, which I'd like to share with you, which might give you a shortcut, it might give you a way of doing it quicker, it might give you a way of doing it better than Alder Hey and getting there faster than us, are as follows. The first one I think is really important, that innovation and setting up an innovation centre from scratch can be a roller coaster, but that's okay. That's what it's like. It's hard. If it was easy, everyone would have done it, and everyone would have successful innovation centres in hospitals in the world. So hold your nerve. If you've got a goal and you've got a big vision and you're on the right track, hold your nerve. You will get challenged. You will get folk not believing in you. You'll get folk thinking you're rogue, but that's okay. Hold your nerve. Keep on track. Keep going, and you'll get there in the end. The second thing I wanted to talk about was that credibility point. I think one of the challenges for an innovation centre when you're trying out stuff which is not the norm, which isn't the standard, which can feel quirky, it can feel different, and it can feel definitely disruptive, is you need to do that in a credible way so that you've got the respect of both your colleagues but also your board, that they will know that what you're doing is going to have long-term benefit for short-term effort. So that credibility is really critical. And one of the key ingredients for credibility is having the right team. And I would just really recommend that any new innovation centres that get going, make sure you've got that right team. Make sure you've got a team with the right talent. You need commercial people with IP experience. You need clinical inspiration. You'll need folk with financial skills, but you'll also need tech startup skills and probably a plethora of other things. But my key advice is making sure you've got that credible team is a key, and has really helped us at Alder Hey do what we've done. The third piece of advice for me, and this is probably critical actually, and I would say probably the number one piece of advice that I could give any innovation centre, is be really clear with the board when they invest around what they're going to get in return. Set them expectations from the start. Don't enter into, a deal with board that you're going to give you money in year 1 and then in year 2 there's going to be upside or return on investment. Innovation is not necessarily for everybody a quick win. You can get some quick wins and some early wins, and that's fantastic. But most times, if you're really, really honest about doing open innovation and product development, you are talking potentially a 5 to 10 year sustainability runway. So be really clear with the board, because actually if you set up on the wrong foot and you say, right, we're going to make money in year 1 and there's going to be a commercial and there's going to be this and there's going to be that, it's going to be all fantastic, very quickly the KPIs won't look good and there won't be a positive buzz, and actually that's not going to help with the innovation culture that you need to set. The final piece of advice is about that impact. Be really clear from the outset in your innovation strategy around the so what. What is the impact you want to have? And I think for most hospitals who are in the business of delivering care, it's really obvious you want to have impact to care. But say it, believe it, report on it, count it. Have them metrics that demonstrate the benefit that you're having to patients. Tell the story through patient stories, real life stories, for others to see, for others to hear, and for them people to think, that's fantastic, we want more of that, we're going to grow that, that's brilliant. So that's it for me today. That's my final slide. So I'd just like to wrap up with 3 key points from the presentation today. The first one is find your hook with your board, something that means a lot to them and something that they'll buy into. The second one is get the right people on board, the right team and the right capabilities who are all working to the same common goal. And the final one, this is an Alder Hey one, but be brave and be different. If you want to be a great innovation centre, find your USP, feel like you're different, feel like you're brave. So that's it for me today. Really delighted to talk you through our journey, and happy if there's any additional questions to take them in the chat. Thank you.
Hi everybody, it's great to be with you today. So my name is Kate Warrener. I'm the Chief Digital and Information Officer at Alder Hey. I'm also the Chief Digital and Information Officer at Liverpool Heart and Chest, but today we're going to share with you Alder Hey's journey to a digital future. So there's just a few things I really wanted to share. So I think the first point I would make really is for Alder Hey, digital has been identified as a major priority for the organisation. It's a strategic priority identified through our plan, which is the trust strategy, and we have a great legacy of prioritising digital, including investment backed by our board and also supported by our clinical divisions. Our digital future is built on absolutely solid foundations. As I've mentioned, really, we've got this history of prioritisation and investment. We've got great people. We've got fantastic clinicians. We have an electronic patient record, which has been in place for a number of years, which really helps us throughout the organisation in terms of our digital work. We were delighted to be part of the Global Digital Exemplar programme, and internally, we've invested greatly in our digital work through the years. Our work on the new hospital, digital was baked throughout that, and was really fantastic in terms of looking to what the opportunities are in delivering care. We did a piece of work back in 2019 with our staff and our children and young people, really to reflect on where we were up to and the strong foundations that we had in place, but also looking to the future and seeing, where is it that we want to go in the future and what are our aspirations around digital. The children and young people, the Children and Young People's Forum kept us on our toes and said things like, why do you send us paper? Stop sending us paper. And also, sometimes it can be frightening for us to come in to hospital. So we'd like to see some of the things that are in place before we come in. So we'd like to meet the staff before we come in. And also things, more innovative things around potential for using virtual and augmented reality when having procedures to distract them from frightening procedures. We set out a very clear vision for digital futures, and this was really around thinking about digital excellence and outstanding digital excellence. But at the heart of this was an ambition around creating the really best experience for our staff and for our children, young people and their families. And through this, we really set out an aspiration to strive to deliver the best digital and technology services for our staff, enabling excellent clinical care and excellent clinical outcomes. We set out a commitment to deliver the basics well, and championing a digital first approach within Alder Hey. We also said, we were keen to unleash innovation and research, that there's a real close connection between innovation, research and digital, with digital enabling lots of really great opportunities for innovation and research. And we also set out an aspiration and a commitment to maximise local, national and international partnerships in that work. So through our Digital Futures approach, we set out 3 key themes back in 2019. So the first was around interacting differently with our children, young people and their families, and we set out a range of programmes around that. So things including the development of a digital front door to be able to connect with Alder Hey, including our website, our intranet for staff, but in a really exciting way, enabling our children and young people to see our clinicians digitally, and for the removal of paper, which is one of the things which the Children and Young People's Forum had asked for, and a range of other things in terms of connecting differently with our children and young people. We also set out a key theme in terms of digital quality improvement, and this was building on the work that we had in place with our electronic patient record. We know that good, safe organisations and high quality care, where we have good digital systems and good digital processes, can really enhance that high level of quality and high level of safety. So we set out a suite of programmes working with our clinical teams in that regard. We also gave a huge commitment to our clinical divisions in terms of making sure that they had the right equipment to do what they needed and our clinical staff needed to care for the children and young people that they were looking after. And our final theme, really, with 3 key themes, was around really unleashing innovation and research. As I mentioned earlier, really ensuring that there was that close alignment between digital innovation and research, and maximising those opportunities. We felt that what we needed to do to achieve these 3 themes was to get a number of things right, and that started with the basics. And so we had a refreshed technology roadmap, which included a real range of things, from upgrading some of our equipment on our wards to upgrading some of our back-end infrastructure, and a really great range of things which we put in place throughout 2019. So in terms of some of our headline achievements, what I wanted to do was just talk through some of those. So the first, we've talked about getting the basics right. One of the key things which we found was fantastic for us was our move over to Office 365, and we never knew how much we were actually going to benefit from that in terms of our support for our COVID response. And I think it's true to say, the work that we've done in terms of 365, and particularly Microsoft Teams, has enabled us to continue to care for our children and young people, and to keep them safe, and to keep our staff safe through the COVID pandemic. We have improved our core infrastructure, but we have invested heavily in really improving the equipment that our staff use day to day. We've given out laptop devices, mobile devices, and we've upgraded some of the mobile applications and equipment that are in place across our wards and our community services. We were delighted this year actually to receive accreditation for our Global Digital Exemplar programme, and this was around really upping the game and upping the ante on our digitisation of our clinical work across the organisation, but also doing some really exciting stuff, including championing the Alder Play app and championing our wider system approach to information sharing through the Share to Care programme. That led to an incredible achievement where we were highlighted as the one of the first trusts actually in the country to achieve HIMSS Level 6 accreditation in December last year. And HIMSS Level 6, for those that don't know what HIMSS is, so HIMSS is an international benchmark for digital maturity, and this is very much around how well technology is used throughout care processes in organisations. It's a fairly new thing to the UK, but is well used globally across the world. It goes from level 0 to level 7. Level 7 being the most digitally mature organisations, and level 0 being the most digitally immature. So our aspiration is to build on our level 6 work and take us to level 7 next year. I've touched on the COVID response, and I think it's fair to say without our work on digital futures, we would not have been able to respond as we have done to the COVID pandemic and the crisis that we've seen across the world, but locally, and our staff and our children in Alder Hey. And this has really helped us to keep everybody safe, but it's also helped us to keep connected, which has been a really important thing for all of us throughout the pandemic, and it has helped Alder Hey to continue to care for the children and young people that we are here to serve every day. So we're really proud of our digital achievements in that area. One of the things which we did set out through Digital Futures was this interacting differently with children and young people. And one of the things which we have really accelerated through the pandemic is our approach to digital consultations. And reflecting on that, I think there was a number of us having various workshops pre the pandemic, physically all in a room together. But really working on those plans, and actually, COVID just gave us a platform and an opportunity to do something very different at scale. COVID also helped us really in our thinking around telemedicine, and again, this had been something that our innovation team had been looking at with the neonatal partnership, and we actually had a session with the Mayo Clinic just before the lockdown in March. And we took some very quick early decisions with our innovation in digital and our neonatal partnership to invest in telemedicine and to support the service to provide some fabulous looking after the smallest, sickest babies in our city. And that telemedicine work has been absolutely fantastic as part of our COVID response, and it continues. Just with some feedback from our patients, so this is fantastic. I think it was what our children and young people asked for, when we launched our Digital Futures work, and they actually named our work Digital Futures. But they're really grateful for what we've managed to do for them, and I think particularly around interacting with them through video. They don't have to struggle getting a car parking space, and they've really embraced this new way of working, and long may it continue into the future where it's appropriate to do so. So just final part of the presentation really is just some reflections on some of our key ingredients, and this is perhaps a little bit more of a fun part of the presentation. So, I've talked a little bit about the Children and Young People's Forum, and these, I must caveat, these pictures were taken in 2019, so there is no social distancing, but that wasn't a thing in 2019. And the pictures you see there is the engagement, or some of the engagement we did with our forum in Digital Futures. I had a brilliant grilling from them, and we did a video with them, and they were instrumental in our Digital Futures plans. They also helped with judging some awards with our digital team, and brought some great spirit and fun to that environment. I think the second ingredient for success I just wanted to reflect on was great clinical leadership and work with our division. So we've got 3 clinical divisions in Alder Hey, which is our medicine division, our surgical division, and community and mental health. And what you see on the screen there are 3 of our fabulous clinical leaders. So they're what we call our CCIO, so our Chief Clinical Information Officers, and we've got 1 per division, and they're really the voice of digital out and about on the ground, gathering views from their colleagues, but really keeping us on our toes and leading us in this really important agenda. The next thing really is just celebrating what a great team we've got, and we've built up a fabulous team, really talented individuals. And I think that having the right people around this work, leading it and delivering it on the ground, is absolutely critical to the success we've seen in Alder Hey. Again, what you see there is a picture that was taken in December 2019, and you can just see on the top is a big balloon of a number 6, and that was us celebrating our HIMSS Level 6 accreditation. But it was also a really poignant moment for those of us in Liverpool that are Liverpool fans, and we had the football team in celebrating 6th major significant cup win for Liverpool, and again, no social distancing there because it was pre-COVID, but it was a great celebration event for the team. I think just moving on really, I think the next thing is around building on the team. I think having the right support in place and having the right attitude and the right culture, and that takes time to build that. And for someone like me who's quite impatient actually, there's something around being patient to see that really materialise. And I think our learning through COVID and how we've approached the COVID pandemic from a digital team perspective has really cemented this thing together. What you see on the screen there is a number of things. One of the things which we set up very early in the pandemic was a high five board in our department, and this was in recognition of our fabulous staff who were working round the clock to put in place things for our clinical teams and our corporate teams. And so this high five board is something which was reviewed on our daily calls at that point. In our department, unfortunately, we lost one of our team to COVID, which was a tragic experience. And one of the things we were keen to do was to regularly remember Andy, our colleague, and the team actually renamed our high five board to Stampy's high five board in his memory. We now continue those team sessions twice a week, and we celebrate the successes of our staff, and we hear from our teams, and we talk about Andy's Stampy's high five board, and we celebrate successes twice a week, and that's been a big cultural improvement, I think, for the way we do things. One of the things we also put in place was a drop-in clinic, and this is quite novel, I think, in some digital services, and it was something we were keen to do actually through Digital Futures, thinking about the Genius Bar type concept where you can walk in and be greeted with a smile and be able to get your issue fixed. And we put that in place for our staff through COVID, and we've kept that in place. So it's really appreciated by our clinical teams, and it's a huge success in terms of the way we deliver our services. And then my final ingredient for success, and again, this links to the twice weekly sessions we have in our department, but I think it permeates out. There's something around just remembering to have a bit of fun. So we did a range of things at our briefings. So we had pet of the day, so you can see someone's pet of the day there on the screen, and one of our staff actually dressed up as a unicorn, with his 2 dogs. We had a great bake off, and what you can see on the left there is a cake which one of our team members baked. That cake was actually baked on the back of a picture which one of our staff members' children had made for our team, and it says, "Have a great day, NHS heroes," and it really lifted everyone's spirits during the pandemic. And then the other pictures you can see, so there's one in the background and then there's one at the front, and these are our regular briefings. So the one on the top really has got when masks were introduced. I was actually working at home that day, but one of the team there's got a mask and he's put a smile on his mask, and so that was, to keep us all going. And then the one in the background, this was our Halloween themed day, and I was actually encouraged to dress up, so I'll leave you to spot where I am on that. But we had great fun in really just keeping together and creating that great culture, keeping going and keeping everyone motivated with real passion and energy. That's in a nutshell really, and a bit of a whistle-stop tour where we are from an Alder Hey Digital Futures perspective. We are so proud of what we've delivered. It makes a great difference to staff, and it's a real privilege to share that with you today. Thank you for listening.
Hello, I'm Rebecca Hamilton-Cook, and I'm the Commercial Research Business Development Manager here in the Clinical Research Division at Alder Hey Children's Hospital. In response to our commercial partners, we have recently established a new commercial team called Core, which is challenging the way that we work with and for our commercial partners to bring new solutions and medicines that meet the unmet needs and benefit our babies, children, and young people. As a centre with rich heritage in research and development, including the successful delivery of clinical studies, we are used to working in partnership with our children and young people, and in fact see their input fundamental to our success. We have experienced clinical and academic researchers across our 45 specialities, including outstanding facilities and a dedicated research facility which is funded by the National Institute of Health Research. This facility, which is dedicated to early phase experimental medicine, has been successful in supporting a range of studies and has clinical leadership in several themes. These themes include infection, oncology, and metabolic conditions. Complementary to this, we have experience and clinical leadership in medicines formulation and the development and delivery of device studies. Core brings that combination of clinical expertise, excellence in delivery, and experience of working with the paediatric population together to support companies in achieving their goals. So how can we help? We offer a range of services that can support companies in navigating the clinical trial landscape. From understanding what is acceptable to our patients, gaining feedback on prototypes and products, to working with our clinicians to understand the unmet need, we can provide you with guidance to choose the best research-based methods to produce high-quality data and outcomes. So even if you've never done clinical research before, or are even not sure whether you should, we want to make this choice easier for you. We work with a range of businesses, from SMEs to large multinationals, across a variety of healthcare markets, including therapeutics, diagnostics, genomics, and medical devices. We offer a range of services, including early project design, rapid feasibility, protocol writing, excellent recruitment to trials, high quality data collection and analysis, support in regulatory submissions, and grant writing for collaborative ventures. So if you'd like to know more about working with us, understanding the benefits that clinical research can offer your business, then please get in touch with me, and we look forward to working with you.
Hello, my name's Steve Begley. I'm Head of Procurement at Alder Hey Children's Hospital. I'd just like to give a short presentation on the way innovation and procurement have worked together at Alder Hey. So looking at the contents that we'll be talking about today, as you can see, there'll be an introduction of what this is all about. Then there'll be a discussion around the barriers to the new entrants to NHS markets, the COVID-19 response that we had to address this year. I'll talk about intellectual property rights and possible gain shares with suppliers, and about an innovation dynamic purchasing system that the Trust has actually produced, and then I'll summarise at the end. So if I can just start. So historically, the NHS procurement teams have not really been involved in innovation and product development. They've tended just to focus on things like making savings and reducing costs by negotiating lower prices for what we buy. But more recently, I think some more progressive trusts have actually embraced innovation, and they've explored ways in which they can co-create products which are innovative and unique, and Alder Hey is one such trust. So, in order to successfully navigate the minefield of procurement law and ensuring value for money obligations are met in respect of public sector expenditure, early engagement with trust procurement teams are key to that. All trusts have certain rules that they have to comply with, and they have financial governance rules, often known as standing financial instructions, or SFIs for short. We also have to comply with things like European procurement directives, and there are other statutory provisions as well on top of that. When we deal with suppliers, we try to contract on our terms and conditions, so the standard NHS terms whenever possible. And then we also have to make sure that necessary budgets are in place to actually purchase goods. One of the key overriding factors for all of this is ensuring that best value for money is obtained when you're spending public money. Okay, so often suppliers, particularly small companies and innovative startups and entrepreneurs, often find it difficult to access NHS markets. They often come up against barriers which I have tried to set out in this presentation. One of the big ones is about the lack of awareness of companies who don't deal with the NHS normally around the rules that apply to the way that you have to deal with the NHS. Another issue might be around not having a checkable track record, because that's important to the NHS, that we're able to check the credentials and check the history of a company who we are planning to deal with. And then there are other issues around innovative products, and suppliers are often unfavourably compared against the sort of established safe option suppliers who have been around for years. And that's a difficult hurdle for new companies to try and get over. Most trusts also within the NHS are very nervous about being a guinea pig. You know, they don't want to be the first trust, and they often won't be an early adopter. They'd rather see how it goes, and then they'll adopt as it's a more mature product that's established across the NHS. So that can often be a difficult thing for new companies to actually get into the NHS markets, because no one is prepared to take that step and give them the first order. I mentioned the rules before. I think one of the main things about the rules is there are certain things that have to be adhered to. So there are thresholds around compliance with European procurement law. So spending money over a certain threshold requires competitive processes. There are also issues around making sure that there are budgets for purchases, because an example that I can quote is that when a supplier approaches a trust who wants to sell their product, they often are quite frustrated when we have to reply to them by saying, well, unfortunately, there's no budget for that, or there needs to be a business case created, or we already have a contract with a competitor. And as I say, if it's above a certain value, then there's a need for us to do a formal competitive tendering exercise, so we can't just award business necessarily to one company who happens to approach us. This can create disappointment and frustration for companies, especially those who haven't dealt with the NHS before, as they really struggle to see why they can't just sell their product to us. Okay, so I think this year has been the most challenging year for NHS procurement ever, I would say, certainly in the 20 years that I've worked at Alder Hey. The COVID-19 pandemic obviously has changed everything, and certainly for procurement people, it has been a real struggle for us to make sure that we have the personal protective equipment to actually ensure that our patients and staff are kept safe. So at the height of this pandemic, all trusts were being inundated with approaches from suppliers of PPE of varying levels of quality and prices. This was very difficult for us to sort out the good from the bad, and all trusts were spending a lot of time trying to get their heads around that. Consequently, Alder Hey created an innovation portal. So we were able to coordinate these numerous supplier approaches across the Cheshire and Merseyside region. So we took it on ourselves on behalf of our region to actually coordinate these approaches that the suppliers were making, so each trust wasn't have to deal with them individually. And basically that has been very successful and has really helped to sort out the genuine approaches from the ones which weren't worth pursuing. Alder Hey's innovation and procurement teams also work with suppliers and other partners as well to actually develop new products during this time, and this was in direct response to the fact that we didn't have the product we needed, and it was a real critical issue for us to make sure that we didn't let our staff and patients be exposed to risk. So some of the products that we developed with innovation team and procurement team combined were visors. As at the start of this, there was a massive requirement for visors and there wasn't any supply out there. So we worked with a supplier to actually bring a product to market within a few weeks from just developing the concept to actually getting the physical product created. And that was something our Clinical Director of Innovation led on. We also were working with a company on mask saver boxes. So this was to prolong the life of the FFP3 masks, which were also in very short supply. And we also work with a local cotton mill on cotton face coverings as well, which have now been issued to all staff in the trust, and we also sell those in our charity on our charity website. So during the height of the pandemic, the main focus for us was on reducing the reliance on supplies from the Far East, because no local suppliers were supplying what we needed, and it was all about Far East and particularly China, where we were having to source product from, which clearly wasn't sustainable and really put us in a bad position. So we have been pursuing a made in Britain approach wherever possible, and we also now have been able to gain more control around the costs by not being reliant on the Far East markets, because at the time, at the very worst, we were looking at 10 times the price of the pre-COVID prices. So, talking about intellectual property rights and gain share now, as I say, Alder Hey is leading in working with suppliers on innovative products and creating and co-creating products with suppliers. In the past, there's been, NHS has dealt a lot with suppliers, but have tended to provide input without really getting anything in return. So they've used us as a sounding board and a test bed, and our clinicians have often given them some very good information on how their product could be improved. We are now seeing this, that it's an opportunity that we should be recognised for the input that we make. So Alder Hey now works on the basis of co-creating products where it's applicable to solve the clinical problems that we have. And we are also exploring commercial opportunities with these companies as well, so that our contribution can actually be recognised and monetised as well. So some of the things that we have looked at are sharing the intellectual property of the products that are created. So not just the supplier owning the intellectual property, but the trust would also have a share in that. Obtaining royalties or other financial rewards based on sales to other customers, if you like, apart from ourselves, or favourable pricing for the sales that are made to our trust, which would be better than what other customers would benefit from. An innovation dynamic purchasing system may not be familiar to a lot of people, but this is basically a purchasing arrangement that the trust has put in place, and this was in direct response to the way that we are working with suppliers, and then once we create a product or once there is an opportunity to supply to the NHS, actually accessing the NHS markets is very difficult. For the reasons I've mentioned earlier, So one of the things that we actually did was we created a dynamic purchasing system, which is a very flexible competitive tendering process, which remains open rather than the closed processes that most trusts operate. This enables new entrants to the market to quickly be able to obtain a compliant procurement route into the NHS. So Alder Hey has created this framework which lasts for 4 years, and it started early this year. The framework is split into 3 lots, so it's medical consumables, medical equipment, and also IT-related products such as apps and software. So Alder Hey will receive a royalty for some of the income that is derived by using this framework, and that again is something that we feel that commercialising things like this is a very innovative thing to do and a very valuable thing for the trust to be involved in. There's a very strict definition of innovation within this dynamic purchasing system, because this is about truly unique and innovative products. It's not just about products that have been established and on the market for a long time. These are truly new innovative products that we are looking to procure and to encourage small businesses, entrepreneurs and startups to actually get involved with. So in summary, what I would say is that we all know that for many years the NHS has been under financial stress, and there are many trusts who have reported large budget deficits and probably will continue to do so. We also know the demand on the healthcare system is growing year by year. And the NHS does value its suppliers and the goods and services they supply, and also we appreciate the need for suppliers to make profits as well. We need to work closely with our suppliers and deliver the highest level of patient care at the best possible value. That's something every trust will tell you. And one of the things that has come really to the forefront over the last few months is the need to innovate has never been stronger. So with the very uncertain future around the pandemic, plus the financial strain the NHS has already been under, it's vital that we have new novel ways of solving clinical problems, and this should be at the forefront of the NHS agenda going forward. The close relationship between Alder Hey innovation and procurement teams has been a real key benefit derived from the COVID-19 experience. It's not something that we thought would happen, but it just was something that when the pandemic hit, it made sense for us to work together, and we have really created a close bond and relationship, which I'm sure will continue going forward. And in summary, I suppose the Alder Hey procurement team is always eager to listen and engage with suppliers. And anything that suppliers would like to talk to us about improving patient care, reducing costs and promoting innovation is something we would welcome. I'd like to thank you for listening to me, and thank you all.
Hi, I'm Hayley Thomas and I'm the Head of Corporate Fundraising at Alder Hey Children's Charity. As a charity, we're here to support the hospital with enhancements above and beyond what the NHS would normally provide. We fund 4 broad areas across the hospital. These are life-saving medical equipment, campus, innovation and research, and what we call the magic. The magic can be anything from 4D projection, which transforms treatment rooms, to the amazing music and art therapy programmes we have here at Alder Hey. But today I'll work with the innovation team at the hospital. A visit to the Innovation Hub on one of our hospital tours is always a real highlight. It always captures the attention and the imagination of our supporters, and they can clearly see the benefits, the potential and the impact of the projects that the teams are working on. So we work really closely with the innovation team to understand how we can support them, and we've recently funded several roles within the team. That includes innovation consultants, health entrepreneurs and a clinical innovator. The funding of these posts has allowed the team to identify and assess the needs of the hospital and conduct a review of current projects as well, so that identifies the next steps and further funding that's required for those. It's also enabled the pump priming of pipeline projects, getting them to a stage where they can look at further funding from other sources, and that can be applied for and accessed as well. One of the innovation projects that has been supported with funding during COVID by the charity has been telemedicine. Alder Hey Children's and Liverpool Women's Hospitals have been using innovative telemedicine robots to ensure that babies are provided with the best care possible without the clinician being in the room. So this is really exciting because it's been done through the new telemedicine robots, which have enabled clinicians to take part in ward rounds, deliver emergency medical advice and facilitate urgent reviews for babies as well. Because of this technology, it means that clinicians are still able to make accurate clinical decisions, they can use the high definition cameras, and they can plug in medical devices as well to use for that assessment. So we're really pleased that we were able to fund this project, which was especially critical during the pandemic, but will also be beneficial in the future. As a corporate fundraising team, we're constantly looking for corporate partners who align with our values, and we work strategically to make the biggest impact. So many of the projects that the innovation team are working on currently have the potential to change healthcare practice and improve treatments which have a national and global impact. The projects are varied, and we work with companies to understand what themes or areas they're interested in supporting to ensure that staff fully engage with us. And whether that's through sharing expertise, through fundraising, or through gifts in kind, we work with partners in lots of different ways. So my first experience working on a project was the Alder Hey app. And that's a hospital app which is child friendly and helps to familiarise patients and their families with the hospital, also distracting and rewarding patients with fun games, with stickers, and lots of great content as well. So this was a new concept at the time, and we knew that we needed support from a company who understood what we were trying to do and could see the benefits for our patients. And I was delighted when Shop Direct, which are now the Very Group, agreed to partner with us for a year, but they also gave us support with their expertise as well. So they themselves were on a similar journey, and they'd recently created their own app and were looking at integrating AI technology as well. We were supported by an incredible team who were able to advise us based on their experience, and the app developer was going to bring this to life, so it needed to be the right partner. Their advice and guidance was really invaluable. We hadn't had any experience in app development before, so we really needed somebody to steer us and support us along the way. And then whilst this was happening, the staff across the organisation were looking at loads of unique fundraising ideas to help reach the £200,000 target that they'd set themselves. Staff took part in a walk between the sites in a retro gaming event, and held company-wide raffles along with lots and lots of other fundraising ideas, and they actually reached an amazing £250,000. This all supported the first iteration of the app, and we're able to engage the staff by sharing stories from our research with the staff and patients. Lots of really great things came out of that, and it was lovely to be able to share that with the staff, just keeping them updated with our app creation journey. So for us as a corporate team, it's really powerful when we're able to work in partnership with external companies. So we'd love to hear from anybody who would be interested in initial discussion around some of the projects that the innovation team are working on at the moment, or just anybody who wants to talk through their CSR programme and see how we can work together in the future. Please do get in touch with me and my team through corporate@alderheycharity.org if you are interested. There's so much more to talk about, and I haven't covered even half of it on this talk, but we'd love to hear from you. Thank you so much for listening to me. Thank you. Bye-bye.
Hi everyone, I'm Anthony Whitington, founder at Fixing Dad Limited. Welcome to our event, Fixing Us, Tackling the Patient Engagement Challenge. Our journey began in 2013, fixing our dad. Dad was the definition of disengaged from his own health and from his own life. He took no ownership whatsoever because he didn't believe this was his to own. His health belonged to others. His health belonged to professionals who knew much better than him what his state of health was and what he could do or couldn't do. His health belonged to the people who were managing him day by day, the healthcare professionals, the nurses and doctors around him. We were reassured that he was being managed, and yet he was dying. We learned on our journey that patients can and really must engage. There are so many people and organisations who can help them do this, but they do need to get in the driving seat with their condition. They need to own their issue and work at it, because the benefits are huge. When we do truly engage and take control of our health, we get better, and the world around us, the people close to us, get a little bit better along the way too. It's all about all of us, and it can benefit all of us. And that's how Fixing Us emerged. 7 years ago, our dad was very sick, so my brother and I set out to fix his health. We crowdfunded a campaign to make a film of our journey. So much has happened since those early days, so here's the short story of fixing Dad and why we believe engaging with our health is the key to building a better world. On the 24th of July 2016, the 1-hour documentary of Fixing Dad aired on the BBC. Millions of people saw our story and were inspired by it.
I mean, I guess this is to the whole team here. What a transformation. Jeff, I mean, you're just exuding energy now.
You're a picture of health.
Media coverage began to intensify, and right there, beyond our little project, we saw a massive, massive need for a positive and inspiring approach to health. Today, we live in a world where more than 2/3 of all deaths are from preventable diseases. Nearly the entire global population has a health condition, and 1/3 have more than 5 conditions. At Fixing Dad, we produce and deliver content to inspire and engage with so many health conditions. Under Fixing Us and other brands, we create authentic, real-life journeys, finding new ways to engage with patients, new ways to help people to be healthier. We believe the world needs Fixing Dad now more than ever, and we're on a mission to make this something really special, working internationally with some of the world's leading organisations and brands to bring this vision to life. Today, we are an organisation that can genuinely make the world a healthier and more loving place. It starts with engagement. So engage with us via our content, virtual forums, media and events, because we really can build a better world together. So what is the challenge? Why don't patients always engage? Why, in a world of more and more health solutions, are patients so difficult to connect with and solve? Well, this is what we mean by reimagining patient engagement. From working with hundreds of patients, we know the dynamics at the moment are not ideal. Patients expect healthcare professionals to provide a quick solution, and doctors have very little time, about 8 minutes in the UK, and can often take a didactic approach which might fail to connect with the patient. We speak to a lot of patients who take their medication and reassurance but haven't really truly been engaged with, and they'll often put those medications in a cupboard and forget about them. Does the patient have other ideas when they leave the surgery? The internet's all bad news. So when you Google type 2 diabetes, it's definitely not engaging. Chronic, progressive, lifelong, irreversible, and that's just type 2 diabetes. The risks are up front if you look. There are amputations, heart failure, stroke, MI, chronic kidney disease. And at the other end of the spectrum, mainstream media is full of unattainable good news stories, the before and after snapshots of these brilliant successes. But can patients truly relate to this, or do they just disengage further? How can patients navigate a path to better health against such an extreme backdrop? We don't think they can. The point here is that health tends to focus on journey endpoints and outcomes rather than on the journey itself. Patients don't need to go to extremes. By creating patient journeys to tackle, engage and properly inspire around various health conditions, we aim to show the whole journey in the work that we do, warts and all, because this is where patients see themselves. It's where they truly see themselves and identify. In the arguments, in the midnight snacking, in the laughs and tears, the stresses of work, or the relationships and the highs and lows, even relationship breakdown. But these journeys follow a pattern common to so many people with chronic health conditions, and we call these the pillars of engagement. They begin with jeopardy. So generally a journey will begin with a patient feeling the fear of their condition, understanding that this is not something they can necessarily live with forever, and that it will shorten their life or massively reduce the quality of the life they have left. And communicating that is a huge balancing act for medical professionals, and it's a balancing act for understanding for families and friend networks as well. So a patient has to understand fear. They have to understand, they have to feel that fear of a condition. Something like type 2 diabetes, if you don't know about all those complications, you can go on with your life and it can lead to truly disastrous consequences. But if you're going to give fear, then you need to give hope. We speak to a lot of patients who have been scared silly by their healthcare professional, but they haven't been given any hope at the end of the consultation, and that can cause huge problems where they just give up and disengage completely. Hope is something that isn't always easy to convey, but we think it's best conveyed with people who have been through this before, who have been through the highs and lows and have really struggled along the way, but have been successful in some way. And it doesn't need to be cycling 100 miles or climbing a mountain, but if they've managed to improve their health in some way, there's something there to cling on to for the next patient. Support is the next pillar. Now, everybody could go on a health journey on their own. They could tackle their health themselves. But with the support of somebody close to you, just knowing that that person cares enough to help to fix you in the first place can be hugely significant. When we're not really in a place to question our doctor or to understand what we're going through and what our condition is all about, having that person next to you in the consultation room to ask the questions and take notes can be massively important and significant on a journey and can make the difference between failure and success. If we don't have somebody close to us, we reach to our doctor and say, I want to go on a journey and I want to improve my health. We can then start to look at the future, and that's where the third pillar comes in, which is goal setting. And when we set goals in health, it's very important to accompany those with personal goals that are really personal to the patient. We work with a lot of people, and when we set up a health project, we encourage them to make it visual. So we have a whiteboard, and you'll see some of these in the session today, where people look at their health holistically and they look at where it is they want to go. And it may be that they want to climb a mountain, or it may be just that they want to survive long enough and healthily enough to see a grandchild be born, or to climb a set of stairs. It can be something very, very small and seemingly insignificant, but to them it means the world. So setting personalized goals is an incredibly important part of this process. In order to understand engagement and the real crux of engagement, our fourth pillar is perhaps the most important, and that is barriers. So what are the barriers to achieving those goals? This can often be one that's related back to mental health and can be right from people's past, right the way through to something that's just caused them to disconnect from their health and disengage. It can be something as simple as a few words that a doctor has said to them. In order to achieve those goals, we have to face certain barriers along the way, and all patients do. And those barriers will be unique to each patient, and it can go right from a mental health condition to something that's been said to them by a doctor or nurse. When our dad was setting out to improve his health, the biggest barrier we came across with Dad was that he saw his doctor as a god, and nothing his doctor said could ever be refuted. And so overcoming some of the negative things that have been said to him about type 2 diabetes being pretty much a lifelong condition that he wouldn't be able to do anything about was a real barrier for us to overcome. Now, to overcome those barriers, the key tends to be finding purpose. And the next pillar is about purpose. It's about finding that unique purpose, the real reason why you want to go on this journey and why it's necessary to complete this. And the final stage, something we find that's really common with a lot of patients, is advocacy. So a lot of people that have gone on a health journey and improved their health want to talk about it and want to help other people. Sometimes because other people come to them, and other times because they just feel this need to pass on what they've learned and the experiences they've had. So that advocacy, you'll see lots of examples today of people that have become advocates without being that sort of after picture or massive success story. They become advocates for a health condition to really try and help others. So today we're going to be talking with some of those patients we've worked with. We'll be seeing some amazing short films of their journeys and speaking directly with those patients too. Many of their journeys have gone on to inspire a lot of other patients to engage with and improve their health. We'll also be hearing talks from some very eminent professionals in metabolic health. Dr. Scott Murray, cardiologist and past president of the British Association for cardiovascular prevention and rehabilitation. Dr. Murray is passionate about prevention and will be talking about avoiding the path to heartbreak. Dr. Michael Baslington, NHS doctor and founder of the Body Mapping Clinic, will be talking about communicating the value of metabolic health. Professor Roy Taylor, the scientist at Newcastle University who discovered how and why type 2 diabetes can be reversed to normal. Professor Taylor will be talking about how we put power in the hands of the patient. In addition, we'll be hearing from some of our sponsors who've made all these projects possible. All our work focuses on bringing people together for stronger patient engagement. But this is the first time we've been able to bring so many great people and some brilliant minds together at one event. To get to the nub of how we tackle what is now a critical patient engagement challenge. We can't wait, and we hope you enjoy the event.
I'm 24 stone, I've got type 2 diabetes, I'm losing feeling in my feet.
We've been through the cancer and that was just horrendous for the whole family.
You are treated as that's how it's going to be.
I don't want to become dependent on a little pill that tells me I'm going to be all right.
I was put on a diet at the age of 3 and then again I was put on a diet at the age of 12 and it's never worked. They've never dug deeper. And I think that's the key to it. I think, I don't even know myself. It's just really at a point where, something's drastically got to change. I've got 3 kids.
To see these guys see me set an example of a healthy lifestyle blows my mind. Just seeing my image on that scan and seeing just the red outline of me and then just looking at that and thinking, how the hell have I got to this point?
You can go down a different path. That's as simple as that. It's a tough path, but you can do this.
I really need fixing.
I need a long-term fix.
If your dad can do it, your dad's inspired me.
Yeah, you can change your skill. You can make your life better.
I really want it. I don't care what anybody says, I'm going to do it.
I won't walk, I don't want to walk. I don't mind going up in stages.
Go!
Come on, you're nearly there.
I use the granny cog all the way.
Come on!
This change is just fantastic.
Come on, Jerry!
So just some background on the Fixing Challenge. After Fixing Dad aired in 2016 on the BBC, lots and lots of people came to us and were inspired by what we'd done. And in 2017, we partnered with the London Marathon and Prudential to put out an application process for people to come forward if they wanted to fix a family member. And this really wasn't about somebody coming in and a doctor's coming in to fix people. It was actually about families coming together to see what they could do as families in the same way as we'd done with our dad. So it provided that inspiration and that became the Fixing Challenge. So I think about 2,500 people came forward to apply for the Fixing Challenge and 4 people were chosen. And Craig Russell, who you saw in that film, was one of those people. So for us, a really interesting theme that came out of the Fixing Challenge was this idea of the sort of transfer of power from the doctor in terms of empowering a patient and allowing someone to actually go forward and carry their own health project for the future, something that would be sustainable for the long term. And Professor Roy Taylor, who's also going to join us today, was absolutely instrumental in that for us and our dad, and similarly so within the Fixing Challenge. So I'd highly recommend, if you haven't seen the Fixing Challenge, to go and have a look at that at fixingus.com. But I wanted to say a big welcome, first of all, to Craig Russell. Craig's with us today, and I just want to talk to Craig a bit about his first-hand experience. in terms of taking control of his health, and it's something Craig definitely did during the course of this. We've seen lots and lots of patients, do this, but this was a really, really incredible example. Craig, I think over the last, in those 6 months, lost about 7 stone. It was an incredible, incredible achievement. So, Craig, was there a moment in that whole process when you felt you took control of your health?
Yes, I think the big thing for me was understanding what worked, and being picked to do the challenge. I think was a big inspiration as well, because at the end of the day, you guys have put your faith in me in a sense that you saw that it was a possibility that I could, turn my life around by losing the weight. So for me, it was almost, I've got to do this. After what I'd seen with your dad, the losing feeling in the right foot. Yes, that's never going to come back for me, but at the end of the day, taking charge and basically being given some tools to basically, lose that weight, and the potential has been huge.
And because you've now been you've been in remission from diabetes for the last 3 years now, haven't you? Since the Fix and Challenge.
5 days in of doing the 800 calories a day, I had to be removed off all medication because my blood sugars were going too low. Mind you, doing a 20-mile bike ride against Roy's advice was a little bit stupid, but to get your blood sugars down to 1.9 after a 25-mile bike ride, and then realizing, hang on a minute, this isn't right, was a little bit foolish. But from there on in, it was almost plain sailing. You follow the plan of the actual meal plan, and you can't go far wrong. But it's having those tools in front of you to follow a plan in that sense, as in the help to be able to then lose the weight. And it's finding what works for you. For me, I've tried every diet under the sun. I've tried Weight Watchers numerous times. I tried, all sorts of things. And nothing ever worked.
So what was the difference, do you think, in terms of you actually taking control this time? Because I know the diabetes, you'd had it for some time, hadn't you? I mean, it was 3 years before you came onto the programme?
It's probably a bit more than that, actually. So what are we on now? 2020. So I think I was diagnosed 2012, 13, something like that, if I remember right. I haven't got the stuff in front of me. I can't tell you exactly. But, sort of when you go and see the doctor, it's like, here's a blood test. Let's see what you're at. So you have the blood test. All right, your blood sugars are doing this, right? Okay, just keep an eye on it. It'll be all right. Manage it with your diet. You'll be all right. And it's like, oh right, okay. And then before you know it, I was like, a year down the line, we'll have another test. Okay. Oh, that's quite significant now. Here's a tablet. And it was just like, right, okay. So we're now on medication. And you think, like, I thought, like, I've got real big trust in my GPs. They've been brilliant, to be fair, throughout. I've been with the same GP for 21 years, and I know them all personally. They're all keen cyclists, randomly. Seen my GP out numerous times on bike rides, and charity bike rides where I've done charity bike rides on the lead up to the Fixing Challenge, and he's gone, oh, like, you're looking really good, it's brilliant, to the point where they recommended doing the 800 calories to a friend, because it's wife and husband sort of GP practice, and they both had this friend who'd got type 2 diabetes, and they recommended the same as what I did through you guys to him, to this guy. And he's reversed his type 2 diabetes. Now, with me taking control, it was all about having the tools to know, which, you don't get given, I don't think, as much as you should. It's like, well, here's a tablet. It's not, here's a cure.
Yeah,
It's
yeah.
more,
We found
let's
exactly the
treat it.
same thing. Yeah, we found exactly the same thing with that. The information we got from the doctors at the time, and I don't think this was anything unique or particularly, bad, in terms of what our dad's doctor was advising. But it was very general advice. It was almost like, this is just common sense. You should lose weight, and you should, so eat less and exercise more. But there were no real specifics, and there was no specific sort of hope given. And that was when, we were sort of Googling everything and trying to work out, is there a way forward that where there's more hope involved? And that was when we came across Professor Roy Taylor's study. And suddenly there was this word reversal in there, and it was exciting, that it gives you this sort of moment of, actually, this is something you can actually do something meaningful about. And that was when we went to see Roy Taylor, and obviously our dad's story is history, but that was why we wanted so much to get Professor Roy Taylor involved in the Fixing Challenge, and so it's probably a good place for you to come in, actually, Roy. Welcome, and it'd be just great to hear from you about this subject of putting power in the hands of the patient and giving them that hope and inspiration.
Thank you very much. I'm delighted to be talking, and fantastic to meet Craig again. So, really, the whole business of medicine is trying to help people feel better, to solve whatever issues they have. And although it's sometimes dressed up in fancy terms, it's all about helping people live better lives, healthier lives, happier lives. And as part of this, I've been working with diabetes, both kinds of diabetes, but my research has been on type 2 diabetes predominantly. And throughout my career, the question has been, what causes it? Because it seemed to be so complicated. And if you go to the textbooks that all your GPs would be well familiar with, then it's a complex disease, it's inevitably downhill. And I was working all the way through trying to understand what happened to food after you eat it. That seemed to be a pretty basic thing, because we all eat every day.
Yeah.
And by about 2000, I'd figured that really it was the liver that was really calling the shots. And a few years later, we realized that it was fat in the liver that was really preventing insulin working properly. And that's when glucose levels start to rise. But suddenly in 2006, the possibility occurred to me that it might all be dead simple. So it wasn't just one organ that was bad, it wasn't the liver, it was the liver and the pancreas. And suddenly saying type 2 diabetes is a simple disorder of too much fat inside the liver and the pancreas suddenly gave me a different perspective. And I was then able to say, look, if this is right, we can demonstrate it's right by getting people to lose weight, substantial amount of weight, and everything should go away. So I published that hypothesis, which was greeted with enormous skepticism, and managed to get funding. Now, this is a key. The research funding is that which unlocks the door to everything. And it was Diabetes UK that provided the relatively small amount of research funding needed to show me whether my idea was wrong or whether it was right. And this study, the Counterpoint study, was absolutely the sort of results that hit you between the eyes. I've never had a hypothesis come out with such a clear test. There was a dramatic reversal of type 2 diabetes. And because of our tests that we'd developed using advanced methods of using scanning, magnetic scanning, MRI scanning in the body, we were able to say, okay, it is right. It's just a simple matter of too much fat in the liver and the pancreas. Send it away and it'll stay away. Now, that was in 2011, and still we're here today. And some GPs, not all, but some GPs are still handing out the old information. And indeed, some experts are clinging to the idea of complexity because that's where they grew up. It takes a long time to change a belief system. And so I'm just steadily working away, producing more and more information. But I might be able to show you something interesting that's actually happened inside your body, Craig. I wonder if we could
Brilliant.
have those slides I sent through. So this first slide shows just what's so critically important about getting rid of diabetes. It's the amount of weight loss. Originally, I'd calculated that 15 kilograms would be enough to do it. That might sound a lot, but we're not messing around here. We're talking about trying to get health back. So we've got to say what's really true. And what we found in our biggest study was just if you did lose 15 kilograms, and that's the bar on the right-hand side, then you had at least a 70% chance of being free of diabetes 2 years later. So that was really quite remarkable. On the other hand, if you just lose a tiny amount of weight, you don't really have much chance at all. Way down to the other side, there's about 5% chance of getting rid of diabetes if you only lose 5 kilograms. Now, I'd just point out that 5 kilograms would usually be regarded as a magnificent success in view of everything that's gone before, because medicine hasn't really grasped that you need such a lot of weight loss. But coming on to you at this point, Craig, I'm saying losing 15 kilograms. Now, you lost considerably more than that, didn't you?
So I think when I started, I was bang on 23.5 stone when I went through your scanner. Now, I think had got down to about 19 stone when I then went through your scanner again. That was in the June, I think, beginning of June. And then after that, when I got on the scales day before Ride London, which was 30th of July, I was 16 stone 8.
Wow. So that is just fantastic, Craig. So in the period that we saw you, up to that second scan, you'd lost about 26, 27 kilograms. And so you were way at the right-hand side of this slide. And so you were highly likely to have got rid of your diabetes with a good prospect of keeping it off. So that's the starting point. You'd actually done what people need to do, and that is to get the weight down. And if we could have this next slide, please. This is actually what's happening inside you. If we start over on the left-hand side, Craig, where it says 0, that's at baseline, then your pancreas would have looked pretty raggy inside. It would be irregular in shape and really quite thin and wasted. And even after 6 months, now this is after you've got back to normal, everything's hunky-dory as regards your glucose tests, but your pancreas gland, the organ, hasn't changed. You've still got a shriveled little walnut in there instead of a nice plum, as it were. But within a year, hey, look, this is getting back to normal. 2 years, it's well on the way to being normal. And for comparison, there's a nice normal pancreas from someone of equivalent weight. So that's what's actually gone on inside you. You know, you can be really pleased. Your pancreas has actually recovered to the nice smooth shape that you were born with. That's fantastic. So well done on that. Let me just show you that in numbers. If we could have the next slide. This is how your pancreas has changed from a relatively small size here, volume here, and it takes a long time to begin improving, but it improves. Now, one reason I'm showing you this is that it's so exciting to be able to see real physical change inside the organs of the body. because I've still got a lot of skepticism amongst experts who say, oh, it's just well-controlled diet. It's nothing to do with the basic process. Well, you know, this actually stamps the die and really makes it very clear. What you've done, Craig, is to restore this main organ of diabetes, the pancreas, back to normal size. And there's something else as well. You remember I pointed out that this pancreas was a bit lacy and irregular in outline? Well, next slide, please. That irregularity goes from being very irregular and not much change at about 5 or 6 months, but a year's better. 2 years, it's completely normal. So, congratulations, Craig. You have got a completely normal, smooth pancreas. So, that's an amazing achievement. And I hope that this new information, it was only published last month, I hope this new information will help bring more experts online to actually understand type 2 diabetes is a simple condition. So that's the new information that I'm excited about. But tell me, Craig, how does that strike you?
To see that and say, right, 2 years down the line, right, you're effectively cured. We can't say cured, I know that, but in a very good way.
It's interesting.
Like you used to.
It's really interesting you say that, Craig, because the whole subject of what you can and can't say in type 2 diabetes is quite an interesting one. Because we went through this for so long. Because once we did what we did with Dad, and then we realised that, you know, some people object to the idea of reversal. Some people object to cure, you know, remission, whatever it is you use. It's just, for us, it was hope. You know, you had to have. I think for us, in the end, we settled on reverse direction, and my dad was in reverse gear.
Yeah.
And as long as we kept him in reverse gear, we were all right.
Yeah.
And so it's kind of a process. But would you agree with that, Roy? Is it something that is there still a controversy around what we call this?
Yes, there's a lot of misunderstanding. First of all, the cure thing. Well, in the one sense, yes, of course. Craig has managed to cure himself of this illness that would be otherwise marching on and causing more and more trouble. You'd be numb to above your ankle on both feet by now, Craig, had you not taken action. And so, you know, in that sense, yes, of course. However, I much prefer to avoid the word cure purely because you're still susceptible to diabetes. If your weight went back up to, say, more than, I don't know, possibly 19, 20 stone, it's highly likely the diabetes will come back. If it went back up to where you started, it's 100% likely. And so it's because if you like, the threat is always there, that I'd prefer to avoid the word cure. And the other reason is that my fellow experts are still extremely sensitive about this. So I would want to avoid that sort of provocation. I just need to bring people on board and get them to understand just the real nature of this disease. So that's cure. Now, this reversal business is exactly what we're doing. It's what I set out to test. I wanted to find out if diabetes was reversible, and I've studied the pathways that underlie that. And I can say that yes, we know why the reversal happens. So reversal is real. Now, rather bizarrely, some people say you can't talk about reversal because that means to some people it's a permanent thing. Well, the other day I reversed my car into the drive, and I do hope it'll still go forwards. So I think it's a misunderstanding about the words. But then, you know, words are always troublesome and people get het up about these things. So remission is what you achieve long term. Yes, I mean, that is the state of being free of diabetes. Reversal is the process of going from diabetes back to normal. And so those two terms are correct. In a modified sense, you could say cure, but I would much prefer to avoid that. So that's how the words stack up to me.
And this is, the overhanging sort of title of this whole section is tackling the patient engagement challenge. So in that respect, before, and I'll let you bring you back in a minute, Craig, but how important do you think this idea is? I mean, you see it really clearly there in that graphic, of the pancreas. There is this clear sort of process of reversal, and you can see it happening. And there's no denying that. You can see it happening there. So how important do you think this is in terms of actually engaging a patient?
Well, I think it's critically important because here we've got a very visual indication of what can happen inside the body. And people like to understand what's happening. If I prescribe a drug to anyone, the first question is, but what will it do to me? How does it work, doctor? And if I advise anything to do with how they live or what they do, is what will it do to me? How does that work? And it's what people want to know. And now we can explain very simply that the pancreas is really battered. It's small and shrunken. It's just not working to produce the insulin. But if you take away the excess fat that it's struggling with, it might be able to get back to normal. And the shorter time you've had your diabetes, the more likely it is to be able to get back completely to normal. So we can hold out real hope to people. And I hope by conveying this very simple information, we'll actually transform the whole way that type 2 diabetes is approached.
One of the things I would just caveat with the fixing challenge is I think a lot of people look at that story and they see the 100-mile cycle ride, and that can become a bit of a focus, and it's like you've got to get on a bike and cycle 100 miles. And one of the things we're always keen to dispel, Roy, is around the exercise, food, focus, balance, because I know it's much more, isn't it, about the food, especially in the initial section of weight loss, much more about the food focus than the exercise.
Yes, that's absolutely right, because we've got to be realistic about the group of people who tend to run into type 2 diabetes. They tend to be a bit older, they tend to be a bit heavy, and these are people who can't actually exercise for terribly long. Indeed, if they take it upon themselves to go running a lot, they're likely to run into bad arthritis of the knees at a relatively early age. It's not a good idea. But they won't be able to burn off the sort of number of calories anywhere near what Craig mentioned just there, which is, for someone in peak form at a nice weight. So they might go out and just about exercise for half an hour, and that burns a trivial number of calories. They can get rid of that and counterbalance it with literally a mouthful or two of food. And that unequal balance is not really recognised. And, you've mentioned putting the power in the hands of people. And this is all part of it because it's all about the information. Yes, the detailed know-how and how to do it is important. But this is why I recently set about writing a book about this, just to tell people in simple terms what happened to food after they eat it. For instance, most people haven't got a clue that if they eat excessive carbohydrate, the body turns it into fat. And even experts don't realise that's where saturated fat comes from. If you eat excess carbohydrate, 100% of it is the bad form of fat. Now, you mentioned before tucking into that chunk of blue cheese on top of your fat. Well, the blue cheese has got relatively smaller amounts of saturated fat, and even that nice tasty layer of fat around your steak, Craig, is only 50% saturated fat. Now, you don't understand that from the conventional chat about food and what's good for you. So it's not the fat on your plate that's bad for you, it's the fat that you've stored inside you. And that's a critical thing. So all this information I've tried to put on our website just to try and make the information available to all. There is a website which contains a lot of this how to do it information, but also the book, Life Without Diabetes, by the way, all profits to Diabetes UK that put in that critical amount of funding to found this whole area of understanding of what type 2 diabetes actually is. That's all due to Diabetes UK, and all the profits from that book go to Diabetes UK. So in more detail, this is where it's all at. So you can find out what really happens to your food. A basic form of it is on the website, but more tilted at just the mechanism of getting rid of your diabetes. So this fits with the thrust that you mentioned in this program. We need to put this in the hands of people who can make what they will of it. It's not obligatory. It's up to anyone to decide what food they put in their mouth. So in a way, it's not really a medical decision, but it is information that's useful for people. So that's why I'm so passionate about finding out how it actually works and then trying to explain it in simple language.
I think that's brilliant, because that's so important, because I just, thinking back on the number of people that say to us, "Oh, we're so inspired by your story," or one of the stories that we've shown. And I've just gone and got myself a bike, or I've gone and got myself, a new pair of shorts, and they're out running straight away. But there's very little focus sometimes on the food. So I think that split is really is power in the hands of the patient. Just to understand that.
I think for me, I was always like growing up, like my story, Roy. Age 3. I've recently my uncle died a year ago, and he had a load of cine films of me as a kid. Now, I've posted a few on Facebook, and Anthony's seen a few of these already. And you can tell that I was overweight from day one, pretty much, on these cine films. So I've had them converted, so they're all, digital now. And, going back to that age, put on a diet at the age of 3 and told to eat low-fat foods throughout my whole life growing up was, that's what you do. And for me now, I suppose, having all of that turned on its head to the point where it's like, carbohydrate is what's caused you to have diabetes, effectively, because I've piled the carbs in for however many years, or done a low-fat diet, which you think you're doing the right thing doing a low-fat diet. You eat low-fat foods. Then you, like, more recently, in the last sort of 5-6 years, I've been looking at the labels and going, oh my God, how much sugar? And it's like, wow, and having that information there now and saying, right, okay, the sugar content of that compared to that is like, well, I'm going to go full fat every day of the week. And the way I've looked at it is it's all about managing my sugar intake with this whole process of change in my lifestyle. It's not about the calories I'm putting in and how much I'm putting in. Yes, I am sort of careful, but I don't actively count calories. It's, for me, it's all about the sugar content of food to manage my pancreas, which is now very, very nice and smooth, Roy. Yeah.
Absolutely. And this is worth a comment, Craig, because this business about the carbohydrate often gets a bit out of focus. And people talk about low carbohydrate diets as a way to lose weight. It can be. It depends how much carbohydrate people eat. But we've got to realize that this state of having accumulated more fat than your own body can cope with is actually due to having too much food. It's as simple as that. It doesn't matter what you eat. Whatever it is, you've eaten too much of it. And we need to first remove that. And that's why we've got this sudden drop. But when it comes to the phase that you're in, Craig, then it's a matter of whatever suits the individual. And by focusing on avoiding sugar-containing foods, which automatically means you won't be having any processed ready meals, you won't be eating prepared meals. If you read the labels, they've got a hideous amount of sugar in. So what you're doing is absolutely right. But if you'd just gone on to a low carb diet at the start,
Yeah.
it would not have done very much for you.
No, that's right. Yeah. So I didn't explain myself very well there. Basically, in this process that I'm in now, after losing the weight, it's for me, it's about doing the low carb thing now, and keeping to that to stop me from, I suppose, relapsing in a way. For want of a
And
better
that's where I
description.
think that was where the blood sugar monitoring was really powerful. Once you'd finished the 800 calorie phase, actually monitoring what different foods, the effect of different foods, was really effective blood glucose monitoring, as opposed to just we see so many people who just have a blood monitor and you look at when they're actually monitoring, it's very random. Whereas actually, if you monitor at the specific times, an hour and a half after eating, see how quickly it's coming back down. And you can see immediately, which foods are causing bigger spikes and affecting your averages, I guess.
We're touching on a wider issue here. The diet, as it were, the average British diet has become overloaded with sugar, largely because of the influence of pre-prepared foods, processed foods, and the habit of adding sugar to meat dishes, whatever, to increase the palatability, certainly to get folk to come back and buy more. And we really need to get a handle on this. And this is something that legislators have constantly danced around. Just at this moment, we've got a fight back from the food companies who'd far prefer to continue what they're doing. So there's nothing wrong with the food companies. We need these commercial enterprises, but we need a level playing field that people making the laws, and it's got to be enshrined in law, voluntary agreements are highly unlikely to have an effect. That has to come. And those individuals that shout loudly about not wanting a nanny state have just got to be asked, look, do you really want to pay out £10 billion a year to look after type 2 diabetes? Because that's what it costs the NHS. £10 billion. Who likes paying tax? Hands up. Well, no. We've got to get real here and get away from these heated arguments and look at it in the cool light of day. So we do need some changes to ideas about national food production, distribution and availability. That's a really important point, because it's not so much our generation, it's a matter of looking after the young people so that they will have less troubles when they come to our stage of life.
Yeah.
That's brilliant. So, I mean, obviously today, the main audience will be healthcare professionals from all over the place. So it'd be good just to maybe get from each of you your top point or two that you think would be the good pieces of advice for them to take away for the good of patients.
For me, for someone, if they're a healthcare professional, to take this away would be stop trying to tell people what to do, help them change. Because as soon as you tell someone what to do, people rebel against it, I think, and I was one of those people. It was like, telling me what to do, having a go at me, it's not fair, and a lot of people react like that. For me, it was about having my mind opened to a different way of doing things.
And that's where Roy, right now, that's changing at the moment, isn't it? So isn't this becoming more mainstream now in the NHS?
Yes, absolutely right. If I was just to underscore Craig's point, because he said something really very profound there for healthcare professionals. He said, stop telling them what to do, help them change. And that's really crucial. Although, of course, it has to be based on knowing exactly how and what to do in achieving this change. But we've shown that to be the case. So, a couple of points. First of all, we're in a fairly exciting position of actually moving things forward, because we've been able to move from this new understanding of type 2 diabetes, this discovery funded by Diabetes UK of finding out what causes the disease, to today, when I've just had a further meeting with NHS England about the rollout programme. There's a pilot programme in 10 sites throughout England to actually put this into practice, actually on the ground. And 5,000 people are going to enrol in this, and it will inform the NHS as to the most cost-effective way of doing this. And so things are moving. It takes a long time, but the understanding is rolling. So that's just a background. So you asked for a single point as to what I'd want healthcare professionals to take away from this. I would say the critical thing was, at the time of diagnosis of type 2 diabetes, this is a medical emergency. You don't mess around saying, it won't bother you very much, we've got tablets and we've got guidelines to treat this. That's a matter of supervising the inevitable decline. No, what you need to do at the time of diagnosis is to say, look, you have a choice. It is possible to get your health back. It's not easy, but you can do it, and this is how. On the other hand, we can give you tablets, we can supervise it, but we know there are huge risks. You're going to lose at least 7 years of life. You're going to suffer a lot of complications, and that's a polite term for it, because you just don't want to go there. Well, that information should be provided to people so they have a clear choice. Now, I'm not suggesting that everyone must opt for getting rid of diabetes. It doesn't suit everybody. Not everyone wants to do it at a particular point in life. It's not something that should be regarded as a stick with which to beat people. On the other hand, having clear information should be what we do as healthcare professionals. We're in the business of providing information and advising people. And so that would be my wish. You've got type 2 diabetes. You have a choice. So that's my message.
That's fantastic, fantastic message, and I think from both of you there, we've seen both perspectives, and it's really powerful. So thank you so much, Craig, and thank you so much, Professor Roy Taylor. Thanks for your time today.
My pleasure.
Like, I had some deep, dark days. You know, I'm not going to lie, it wasn't easy. But with the right support, and I think medical professionals need to sort of look at the way they support.
Ian, I think we've got a problem here that no one can hear the quick Q&A.
Okay. I need to check on this with tech.
Yeah.
You know, so for me, it was all about. Can they hear me?
We've got a technical issue.
Shall I carry on?
I think we'll just pause a minute just to see what's happening. Okay, I think we're back now. We're back now. I'm getting messages to say that we're back in.
Okay, brilliant.
So Craig, I think we'll go back on that because I think we had a tech issue in the middle of that.
Okay.
So what would you say to people? Because we're getting some questions through from people. You know, how realistic is this for others? You know, that perhaps want to set out on something like this.
You know, realistically, if you follow the plan, and you know, you've got to have a plan. You can't just walk into it and go, "I'm going to lose all this weight." It'll never happen. You've got to have a plan. If you follow the plan works. You know, it's been proven. I've proven it. Your dad proved it. You know, many other people have proven if you follow that plan, you can do it. The issue falls when you deviate. You've got to have the right support in place. It's not foolproof. I had some deep, dark days. I struggled. You know, and it's about managing. You know, if you have a bad day, you have a bad day. Move forward. Go on to the next day. It's
interesting, isn't it? I mean, how much do you think is actually, you know, facing those deep, dark days? Because I think this is something that, you know, in a lot of the journeys we see, people that are successful with this do go through those things. You know, they go through those deep, dark days, and perhaps something that distinguishes the less successful journeys is they're more superficial, so people don't really link those things together. And I think for you, one of the things you talked about a lot was your mental health and the impact of the diabetes on that, and the impact of your overall health, and really bringing the two together.
I could, you know, when I was sort of my heaviest at 25.5 stone, I'd be struggling to stay awake during the day. I'd be, you know, all over the place. I'd be, you know, in a real bad way. But as soon as I sort of started following the plan, you know, it almost made my mental health not better, but it was more manageable. And the exercise, you know, as soon as I started exercising, wow, you know, that I think that was one of the big keys to it. You know, you're getting off your backside. You're not sitting on the sofa all day. You're not behind your desk. You're not, you know, you're doing something on top of. Yes, managing it around the day when, you know, you've got 3 children, you've got, you know, all the other stuff going on, life stuff. Yes, it's hard. But if you really want it, and you really want to, you know, sort of engage, I suppose, with your health and your mental health, then you've got to take charge of your own, I suppose, destiny in a way, but with the right support, you know. And I think the medical professionals need to change, you know, the outlook of here's a tablet, this is how we're going to manage it, this is how we're going to do it. You know, no, I tried every diet under the sun. You know, I tried, you know, I was backwards and forwards to, you know, one of the well-known diet people, companies, whatever you want to call them. And I went backwards and forwards, yo-yo, you know, it didn't work. And I think the short, sharp shock of losing the weight in a massive amount straight away, it literally just dropped off me.
There's something really powerful as well, isn't there? The sort of the visuals that Roy uses, because I remember, you know, in that little clip we showed at the beginning, there was that little section where you know, you're kind of looking at the visceral fat on your liver and pancreas, and it really hit you at that point, didn't it? I remember you see you almost welling up there now. It was something about seeing that that was very powerful and sort of wanted you to
really, it didn't frighten me, but it made me really think about over the years how I had been doing and how I can now take charge of that, because it's like, hang on a minute, you know, losing feeling in my right foot, you know, down one sort of one edge, or one edge of one and two edges of the other, you know. So my left foot, I've got slight numbness, but the right foot, it was on two edges, you know, so on the inner edge and the outer edge of the foot, which will never come back. I know that. But seeing that was like, hang on a minute, this is, and then being told you can change this, you know, follow the plan. It's like, right, okay, great. You know, not here's a tablet, come back in a year's time. You know, I don't know. It's a difficult one. You've got to be able to take charge of yourself with the right support, I think.
Yeah,
you know?
yeah. And there's something, I think one of the things is it's such a big difference between being told you can manage a condition and actually being told you can reverse a condition.
Yeah.
You know, for us, I think one of the biggest issues when we started Googling, you know, chronic illness and type 2 diabetes was that everything is a plateau. You know, all you see is plateaus in health, and the language is very much, you know, it's apathetic at best. And so when we found, you know, Professor Roy Taylor and the work he'd been doing, I think the real most significant thing about that was that he was talking, you know, quite openly about reversal, and suddenly it changed the whole thing for us. We had a goal that we could set, and we're going to come on to goal setting in a little while, but we had the goal that we set. But you know, how did you feel in the way Roy spoke to you, you know, in that first consultation about, you know, you can just grab this and take hold of it?
It made me think. You know, previously, you know, like my GPs are really good. Like, don't get me wrong, they're brilliant. You know, and they've been totally behind me on this. When I went to them and said, "This is what I'm doing," they were like, you know, and sort of looked at me, and it was like, well, you know, this is under Roy's direction, sort of thing. You know, it was very sort of, I suppose, profound for me, because he said, you know, you can do this. You can take charge of it. You can get rid of it. And it's like, well, okay, brilliant. Let's have a go. You know. I think I've lost you.
We couldn't hold an event about tackling a patient engagement challenge without addressing the elephant in the room. Now, this is the biggest challenge we've faced arguably in a generation. This is the whole reason we're holding this conference remotely, the coronavirus pandemic. We speak to people all the time about how their physical and mental health and COVID-19 has impacted all of us, but some of us are more vulnerable than others. Becoming and staying engaged with a chronic health condition is tough at the best of times. Right now, it might feel impossible for many patients. So in this next session, we're going to be talking about engaging with chronic conditions like type 2 diabetes in a pandemic. And we're going to be hearing this directly from a patient who's been striving to do exactly that. In the work we do, we're behind the camera or behind the edit most of the time, but it's always an honour and a privilege to be a part of people's lives and to be so close to their health journey. And for the past 4 months, Fixing Us have been following very closely the journey of 59-year-old John Neary from Enfield in Essex, to see firsthand the real-life challenges of staying focused and engaged, and to really take ownership of our health in the most difficult of times. To give you the best feel for this, let's have a look at the first part of 3 in John's story.
My name is John Neary. I'm 59 years of age, born in 1961 and was born in Hackney, East London. I've been married to my wife now for 30 good years. I like to look at life in a good way, a fun sort of way. When things are down, I tend to try and bring people up. I've got 3 beautiful girls and they're fit and very healthy, which is all that counts really.
Some of the best memories I had with Dad would probably revolve around holidays. I think just having fun.
Unfortunately, sometimes in life things don't go as you would like them to. My wife came out, I was in bed because I wasn't feeling well, and she said, the hospital's on the phone for you. So I was speaking to this guy from the hospital, and the words he said was, don't panic, but your results have come back. Your cholesterol is showing 15.5 and your blood sugar levels are off the screen. We've had my trials and tribulations throughout life, but I think there's a lot of people who've had a lot worse than me. I've always worked. I think in life you have to work for it. You have to work for what you get. And I think you need an element of luck along the way as well. I wasn't aware how badly this illness eats away at your vital organs inside, especially like kidneys and your pancreas and your legs. The more I'm starting to learn about it, the more I'm starting to be aware of what it can affect. I haven't cycled to work for a week and a half now, and it's quite interesting that my sugar levels have rose since I stopped that. My sugar levels increase with stress, very much so. I do try and reduce it. I get very good help at home.
On the train, just pulling into Liverpool Street.
Are you still filming?
Yes.
Right, I'm taking it now, my blood now. 7.6 is my reading, which is good. Tennis I started a couple of weeks ago, and I've been going for some runs.
It would be nice for him to maybe decrease his medication.
The first one I take would be an aspirin, bisoprol, my insulin, my metformin, albufuranol, losartan. I've only been on the insulin since Christmas Eve, which is when I got brought into hospital this year. I still relapse sometimes in my food and diet where I do like a chocolate. I've got a sweet tooth and I've got a savoury tooth, unfortunately. I've got both of them.
If he carries on the way he is, it's going to be difficult for him to maintain a lifestyle that is going to keep him around for long enough, really.
So this is my prick test, which I would do now before my midday meal. It's 8.5, so I would accept that. I don't know what I react to in the line of what food affects it as much, you know. All I've had today is 2 slices of granary toast with a bit of peanut butter. That was eaten at about 9 o'clock.
Currently at Enfield Town Station on my way to work, either bike or train, depending.
Mind the gap between the train and the platform. We want to help him feel fit and healthy in himself as he's getting older, so that he can enjoy that next stage in life.
This one?
Click on campaigning.
Cool, don't you showing Tom's phone?
If he was fit and healthy, it would mean that we wouldn't have to worry. He's getting older, we're getting older. Hopefully, in the future, there'll be positive things to come for us.
If you don't feel pain, it's very easy to ignore. It's all about getting to understand it. The only way that people will take that in is by hearing and being able to contact people and speaking to people that have gone through it.
It's got to a point now where I've been told it's affecting other things as well, so I've either got to step up to the mark to make sure that I don't snack anything anymore. My level's now gone up an hour and a half after eating the vegetables and salmon and spices to 10.4.
I think the main thing for us as a family is just to keep on top of him. We need to support him when he's having good days and try not to nag, I guess.
So that was John's journey, part 1, and you'll see there that John's journey will continue with parts 2 and 3, which will come along soon. So John, a big part of what you've been doing is learning about your diabetes in terms of, you know, which foods and lifestyle factors, stress, sleep, all those sorts of things affect your blood sugar. So do you want to just tell us a little bit about what's been happening over the last few months?
Well, over the last few months, as you said, my blood sugar levels were going all very high, and they was a bit out of control, or sometimes a lot out of control. And obviously, I identified with the fact that it's certain foods that would trigger my blood sugar levels that were going high. So, in the process of the last few months, I've sort of decided to eat my meals, but then take my blood sugar readings before and after at certain times, and trying to eliminate and prove certain foods were the root of the cause that were making my sugar levels peak. And I've done that through quite a lot of time now, where I've just like readings, and then I've had the same meal, and then I've cut out certain foods, mainly the carbs. I think the carbs were causing the major issue. We all know, unfortunately, being type 2 diabetic, that things like sweets and the chocolates and fizzy drinks are sort of out of the way. I can't drink them, or I can't eat them to excess. So over the process of the few months, I've sort of reduced my sugar levels. I'm now pleased to say that I've actually got my sugar levels over the last few weeks very, very good. It's not been an easy time. What with COVID and work and stuff has been an extra thing to it as well. But you know, there's not ever a good time really to sort it out, because I'm coming up to 60 now, so it's a time where if I let it go too far, you know, I don't know what's down the line, and it's time to sort of get it in check.
And what do you think? Obviously, there's been the pandemic, but what do you think's been the toughest thing along the way? Obviously, back in January, you were actually in hospital with this, weren't you?
Yeah, my sugar level rose. I think the early part of that year, 2020, sort of thing. I was sorry, at the end of 2019, my sugar level started to get high, started to rise. I think that was because I took my foot off the gas. I thought everything was fine. I went through a stage in my head where I sort of had started to resent having to take all the tablets I was on, and then be careful what I was eating and stuff like that, because I felt good. I felt all right. I didn't have a problem with it. And then I found towards the end of that year, leading up to Christmas, I was feeling ill, and I was getting worse and worse. And once again, it was trying to get an appointment to see someone, and it culminated in the fact that I had to sort of have an emergency appointment with my GP, who then subsequently told me I had to go to A&E straight away, and that was on Christmas Eve. And I ended up being in hospital Christmas Eve and Christmas Day. That's when I was put on insulin, the first time I'd ever had to be put on insulin. And as I've said before, my blood sugar levels was virtually off the scale. When I did my tests on my finger prick, it wouldn't even read it. It was too high, which was a shock.
So you come obviously a long way in that time. So you think the most significant discovery is obviously monitoring the sugars more closely. So, I mean, Con, that's probably a good place to bring you in. Just talk to us a bit, Con, about why Roche wanted to support the project and why it's still so important right now.
Yeah, of course. So Roche has a long history of producing blood glucose monitors, so we know what we're talking about here. But diabetes is different for everyone. Every day is different, and you're managing a range of things. Keeping your blood sugar levels within what you would call a kind of a normal range is how you avoid the complications of diabetes, both in the long term but also in the short term. And within the video, John talks, for example, about experience of blurred vision, which can be an effect of having your blood sugar levels run too high. Also, having started on insulin, people living with type 1 diabetes and many people living with type 2 diabetes are reliant upon insulin to help manage that condition. Of course, you need to, as well as avoiding those highs, once using insulin, you need to also be sure to avoid going too low with your blood sugar levels. And it's not a sort of recipe book approach. You can't learn what works and then carry on every day the same. What you eat each day, how you're feeling, how you slept, what exercise you do, it has an impact. And some of those things you can predict. We really encourage the recording of data, whether that's on a scrap of paper or using more modern digital tools. But all you can ever really do is get an idea. You need to equip yourself with the knowledge and education. Now, people living with diabetes have a lot of support from healthcare professionals, but they're only with them for a fraction of the time. We're talking at most 3 or 4 hours a year, once you add all those appointments together, and that's not enough if you to manage the condition. So people are looking to make do on their own, and that's what we're trying to do, is to provide some basic tools, but also bring people together and show them what can be done if you upskill yourself and take some control.
Sure. I mean, that's really what's been happening, I think, with John. John, I mean, correct me if I'm wrong, but I know you've been sort of recording your blood sugars in a book, and now you've made a chart on the wall as well to sort of really sort of highlight the different foods and different blood sugar levels.
Yeah. I've done. I've sort of when my sugar levels been high after I've eaten certain foods, I record it, and I've been recording it. Part of the problem was originally was that because I'd sort of been complacent, a bit blasé about the whole thing, because I didn't really understand, to be honest, about it, about the whole thing about diabetes. So when I was a bit blasé, but now I then took into control that I actually recorded everything I do now. I sort of record. I mean, I know as well. I know as well how I feel. I know when I'm not going into a hypo, but I know when I'm low, and I know when I need to eat like food and eat certain foods. So anytime I was above a certain figure, say for instance 10, anytime I was above 10, I actually wrote down what I'd eaten for me to be above that sort of amount, that figure. And then I would analyse what I'd written down, and then I changed something in that meal the next time I had that meal and record it. So I've done quite a lot of the research on it as well, going on the websites and going onto the Ross sites as well, and having a look and seeing about things on there as well, and how they and other like companies do like things, just to get the advice. It's there if you know where to look. Everything is like there, and as I said, you need everything combined. You need help at home. You need help. I'm fortunate, I'm quite a strong-willed sort of bloke, so I've got, I can do these sort of things, and I think it's worked for me. And when you see it written down, and when you see, so when I go now to see a healthcare professional, I bring the information I've got, and I find that helps them so much because it's the facts are there. They don't have to ask me everything about this and other things. I just say, that's what I've done. By the way, there's a note on item number 3 which says what I ate at the time and when I did my blood sugar, like my testing. So I think that just helps the whole thing, the whole situation, really.
And is that, Con, just to bring you back in there, that's really what we're referring to, I guess, by effective glucose monitoring as opposed to just glucose monitoring. I know with our dad, the only way we really sort of made improvements was, actually doing that. So process of elimination sometimes, and then monitoring sugars before and after different processes and events. And is that what we're talking about in terms of effective monitoring?
Yeah, I think like anything in life, you want to be able to take action or gain insight as a result of the data you're generating, which in this case is your blood sugar level. The testing in pairs that you mentioned is really important, because to take an action, as you mentioned, John, about changing what's in a particular meal, if you don't have the data point of what your blood sugar level was like before that meal, then you can't pinpoint if it was actually what you've just eaten that's had that impact. Similarly, around exercise times or waking up in the mornings and going to bed in the evening, you need to to really kind of get to the bottom of it.
Yeah, that's exactly right, and that's what I sort of did. I mean, I can show. I mean, she can't see it because I can just show you quickly if you want an example on the screen of what I recorded. I mean, if you want to see it, it's whether it'll be any use or not, I don't know. I mean, it's here. If you want me to just show it to the screen, and
yeah, you could show us you can show us quickly. Go on.
Well, it's just it's just really an idea. So from this side here was the readings that I took, and as you said, Ron, from like when I get up to before I have my breakfast, after my breakfast, 2 hours or 2.5 hours after my breakfast, before I have my lunch, 2.5 hours after my lunch, etc. And one, as I say, that were higher than I would expect 10. I've put the number by it, and then I've wrote a note on the other side to say what I'd eaten, etc. And then further down on this side, I've eaten the same meal, but it's all there. It's all there. You can see. So it gives me an idea. It's not the everything. It's just that part of it where I mean, you can. And I've found that yes, I can have a treat when I want a treat. I can have certain things when I have certain things, but I know, like, if I have carbs, say for instance, if I have some bread in the morning, I won't have carbs at lunch. I might have some carbs in the evening with my dinner, but I won't. And if I don't have carbs at breakfast, then I can have a sandwich at lunch because I'm having a bit of carbs at lunch. So it's all about that. It's sort of like just finding out. As I said, there's other things involved in it, obviously, but it's just them things, little things. And as you say, it's testing my blood because, as you said, I can only get a true reflection of the sugar levels if you do it all the time and you do it consistently at the same times, because then you begin to realize how you're working inside, and how things are happening because of what you are doing and because of the elements that are affecting it.
I mean, that methodical approach with recording your numbers by hand is really impressive, and it shows a lot of motivation. Whilst this is probably a kind of exemplary way, we're seeing that people can sometimes believe it has to be all or nothing, when actually, if you are struggling to gain that motivation, testing in pairs on even one occasion will give you an additional level of insight. And I think with type 2 diabetes, that's often something that's hard for people to grasp. I mean, you mentioned before Christmas last year that you'd been a little bit overwhelmed by it, and it can be like that for many people. What we don't have to do is to give up just when we have one bad day. We can go back to it. We can say, actually, I'm going to test again in pairs. I'm going to see what the impact is here, and you do it at your own pace. And that's what I think either a healthcare professional or anyone else who's looking at your data with you can help with. They can help you interpret it and make decisions. There's also sort of more and more apps available where people can snap photos of the meal they've eaten, they can record it, and also some of the modern glucose monitors, they've got either internet or Bluetooth connectivity so that you can set it both to your own mobile phone. Sometimes it will send it also directly to your doctor's computer and to whatever software they're using, and you kind of ever increasingly improve upon the process. But it all starts with that really simple idea of trying to understand what's happening in your body.
And a lot of people are very, I think, feeling very out of control at the moment with the coronavirus pandemic. So those kinds of measures that give you some control, some ownership, I guess they're really significant at the moment. It's can really make a difference to people. Would you agree with that, John? Do you feel like it's given you some control in this time?
Everything in life, no matter what you do, you need to try and have an achievement by it, to have some good news by it, the result by it, and a boost by it, things. Whether it's anything that you do, and obviously it's no real a difference when you're talking about what we like talking about now. I've got an issue with my blood sugar levels. I'm concerned that in years to come, I mean, as I said, I'm 69 next year, so all my thoughts are as being around as much as I can for my family and my kids and stuff like that. So obviously, it's given me a boost, because when you see that it was going the wrong way for whatever reason it was, and I appreciate there can be a dip, there can be things that go wrong, spikes and stuff that happen, and they happen for various reasons. But when you then can control it, or you believe you're getting it under control by the effort you're like putting in, it makes you feel as though you're achieving like something, and you're achieving it because you're working at it. In life, as I said, we're blessed in life, and we need a bit of luck in life. Everyone needs a little bit of luck in life, but I think you also earn a little bit of that as well. It's like whether it's taking an exam at school. You know if you've worked at it, if you've revised it and you've worked at it, and you get the rewards at the end. It's what you've worked at. If you fail it and you haven't worked at it and you haven't revised at it, then you sometimes stand back and say, "Well, I didn't really work for that." So you expect what you get, and that's it. It's about putting something into it. And yes, getting back to your original question, you feel good. You feel good when things are going the right way, because that's life, isn't it?
Oh, that's great. Okay, so generally now, I mean, what sort of advice would you give to other people, perhaps that have just been diagnosed with type 2 diabetes, especially during this this pandemic with lockdowns and things? What would be your advice? What could they do to make their lives better?
When you're told that you're pre-diabetic, is to take heed of that, the notice of that. Is to take that seriously, because you can stop it. You can do the changes, hopefully, that you need to stop it. Now, unfortunately, with that is sometimes you don't get the correct help at the start for you to know and to be educated and to be shown exactly what will happen if you do not. You'll be told that you're pre-diabetic by the readings you have, the blood test, the urine sample comes back, etc., etc. But because of strains and because people are in their lives, as Con said, you only get a certain amount of time every year with a consultant or a GP. I was told I was pre-diabetic, but I must admit I didn't really understand what it was. I didn't understand at all what it was. I didn't understand that it will affect other organs. I knew about it could affect your eyesight. That's something you generally are told about diabetes, and you hear about people having their feet amputated and stuff like that. I mean, you hear that, but there wasn't anywhere to go and sit down and discuss it. So that's my own thing. I've been going about that for a long time. It's still up to me at the end. When I was told I was pre-diabetic, I should have stood up. I should have researched it like I have now. I should have researched it then, and quite possibly I wouldn't be here now, sitting here like talking. the real facts I will do, by what the people out there have got in place, there are means to control it. You know, we have got the means now to control it. We've progressed since the old days of diabetes, and and I think that's a good thing, and that's, you know, when I felt it, you know, no one wants to have to um, insulin inject in insulin or take all the tablets I take and stuff like that, and I would advise people, as I said, to take notice of it straight away and try and, you know, stop what you're doing. I've been having like one to ones with my with my consultant, and she has been really good, great for me. It was actually explaining it, working out different ways that we've increased the insulin at certain times. Um, when I've not felt well, she's actually gone into the technical side of explaining to me how what's happening internally and what she believes is happening and what I need to do. And she's very firm as well. She tells me when she thinks I'm not doing the right stuff. But I'm not if I lapse. It's about sort of honesty thing as well. You know, we've got to tell these people exactly what's going on. You don't hide anything or tell them that you're not doing things that you are, because it doesn't help them or, or you. So the ones to ones I've been having have really helped educating me into the disease itself, and so I understand it, and also just getting a good vibe that I've got someone there that can actually tell me and give me all the advice that I need.
Brilliant, thank you. And Con, do you think, would you add to that in terms of, you know, takeaways for the healthcare professionals when it comes to dealing with type 2 diabetes in these kinds of circumstances?
I mean, the pandemic has made clearer than ever how much people are left to their own devices to manage a condition like type 2 diabetes. And however difficult things are, you ultimately manage it better if you are engaged. And that engagement comes to people in different ways. There are different things that will motivate them. I think watching videos like this and seeing what I would call, not to get sort of too political about it, but real people like John getting by, learning along the way, that's what will make the difference. And it's knowing that there are uh, big dividends from every single incremental improvement in your diabetes journey. You know, we hear a lot in the media about the transformational things, people who put their diabetes into remission or lose enormous amounts of weight. But actually, there's so much to be gained and family lives to be improved by just making things that little bit better. And that's what I think the pandemic has probably given us all, actually, a bit more awareness that we just want to get by.
I think that's been what's so sort of humbling about watching John's journey develop is you've sort of said, yes, you've seen the blood sugars improve, but you see the family, the impact on the family. You know, everyone gets closer, and that's all you can ask, really, John. You've had great support there, by the sounds of things.
Yeah, well, yeah, I've had great support. I mean, I'm fortunate again, as I said, to have a loving family. My girls are all at home with me. They're all adults now, and I must admit, though, it ain't been easy. My daughters, every time I go to a certain cupboard in the kitchen, are questioning what I'm going for, what I'm doing, what I'm eating. You know, you should have carbs. Telling my wife not to put that much potatoes on my plate because they've got carbs, and I'm sitting there starving. And I'm going, well, just could you put it on my plate? And they're going, no, you're not having them. You're not having that much. So it's been like, you know, we've had our little times where we've had a few words where I'll come home and but it's all in a good way. You know, it's all an effort. It's a team effort. What with the national health and what with the people that produce all the stuff, and then your family as well. It's not a singular thing. It's a plural thing where everyone is sort of helping.
I think, it's admirable what you've done. I think becoming engaged and staying engaged, you know, with a chronic health condition is really tough at the best of times. But the fact that you've done it now is just, it's probably felt impossible at times, but you've done brilliantly. And I think it's so empowering for other people to see and hear that directly from a patient that's been striving to do that. So thank you and well done. And Con, is there anything else you want to add to that? I mean, I'm just trying to think if there's anything else we'd like to cover.
Well, I think all I'd say is just how much we've enjoyed working both with Fixing Dad and with John, because in industry we go through a lot of kind of hoops in order to make sure that we do talk to people with diabetes and that we try and incorporate your voice into what we're doing. But personally, in my career, it's never been as kind of clear and obvious as in this process. We've all learnt a lot in Roche by watching your journey and seeing you become more engaged in your diabetes and understanding the impact that your life has on your blood sugar levels.
I don't do anything to fail, competitive to a fault, and I wasn't going to sit back and waste the sort of the opportunity when the opportunity arose to, like, to just talk to people. I mean, I'm not anything special, I'm just a normal guy who's unfortunately got type 2 diabetes, but you live with it. You live with these like things. You are what you are. You do what you do. But I'd say thank you very much for Ross as well for being involved in this, for bringing this to the attention of everyone else, and thanks for you, like, guys, for inviting me in. You did say I'd be a film star after this, but I don't know whether that's going to happen or not now. But I'll wait and see with the contract.
It's not happened yet.
I'll wait and see with the contract who comes through, but I'll leave it there. But no, I've enjoyed it.
There are a lot of people watching.
I've enjoyed it, and as I said, thank you very much for the opportunity.
Oh, well, thank you. You've been brilliant all the way through, and it's been a pleasure and a real privilege to work with you and the family. And it always is. It's always a very sort of intimate process. So obviously, it is a privilege. You get a real insight, and and then to see other people hopefully inspired by your journey, it's sort of a double whammy, really. So it's been brilliant, and I'm sure we'll get some immediate questions coming in about your journey and about the blood sugar monitoring, and particularly, right now, I think it's probably the most relevant session today in terms of the pandemic as well.
Yeah.
So thank you.
Thank you.
In this session, we'll be talking about recognising barriers to patient success and how we overcome them. We'll be fortunate to speak to my own father, Jeff Whitington, about the journey we went on with him, and also to Dr. Scott Murray, consultant cardiologist, who'll be talking about avoiding the path to heartbreak. Let's have a look at Fixing Dad, the cardiologist's perspective, which will give a really good overview of this session.
There we go. You nice one,
And all right?
All right, how you doing?
Yeah, I've just been to see Dad, and he's just getting worse. It's just not good.
I know,
really.
he is. I know.
So I think we need to get together and do something.
But where the hell do you start?
It was behind me all the time, but I didn't really realise. I didn't know that I could be close to a heart attack or stroke or anything like that. I wish I'd been told back then. I wish I'd known. I just carried on how I always had. You always knew, you heard about people with heart attack. I just thought that was something that you either have or you don't.
I had to scare myself by seeing what was going on and then realising that terrifies you.
It's not just an illness. These things are there in the background and you need to look at them. You need to get them under control. And you can do it. You really can do it. I know that now. I know you can beat this thing.
Health is wealth. You know, you haven't got a dime if you don't have your health. We're living in a multi-morbid world now. There's not just one condition, it's multiple conditions you're having to unpick. Humans naturally won't change until it's right there. That's when they'll change, and that chance to be there at that time to influence them is rare.
Right, it's now 2 o'clock in the morning. I'm completing my chores around the building. Slightly out of breath now.
Tamsulosin, metformin, glycoside, warfarin, statins, atenolol.
Yeah.
The problem is when all these things come together, isn't it? Who is looking at the whole picture?
What is the problem with his heart?
Jeff was the poster boy for metabolic meltdown. Blood pressure was over 200 systolic, and he had atrial fibrillation, he's on warfarin, so he's already got macro and microvascular complications. You know, if we had put Jeff through the ringer at that point, we would have found quite a lot of abnormalities. I suspect that his cholesterol would have been raised. You know, there would have been talk about going on a statin. I reckon we would have found some abnormalities at the liver level, at the coronary artery level. The next step was a full-blown heart attack or stroke, without a doubt.
Perhaps I was thinking of downsizing a little bit later on and having a bit more money there.
It's not later on, it's with a line in the sand, it's now.
Yeah, yeah.
There is no later on, that is the problem, isn't it? It's, you know, you just keep going and keep going and keep going until suddenly it's not doable anymore.
Doctors don't really want to upset patients, but I think patients need to be upset to make a change. I don't mean that like I'm shouting and crying in the consultation, but they need to know that this is real. This could mean something drastic down the line.
Everything from cancer to heart attacks to strokes to dementia to amputation to kidney failure to blindness, impotence, it's all going to be much more likely. Unless we fix this, you are driving right next to the cliff. Where previously you were in the middle of the lane, you've now got a wheel half over the ditch, and it doesn't take much to push you.
I just really feel like it's someone else has got to do something. He's a fantastic dad, he's been a brilliant dad, and he's a brilliant granddad. And if we don't do something about it, no one else is going to.
From Jeff's perspective, the continued elevation of your blood sugar, as soon as you're going above sort of 7, cardiovascular disease is guaranteed almost. The biggest impact that we have on patients comes from the consultant cardiologist, especially at the time when the stent goes in. Prevention and rehab is not optional. This is what needs to be done to stop them coming back. And sometimes you feel a bit as if you're drowning and that you're never going to be able to do the right thing. Ultimately, you just have to follow the guidelines. Yes, it's good to know about imaging the heart and echo and putting stents in and devices, pacemakers, all those other facets to cardiology, arrhythmias. But if you want to stop people from getting there in the first place, you've got to embrace prevention. I think that more thought has to go into what the patient actually wants themselves. Ultimately, everyone who's in this sphere wants the same thing. We all want patients to get better.
And I think it's just I start to think about all the things that,
What?
Well, that you're going to leave behind.
No, you don't need to think about that yet.
I think we're looking at a world where at younger ages, people are going to be pitching up with heart failure because they've got diabetic physiology, hypertension, atrial fibrillation, stroke, heart attacks. It's gonna rise unless individuals start realising that what they ingest and what they do day to day actually matters.
We know he's stubborn.
I understand what I need, but I'm not going to be doing it. So what's the problem?
You're always 100 miles an hour, you just got to calm down.
Once he digs his heels in, that's it.
I don't enjoy cooking. You do though. I don't enjoy it. I don't enjoy cooking.
5, 6 people who come into my clinic on a Tuesday morning will be Jeff.
You have me running up and downstairs with my heart going like 20 to the...
Yeah, we have to.
dozen.
That's part of saving you, isn't it? Otherwise you'd be lying on your back eating whatsits.
It's such a moving thing when you think about the dads that haven't been fixed. If you could only just take a snapshot of that final moment when someone dies from something that could have been prevented. If you can only take that snapshot and show it to people, this is what happens. It's like a shock.
If the boys hadn't done this for me, then there's not a way in the world I would have achieved any of this stuff that I've done. They did things with me, they checked everything, they keep on top of things. It made it possible and doable. When my sons first started taking me out on the bike and trying to get me to do things, I was sort of almost taking it as a bit of a joke, really.
I must be complete stark raving.
He's agreed to it.
Okay.
If you could get prevention and rehabilitation right, we know that there's rapid improvements. It's the same as population level prevention strategies. It's rapid improvements.
I would never ever have contemplated even trying. The loss of feeling in my fingers and toes, I mean, that's your warning. You're getting that numbness. This is happening to my body. It's going to stop certain organs in my body from working.
Occasionally I see the penny drop patients.
This is absolutely glorious. It really is. Oh, it's fantastic to do.
They leave with more hope or a bit of a glint in their eye that, right, I know what I have to do now.
Right, we've got raw frittata for dinner because nobody can turn the cooker on. What have I done? Help, help.
It really isn't a sentence to a future dull life, believe me.
They go away and then they come back 4 months later and they've lost weight and the bloods look better and you say, see, you could do it. And I think that's something that's really motivational, is activating a patient.
I've got a far better life now than I ever had, and it's only through doing what we did and doing what the boys did for me and changing my lifestyle. In a very short time it became more than that. It became something that I knew was making my life better. I was going to do it, and my God, I'm so glad I did.
Hey! Yes!
You see the rapid changing, and during the documentary you see his energy levels go up, you see the weight coming off him, his mood goes up. The key message is that if you've got the right support, if you've got the right information, and you can make the right choices, you can revolutionise yourself. I think any human being could do that in that situation.
It's a truly shocking and horrible statistic, isn't it? 300 people will have died from a heart attack or stroke just in those 10 short minutes. but what you do today can make a difference. And as Dr. Scott Murray says in there, it's activating a patient that's so important. That film is obviously so personal to me for many reasons. Fixing Dad represents some of the best and most worthwhile years of my life, but the significance of that message just can't be understated. Dad, what is it you'd like to say to people who might be heading for these kinds of health problems like type 2 diabetes or cardiovascular disease?
Well, all I'd say is that look at that. It was 6 years ago this started for me, and believe me, at that time I was of that sort of attitude. There's no way that I was going to be able to do anything about it. I was at the lowest level in my life. Everything around me was falling apart, and I knew it was, but there's nothing I could do. It was just the way life was, and it was the way things were going to happen. But just realising now that just getting hold of these things, one thing at a time, you can get on top of it. You've got to take control. You need to be able to be in control. You've got to understand what's happening to your body. And I think that's what it is all about now. It's about monitoring yourself. It's about keeping an eye on what works for you. It's not all about just having a silly sort of diet, silly salad diet. It's got to be what works for you. And I think everybody I talk to now in the same situation, they see the film and they all say, well, I don't think I could do what you've done. And I tell them, yes, you can. It isn't what you're thinking. It really isn't. My life has totally turned around. I wouldn't be here now if it hadn't been for this. I know I wouldn't be. But I'm having the best time of my life, and I know I've got more years to go, more years to come. And I'd say to anybody, just get people around you. Get the people you need. Get your healthcare professionals to talk to you. Just make the effort and make a project of it. That's the biggest thing. You can tell yourself, this is going to work. I can do this. And it doesn't take very long before you see those results. They really do start coming through, and your life turns around completely. And that's what it's all about. It's getting hold of your life and controlling it. And you can do it.
Something we're always saying, because obviously Fixing Dad is now, it's become Fixing Us, because we work with so many people. And what we find is that when they start helping themselves, they start to help the people around them, and it has a knock-on effect through the whole family. But I mean, what would you say? We always said a key to this is what Scott said in the film there. It's about activating patients, and when you activate a patient, there is this great feeling for healthcare professionals. So it'd be a lot of healthcare professionals watching this. What would you say is the key to that? What would be your advice to a healthcare professional?
I think it would be to. You always say that you shouldn't scare a patient, but I honestly believe that you need to be told what the truth is. You need to know exactly what is happening to you, especially when you're diagnosed with diabetes. You've got to be told this isn't just about eating the sugar, which is what most people think. This is about what's happening to all your organs, what's happening to your heart, what's happening to your kidneys, your liver. Everything is being attacked by this thing. Just tell them, let them know, but let them know you can do something. It is manageable. You can get hold of it at any stage. You can get hold of this thing. And I realised just from seeing all the other people that we work with, that over a very short period of time, you can take control of this thing. And you just got to be got out there. We've got to let people know you can do this. With the right help, you can do it.
So what do you think was the moment when the switch flicked for you, to when you actually became engaged rather than just a passenger on the journey?
I don't know. I think initially when you started on the project and you started talking to me about going out on a bike and cycling 100 miles, it was all probably quite a joke, really. I couldn't, there's not a way in the world I was going to do anything like that. But I could see what it meant to you, and that made all the difference for me. It was having you behind me. It was getting all the information from the right people, and then realising that I was actually doing something myself to make a difference, and that this could totally change my life, and it has.
So obviously this is something that I know at the beginning you didn't know, all the things that type 2 diabetes could have led to. So what do you think? And I know you obviously realised the having the foot and the risk of amputation, that was a big risk there. But what do you think's changed now in your understanding of that? and you know, what has it done for you in terms of keeping you on this straight and narrow?
I think it made me realise that when I look back at that time, I was getting the indications. I was having all sorts of different things. There was the AF was there. I didn't know it was atrial fibrillation, but that was there, and I could feel it when I was in bed at night, and I could feel my heart sort of missing a beat, and I was getting tingling in my fingers and my toes, and I learned later on exactly what was causing it and why it was, but I didn't know at the time, and it didn't worry me particularly. It wasn't anything I thought I needed to do anything about. Shortness of breath, you know, I'd only have to sort of get up off the settee, and I'd feel as though I've done a day's work, and little things like that were obviously indications that I didn't really. It's obviously out there. I know I was being told by diabetes people by that time that, you know, this is what I've got to watch my diet and things like that, but you don't put it together yourself. You don't make the picture in your head of what this thing is doing to your body. And I think it's when you reach that point and you start to realise, I can do it now even. If I should actually eat something that's a bit high in sugar or something I shouldn't be eating, I do literally feel the tingling in my fingers even more. So straight away I've got an indication. And with the blood sugar monitoring as well, making sure you're watching exactly what this stuff is doing to you, you know what works for you. You can take control at that point and really change what you're doing. And it isn't about eating all the salads and everything else. You'll eat what you need to eat, and you'll enjoy your food.
Yeah. I think I mean, one of the real illustrations of that was when, you know, you, me, Andy, and we were all taking our blood sugars, weren't we? And we all had totally different spikes, totally different readings for different foods, for the same food rather. So it really is a personal thing, and at that point it becomes your own health, doesn't it? It becomes your own project.
Very much, because you understand.
So, I mean, yeah, exactly. And so so going over to Scott, so Dr. Scott Murray, consultant cardiologist, was in the film there, and Scott, you talked in the film there about, you know, actually lots of people come in and present exactly the same conditions as Jeff, and in fact they're very, very similar. So talk to us a bit about that and avoiding the path to heartbreak.
Yeah, thanks. Thanks, Auntie. It's basically like a conveyor belt in the clinic, because I just know more what I'm looking for now. I immediately go straight to the HbA1c or the glucose measurements we've got on file. Immediately go to the cholesterol and triglyceride and HDL results, and I immediately ask the patients, roughly what they weigh, because a lot of it is telephone conversations now. So in a way, I can have the conversation more freely by saying, I haven't seen you, but, how tall are you and how much do you weigh? So at that point, I already know, roughly what we're dealing with. But it is literally a conveyor belt of the same patients. They're breathless, and they've got diabetes, or they've been told, oh, you've got pre-diabetes, which I have to say is one of the, most annoying things that I come across is, oh, you've got pre-diabetes, we don't need to worry about you. We'll put you on the pre-diabetic register, not the diabetic register. And I'm just thinking to myself, one can of Coke and this person is diabetic that day. And the sheer fact that the HbA1c is a test of your mean blood sugar, your average blood sugar. So your blood sugar could be 10 for, 5 times a day. But your blood sugar could be 4, 6 times a day. And when you add all the 10s and the 4s up and you divide by the number of times it's gone up or down, you get maybe 6 or 7. And that's what your mean reading comes out. And it's, oh, you've got a bit of a touch of sugar. Whereas, every time you eat, your blood sugar's going to 10, 11, 12. And that's just, that swing out of range, those glycemic variabilities, as we call them, is not good for your internal physiology. It's trashing your vasculature. It's upsetting the endothelium. It's not letting your kidneys do the job properly. It's extra, calories and energy that you probably have got nowhere to put. So nowadays, I just say to people, you got to start with what's going in your mouth and what you're eating. And again, the same thing comes back. What do you have for breakfast? Oh, I have cereal or porridge. Okay. What do you have for lunch? Oh, I have a sandwich and some crisps. Okay. And what do you have for dinner? Oh, I have pasta with a sauce and, and then I'll have a pudding. And, human beings don't actually need to eat 3 times or 4 times a day and have snacks in between. We actually probably need, much less than that. And I think because you're hungry all the time, if you're in that paradigm and you're conditioned to eat in that way, you are just going to continue to eat that way.
So what do you think is the biggest barrier, and how do you actually get hold of patients on this and make them realise what needs to happen?
So what I use the David Unwin technique, which is I try to give them a bit of hope, and I try to say that if they can get control of it, then there's no reason why they can't take it forward. And I just say many people are reversing or putting their diabetes into remission now, and that will have multiple implications for your blood pressure, for your heart arteries, for your kidneys. All of these things are going to benefit. So I tend to say to them, have a think about what you're eating, and before you eat it, think, is this going to digest down into sugar or a glucose in my body, and is this going to potentially spike my blood sugar? And the things that aren't going to do that tend to be your sort of real, they say real foods in inverted commas, but foods that are high in protein and healthy fats. That's not going to spike your blood sugar, but it's going to satiate you and it's going to make you feel like you've had some decent food. And it probably contains more of the nutrients and vitamins and micronutrients that you need than so-called foodstuffs like croissants and bagels and buns and biscuits and, breakfast cereals, which are, let's face it, fortified for a reason. And so I start with baby steps with them and say, well, why don't you just change what you have for breakfast and, maybe have some scrambled eggs and see how you get on and test your blood sugar. And then you might not need to inject your insulin if it's not gone too high. And then maybe move to the next meal and then say, well, what are you going to have then? Maybe if you had some chicken on its own with some, cucumber or salad or something green, then again, your blood sugar might not rise. And I think that's just getting that information across. You can eat things that will still be tasty without, it having to be with bread. Because a lot of patients are eating half a loaf or a loaf of bread a day, and you're like, this is not going to end well.
And how much of this is the kind of support network at home, the person that's doing the shopping, those things? How influential is that in your book?
Very, because if it's there or it's in the cupboard, it will get eaten. So if someone has a treat drawer, or there's a little cubby hole for crisps or chocolate or treats or whatever, it happens in our house. You see people opening cupboards looking for a random jar of Nutella that might have a scraping of the internal contents left that someone can spoon out. So I think it's about being mindful of when you're shopping, right? I'm only going to get stuff in that's, protein, healthy fat, nutrient dense, and trying to do that on a budget can be difficult, but it's not impossible. You can get excellent cuts of, chicken and fish and meat if you're that way inclined, that you can cook and slice up and freeze and do all sorts of things with. So I think it's about being mindful that if someone gets a 10 packet of Kit Kats in, then they're going to be there and they're going to be eaten.
Yeah. Now you've sort of set out, I guess, haven't you, as a preventive cardiologist? Would you say that? Is that fair to say? Do you think there's sort of different approaches in your work?
Yeah, I mean, I think I just got a bit fed up seeing the endless conveyor belt of people coming in needing stents put in the middle of the night. And when you actually take time to speak to the patients after the procedure, you find out that they don't drink water; they just drink full fat Coke. And they're living on chicken nuggets and crisps and things like that. It's interesting when you start delving into the root cause, but often it's not just food; it's the stress, the social environment, there's poverty, smoking. There's lots of facets to this. I mean, we tend to focus on the diet, but the diet is really just one thing that you can action along with other preventable risks. But I just got fed up seeing that and decided, and also got fed up getting up at 4 a.m. with a young family. So I think it was a change in my mindset, and I was just about to take on a role with prevention and rehabilitation in a national role. So that's when I changed tack and have been focusing on that ever since.
Yeah, so I mean, it's interesting what you're saying as well about the the people in the house or the caregivers, in terms of how they become so instrumental. I mean, obviously our story was a sort of extreme version of that, because we gave our dad complete, care, if you like, for a long period. Having said that, we weren't in his life quite as much as the film suggested. It was more of a couple of times a week, and phone calls and things like that, but just sort of tracking how you were doing, wasn't it, and looking at the blood sugars and looking at your cholesterol and all that stuff. And Graham, it's probably a good place to bring you in. So Graham Addison from AstraZeneca, just in terms of why you decided to support this project, the Fixing Dad, the cardiologist perspective.
Yeah, thanks, Anthony. First of all, I would just like to say it has been an absolute privilege to be able to work with Jeff, with you, over the course of this project, and of course on previous projects, and yourself, Anthony and Ian. And you really are an inspiration. And I say that very genuinely. Personally, I've seen that, through our organisation, and of course out with that in a public setting. So that's the first thing. I think secondly, I would say that the reason I wanted to get involved in the project is that knowing, the backstory, I guess, with Fixing Dad and the original story, and certainly within my role, we're very much focusing on the cardiovascular therapy area, and the thing that was missing for me out of that story was I guess the narrative. That Scott so eloquently added to it. What does this actually mean from a cardiologist's perspective? And it really highlights. You don't need to dig too deeply into the numbers. Unfortunately, we're living in a world where 18 million people die every year from cardiovascular disease, and 85% of that will be attributed to heart attacks or strokes. So there's certainly a role there for us to play in raising awareness, of course, in relation to that, and the unmet need, but of course not just raising awareness, ensuring that we all work together to do something about it and to support patients to achieve the best possible outcome. So for me personally on the project, I had two jobs to do in relation with the film. Our organisation, as you can imagine, is rather large. I think in my last count there was about 74,000 employees across the organisation, and I had a job to do to, I guess, inspire, motivate, and engage the organisation behind, the unmet need, if you like. And as you would expect with an organisation so large, not everybody knows everything that's been worked on. So the ability to utilise, a really inspirational and emotional story like that really helps us to unite, I guess, and come together behind a common cause. And then secondly is actually be able to which is really the really exciting part for me, is to be able to get that out there into the public domain, and share it equally with healthcare professionals and members of the public. And I think importantly for me, especially considering what we've just been through, all of us have just been through in the past year, it's critical, that people still talk to their healthcare professionals. And I know that we've seen a real impact in that across many countries, in relation to admissions to A&E, for example, or admissions to hospitals in a secondary care setting. People just weren't turning up, in the first part of this year, certainly, which had a huge impact on health outcomes. And I guess, for me, it really does, put the onus on the patient, as well as inspiring, informing, and motivating them. I'm a very firm believer that emotion leads to action, and that is definitely something that I hope you get a sense of when you watch the film. Really, it really is emotive, and that comes down to the beautiful way that you tell the story.
I think this is it in terms of the engagement. We always said that there had to be a sort of balance between hope and fear, I guess, and it's the same right the way from diagnosis of a condition right the way through to. But I think you often see, in the way it gets dealt with, even if you just Google the term, type 2 diabetes, or cardiovascular disease, you get all sorts of, pretty negative stuff. But if you look at actual success stories, or you look at reversing or improving type 2 diabetes, you get a totally different. So it's all about what you're looking for, and the backdrop, I guess, with what we saw even in the healthcare profession, Dad. The different ways different doctors talk to you about it. It was such a sort of disparity. So it's trying to get, I guess it's trying to, unify and through that emotion just sort of show that there is something we can all unite in, and it is that hope that there is, you can improve things. It doesn't have to go down that way inevitably. I think that comes across in the cardiologist's perspective, definitely.
Very true what you said. There's so many different healthcare professionals out there that deal with things in different ways, and it is a case of finding one that really understands the way it works for you. That's the thing. We're all different. A lot of the people I speak to that suffer with this, and they've seen the film and they love what we did, but they couldn't see themselves doing it. It's because they haven't got that support. We had to change their doctor. At that time, it was a totally negative attitude that I was getting with regard to it. I'm not saying it's their fault, it's my attitude as well. I was willing to accept everything they were telling me and just going away and getting on with it and then just carrying on. But I think there's a lot of people out there that aren't willing to give you as a patient the opportunity of explaining what's happening, or explain to you what's happening, and that there are things you can do about it.
And it was interesting. I think this is where just the process of making the film came in, and we didn't realise it was going to have that impact. But because we were coming along to your GP appointments with you, we were actually saying, you were accepting stuff, and we were saying, no, hang on, don't understand that. Why can't this happen, or why can't that happen? So we got a referral to a cardiologist. It was a private appointment in the end we had to get, but we managed to do that. So we got that sort of perspective, and then there was the whole. The blood sugar monitoring, so they weren't even going to probably, potentially continue your blood strips, but instead of that, we started you on constant monitoring, and so that, it just changed everything, I think. And it makes you wonder if everybody had that sort of healthcare advice behind them, or they could be that proactive, then you probably have very different outcomes, because people would be seeing the right specialists and would be, able to take the right steps themselves as well.
Yeah, because most of the people I do speak to, they literally their doctor is God. They told them they've got to do something, and that's it. You don't question it. There's no sort of reason to ask. My mum was a typical example. The doctors told me I've got to be on this, so that's what I'm going to do. I'm going to take those pills, but never to look at why she had been put on those pills in the first place. What had caused her to be in that position? And this is what everybody or a lot of the people I talk to seem to think. They think, oh no, I'm being looked after, it's under control, but they don't ask why. Why are they in that position? And that's what's wrong. I think it needs to be this discussion with the healthcare professionals to say, how can I change this? Is there something we can do or I can do to change this myself? And that needs to be got across at the doctor's appointment, basically.
What you've just described there is something called life stage segmentation, which is a thing that was actually a big document released by the Department of Health on this, and you've described the difference between being a health conscious realist, i.e. you can understand health terms and what you need to do in order to keep your health going forward, and an unconfident fatalist, which is the majority of the population in Northern England, in certain areas, they just don't have health literacy, and they don't question anything to do with the health, and health is quite low down on their priority. Now, if anything, the COVID pandemic has maybe upped health in some people's priorities above, we'll never be above football and, sport and things like that. But certainly, actually being able to think about your health and how you keep your health or improve your health is something which we need to start probably educating primordially, which is in schools and in secondary schools, about how do you maintain your metabolic health going forward. But that's a whole other conversation.
What's your advice, Scott, to primary healthcare professionals in terms of, how do you use a very short appointment slot? I think in the UK it's 8 minutes. What would be your advice in terms of how to use that best?
Well, I mean, I think if it's related to someone's, general metabolic health, cardiovascular health, you've got to take the blood pressure and, maybe dip the urine and look at the blood results in terms of the HbA1c, and the fasting glucose is a very good measure, because if you've got fasting dysglycemia, then you're on a slippery slope already, even though your HbA1c may be normal. If you've got microalbuminuria in your dipstick, or you've got sugar, then you already know that the kidney's not the kidney's struggling to deal with what's been thrown at it. Can go into that a bit in the presentation, but I think it's about saying, look, this is real. This is going to cause long-term issues. You're on the path towards heart attack, kidney failure, liver disease, amputations. The way to act is to really cut back on what's going into the fuel tank and empty out what's in the general super tanker to give some space. Because we know that the problems come when you are glucotoxic and lipotoxic, and what that means is your body's got nowhere and no ability to get rid of the excess sugar in the bloodstream, and it's struggling to store fat. So fat is leaking back out of your fat cells into the blood, and that's got to be put somewhere. So your body has got a storage problem, you're energy toxic. So if you start saying to people, your sugar bowl's full, your energy bowl's full, you need to cut back on energy, you need to cut back on sugar and starch and general your calorie intake, and that you need to start eating as healthily as you possibly can in order to reverse this. And there'll be a whole myriad of benefits that will come by doing that. Your blood pressure will improve, your kidneys will be healthier, etc., etc. So I think, it's got to be hard hitting though, because if you just say, oh, you got a bit of touch of pre-diabetes, a bit of sugar, off you go, don't worry about it, because I think that people in the UK, we don't want to upset patients. We don't want them going away worrying that, because that can be a difficult thing. But I think you do need to, I say it in the movie, I think you do have to make people worry for them to take action. Emotion causes, and what was it you said? Emotion causes action. That's quite a good term.
Yeah, absolutely. So do you want to, it's probably a good idea, actually, probably leads into your presentation quite well there, doesn't it?
Yeah. Okay, great. So this is the Preventing the Path to Heartbreak. I've called this talk just because heartbreak in the personal sense of the word is normally related to, someone you love or something that's happened. But the heartbreak that I see day in, day out is because people's hearts are either failing or having a serious issue. So I'm going to jump straight in. This is a slide from work I did with Liverpool City Council about why people die from cardiovascular disease. And you can see on this chart, it's taken from the Global Burden of Disease study in 2016, but this is Northwest England. And you can see that high blood pressure, dietary risks, high total cholesterol, body mass index, tobacco and glucose with low physical activity are the main things that we can have an impact on in our own lives, which could lead us to die from cardiovascular disease. So why does this happen? what I see a lot of is people say they've got a family history of heart disease, and that can be a genetic, primarily a genetic thing. But I do see a lot of environmental family cues and habits that have crept in as to how people believe that they should act, and what they should be doing with their life. And sadly, the majority of it is preventable. In 2004, Salim Yusuf released a study called InterHeart, and it was a groundbreaking study, but it was ignored in some parts of the medical world. But it did point to the fact that there are 9 risk factors which are accountable for greater than 90% of the population attributable risk of heart attack. MI is heart attack in these slides. And you can see there that it boils down to the same things. It's diet, obesity, diabetes, blood lipids, lack of exercise, smoking, high blood pressure, excess alcohol. And this is genuinely 80% preventable. If we look at the next slide, this shows that the main risk was driven by this lipid marker. And it says here ApoB over ApoA1. And what that means is all the bad lipoproteins, so all the bad carriers of cholesterol in the blood, divided by all the good carriers of cholesterol, all the type of lipoproteins that are able to regenerate or take bad cholesterol out of arteries and places it shouldn't be, was the highest risk. Not total cholesterol. This is a different metric, but this is how we got into the paradigm of thinking that cholesterol was exceptionally important. And you can see on this chart that as the ApoB over ApoA1 ratio rises, the risk of a heart attack rises, and it's almost linear. So I wanted to drop in the fact that many people I see have the phenotype and bloods which show that they are very likely to be insulin resistant with high levels of insulin, so hyperinsulinemia. And you can see from these two tables that if you look at this between people who are genuinely sensitive to insulin and metabolically healthy versus people who are resistant to insulin and requiring a lot of insulin to deal with what they're hitting their body with, there are huge differences in the blood lipids, including ApoB, HDL, LDL, which are different types of cholesterol carrying lipoproteins, and they've got huge differences in their blood pressure and their insulin, and it's the same across men and women. And we see that as this ApoB1 over ApoA1 ratio rises, the risk of, not only the risk of heart disease rises, but it is a marker that you are insulin resistant. And control of cardiovascular risk factors that I've just spoken about is very rarely achieved. If you look here, the average in obesity, people achieving a BMI and a waist circumference goal is actually 3%. So we've got a lot of work to do here, and it's probably because people are not getting the right advice. This is hyperinsulinemia that is causing all of these risk factors. And we know that hyperinsulinemia is an independent risk factor for heart disease. We've known that since the mid-90s. So moving on, here's quite a provocative slide of a healthy heart on the left-hand side and a very unhealthy heart on the right-hand side. Now, I say this is a healthy heart, but it's on the slab, so it's not technically healthy. It was taken out of someone who did not die of heart disease. But you see the heart on the right with lots of lipid and fat attached to it, and that is an unhealthy heart surrounded by what we call visceral fat. This is a patient of mine who agreed to have his photo taken. He was breathless, and you can see his tummy here, and that tummy was quite hard, indicating that his fat cells were pretty filled up, and he'd maxed out his subcutaneous fat threshold, so he'd stored enough. And when we did his echo report, it showed that there was a global layer of fat around his heart, and his heart was struggling to relax. This is called diastolic dysfunction, where the heart pumps okay, but it doesn't relax well, and we're seeing more of this. And if you looked at this chap's CT scan, I've drawn arrows here, but you can see there's a huge amount of fat around his heart. His heart's in the middle here with the contrast in it, but where the arrows are pointing to is just fat, which is encasing his heart and preventing it from relaxing. And in fact, he already had the start of coronary artery disease seen on these cross sections of his left mainstem coronary artery. with some calcification on the top, he's already started narrowing the most important blood vessel to his heart. So in this setting, we need to tell people to stop eating poor choices of food, so carbonated drinks, refined sugars, artificial foods, or processed foods. I call that crap, and you know, the slide has got some evidence of that on there. But we should also stop endorsing that, you know, nationally with regard to bans on food advertising and the way that these things are thrust upon us. The next slide is a pretty poignant one that might take some time to go over, but if you combine positive calorific balance and unhealthy nutrition with a sedentary lifestyle and genetic predispositions as well as environmental predispositions, you start a very difficult cascade, which is summarized in these slides, where you get impaired fat cell health, basically. You max out the fat cell ability in your subcutaneous elements, and you don't know what your fat cell capability is. Nobody does. But very likely that those fat cell tissues become unable to accept more energy. So there's no more room at the fat cell motel. And that tends to lead to a whole host of issues with regard to your body becoming inflamed and generally fat starting to lay down on your organs, so your liver, your heart, your pancreas, your guts, your kidneys. It's very, very pathogenic, and ultimately it leads to your arteries becoming narrowed and the onset of heart disease. If we look at the next slide, this is an excellent infographic taken from Stahl EP and Journal American College of Cardiology, showing what happens when someone has fatty liver disease and how that increases the risk of cardiovascular disease. Now, if you've seen any of the Fixing Dad or Fixing Us programs, you'll see that people are actively trying to reduce the fat in their liver, and that this is possible with diet and exercise. And if you take a moment to look at what happens in the body when you're starting to lay down visceral fat, it is basically a cascade or a slide towards metabolic disharmony, inflammation, and both cardiovascular, liver, and renal disease. If you get to that point where you're laying down fat on your heart, you are lining the heart with inflammation. That's the basic tenet here, and it's the inflammation that causes the reaction within the blood vessels that leads to them thickening and becoming inflamed themselves, and that's what leads to the narrowing, which ultimately will lead to potentially a heart attack if that narrowing becomes unstable. And that's why people need stents and bypasses to bail them out, and that's on this slide, saying that we tend to pick up the patients at that point where they need something doing, but we could have had an impact way back earlier in the process, maybe 20 years earlier in some cases, where education and lifestyle interventions could have prevented this from happening. And this is a schematic diagram of what's happening inside a coronary artery, where the perivascular adipose tissue would normally keep the vessel healthy, and the vessel would keep the adipose tissue healthy. But we get into a situation where everything is in mayhem and the artery is building up a narrowing, and then we get the heart attacks. So I would say that in trying to prevent the path to causing heart disease, or heartbreak as we've called it, you first have to tackle the fact that you may be becoming insulin resistant or hyperinsulinemic. And how do we get you out of that situation? Well, we get you out of that by recognising that you've got a waist circumference to height issue, that you may be becoming over fat. And how do you minimise insulin resistance? Well, you maximise the nutrient density of your food. You minimise the glycemic impact of your food. You keep the insulin levels pulsatile by avoiding snacking and consolidating your calories into larger and frequent meals. And you do high intensity exercise where possible. So obviously, Jeff took up cycling. If we look at patients who've had coronary artery disease, we know that when they pitch up for the rehabilitation, that actually only less than a third have normal blood sugar. And the rest may have thought, 1/3 may have come in saying they were diabetic, but we find roughly another third who are diabetic but didn't know about it. So in total, there are 72% of those patients who have what we'd call dysglycemia. And all it takes to change that paradigm is to give people good advice about the food they eat. You see here a slide showing someone monitoring their subcutaneous blood glucose levels with a Freestyle Libre, and you can see that within the space of 14 days, someone goes from having no time in target range and spending a lot of time with high blood glucose to having 100% time in range. And that only took 2 weeks with a Freestyle Libre to basically look at what foods they're consuming and nail their blood sugar down to the floor. So as I finish up, I would just say that improvements in cardiometabolic risk factors can be induced by regular exercise, and it has to be a combination of both in many cases to get the maximum benefit. And this is only moderate intensity exercise on as many days of the week as you can manage, and it's about taking baby steps. So I'll finish up with my alliteration, where I say, set Scotty's several sins, sending sickness sometime soon. So sugar, sugar-sweetened beverages, smoking, saturated fat from processed sources, sitting, sedentation, sarcopenia, which is low muscle mass, slothliness, no regular exercise, sick fat that we've discussed, substantial starch and cereal intake, sandwich subculture, snacking, salad dodging for the Glaswegians amongst us, stress, sleep deprivation, sexual dysfunction. Many people don't know, but erectile dysfunction predates a heart attack by 3 years. So if this is happening, it's time to take action. Being alone and having depression, so solitude, sadness, and suffering also contributes to cardiovascular disease. So in summary, I think it's clear that we can take action here. We want to increase people's health span because people are living longer, but we don't want them living with disease. So I'm really grateful that Fixing Dad and AstraZeneca and Jeff and the boys have led the way to show how you can take action and how you can take back control of your health. So thanks very much.
Thank you, Scott, and I want to thank you as well for your involvement. It's been fantastic. I know on more than one of our projects, but I think it really has brought this one to life. And I want to echo that, Graham, as well, just to thank you for making this possible, because we had obviously Fixing Dad, but this really threw another angle on it, and I think a lot more weight to the whole, the medical side of it, really, and just what the significance of it was. Everyone talks about how it was inspiring, but I don't think really everyone knew, just what Dad was avoiding by by doing all this. So it was. We talked a lot about the foot, but there were a lot of other organs in there that we hadn't really even, really thought about. I think in the back of our minds, obviously, we know these things are there, but this really has brought it to life. So thank you all.
No, more than welcome. And it's not just you, Anthony. I mean, we live and breathe this every day. As Scott will, and even last year, I know I mentioned that statistic earlier on of 18 million people per year. That when you take that 18 million deaths, per year, but when you take that into account, it's actually higher than all other causes of death combined. And I think in relative terms, the next to that is cancer and then road accidents. So it's a huge problem, and even for us at that, even when you look at it in that way, it was even a shock to us to realise actually the significance and the size of the problem at hand.
I think that's it, and I think obviously at this particular time, obviously. There's so much going on, and people are often locked away and not able to do or be in the places they want to be. But a lot of people have said to us it's been quite a good time to focus on their health. So when we've actually worked with people, I guess that could be a positive thing that could come out of this if people chose to set a project for their health and just try and really focus. Because I think sometimes the stresses of work and being out and about, rushing around, it can make it even harder.
Yeah, I honestly think Scott's statement at the beginning of the film about that health is wealth just about sums it up for everybody, especially at the moment. I think everybody's looking at their health now. Everybody's realising they've had this great, terrible thing that's happening around, all around the world, and that if you haven't got that health, you've got nothing. You might as well give up now. And at the end of the day, I think that's the sort of message we need to get across. This is something that if you lose the health, you've got nothing. So you can start from a very early point. Any diagnosis of anything, just be aware that you can do something, and you are responsible. Only you.
Yeah, you didn't have that attitude right at the beginning, though, did you?
Oh, absolutely not. Absolutely not. But I want to scream at people now. I really do. Everybody I meet, I just want to get across that you are the person that can control this one way or the other. With the help of everybody around you, you can do it.
Brilliant. Probably a good place to finish. Thanks very much. Thanks everybody. Really appreciate your time. With increasing trends towards chronic ill health, there's a growing need to refocus and reprioritise our metabolic health as a key to wellness. Amita Harani from Berkshire has suffered a lot of ill health both personally and in her family. Having overcome breast cancer and supported her husband through MRSA in a short space of time, Amita was diagnosed with type 2 diabetes. This diagnosis was the final straw. Amita was prescribed medication but felt unsupported by her doctor at the time. She knew it was time to take control of her own condition in any way she could, and she set out to do this with the help of her husband. In 2018, Fixing Us partnered with AstraZeneca to assist in the journeys of 3 patients with type 2 diabetes, including Amita. Fast forward a year, and she's reversed her diabetes. In this session, we'll be speaking to Amita about her journey. We'll also be hearing from one of the doctors involved in the collaboration, Dr. Michael Baslington, NHS doctor and founder of the Body Mapping Clinic. We'll be discussing how to effectively engage patients with their metabolic health and how to optimise our time with patients to empower them on their journey.
I was quite embarrassed by having type 2 diabetes. Like, why couldn't I have controlled it better? It was almost a reflection of the way I was living. It's like a numbness. You walk around almost quite numb of what's next. It doesn't leave you. It's just there all the time. So I find it's a constant reminder that I am a type 2 diabetic.
I knew I wanted to be a nurse from a really, really young age. My mum, unfortunately, was diagnosed with cancer when I was 8, and she was cared for at home by a really, really lovely nurse who I absolutely adored because she cared not just for my mum but the whole family, and I really wanted to be her. I really wanted to be that district nurse, so that's what took me into nursing. So from age 8, I knew that's where I was going to be.
I wouldn't even go to the doctors for it, because I don't feel that they actually are there to support me in that respect. It was just, that's the way it's going to be. I don't think there was any hope. The hope was only from myself of saying, how am I going to change things?
If I'm at the same point as you, we're both going to go into that fridge and look at healthier options.
You're not the same point as me because you can cook and you can open the fridge and make a dish out, right? I can't do that.
I think that's what families have to do. They have to embrace the changes in the diet, that it's actually for all of them, because just cooking for one person isolates what is actually food as a social occasion.
There is life beyond rice and chapatis, BP. There is definitely life beyond that.
I didn't say there isn't.
But you've just exampled an Indian meal, and that's not the way.
Because that's what I can cook.
Yes, well then, that's what I'm saying. Let's learn together how to cook other things.
All right, we'll learn. Yeah. Over time, I will learn, right?
I always have in the back of my mind, what's their story? What's led to them being where they are now? And that's often the first point into them changing that round.
The things that I've gone through in terms of having breast cancer, and having treatment, and my husband being ill, I think has been extremely hard. It was almost the last thing that took me down was the diabetes.
Where your HbA1c is, it's actually relatively low on the spectrum.
It's strange. Type 2 diabetic in the family has never been about us. It's always been about me. It's always been mum's got a problem with it. And the project has really helped me to identify that actually it's not about just me, it's about us.
My parents both had diabetes, type 2. My cousins have got it. My siblings, a couple of them have got it. Why is it that we've had it in the family for so long without anyone talking about it? I think it's just one of those things that we've all just said, oh well, we got it.
You have a lot of cooking experience.
Yes, cooking, but
So
I
how
don't
can you
cook
say
the
we are
right
level?
things. Making healthier choices,
But
BP. So we're level in the same.
50% of your cooking experience is
Yes, but-
applies to this situation.
But all I'm trying to say is let's learn together.
I think people underestimate how much support individuals or people with diabetes need, especially when they're making big changes really in terms of their diet.
Having family members in India that haven't controlled it and watching them deteriorate over years of visiting them has made me quite aware of it.
Our challenge over the years is that patients with diabetes have been given blood glucose meters and test strips and then been ill-advised about when to monitor.
I don't think I'm quite connected to what my readings show because they're my only indicators as to how I'm doing with my diet.
When it's taught in a way that patients can make sense of the results, then I think it's really helpful. As you've been learning what foods are influencing your blood sugar levels, so the next 3 days, if you look at all of those results,
yes,
there is only one that's outside of normal range.
I think I should also look at a little bit of my diet to help you through this.
He did actually commit himself to helping and supporting me more with maybe just cooking.
I think we will get to a point with her where she'll actually be able to go out and enjoy her food and that she feels able to have those conversations with her family and her friends to say, look, I'm doing this for me, I want to prevent the long-term complications of diabetes and I'm doing what's right for me.
Definitely at the early days, I don't think I'm nowhere near understanding my food intake and things, but I think monitoring it has really helped.
I think the results are staggering in a very short
Really?
space of time.
Yeah.
We can see a huge difference, I think, from your first 4 days to actually where we're at now.
Now, yes, I think that's
So
made
that-
a huge difference,
yeah.
you're right. Ultimately, if this doesn't reverse BP, there is going to be nobody in the kitchen.
I wish it was easier. We are still two separate individuals.
I'd like us to just think about what it is we signed up to and actually me listen to him more. What is it that he's struggling with?
It's a partnership, you work together, you train together, you have the same level of fitness.
That external support,
It's probably
you'll
not needed
need
as
less and
much.
less.
I think everybody should have a shake of something in their lives just to halt them in their tracks, to make them realise that there is only one shot at this and only you have control of this and you make it the best you possibly can.
We need to come together in the kitchen, I think, more than anything else. Yeah.
What I love about that film is in Amita's story, everything sort of really focuses around communication in a relationship. And so obviously Amita's relationship with her husband BP and her relationship with Lorraine, the healthcare professional. And we found with our dad as well, that there were so many ways in which communication was important, where it was lacking, particularly in the way the doctors had spoken to him right at the beginning, and the way he was very sort of disempowered in terms of his health. And I think he never really attached much value to his metabolic health. And so this is something we've seen across, other people's stories as well, including Amita's, but it's a really good example where family members, doctors, nurses can really struggle to connect with the person, or maybe sometimes think they have connected, but they'll go away and don't do the things that they've asked them to do. So I'm going to introduce Amita. And Amita, what are your thoughts on that? Because I know obviously in the film it's quite obvious, there are lots of little arguments and niggles, but what are your thoughts on communication, and where do you think that sort of went wrong at the beginning?
I think it was very much my thing. I think it was all very much like, yeah, you know what you need to do, so just get on with it. And I'm giving you the support because I'm just saying yes, yes all the time, but not really taking on board what needed to change. I think it was, although he felt he was supporting me, it felt very much like it was my thing to sort out, not his, coming along with me. And I think when I shared things, he would say yes at the right time, he would nod at the right time, but not sure he took it all on board as to how much it was going to impact him. So I think very simple things like just going out for a quick lunch while we were out or something, I'd be looking ahead all the time and I'd look at the menu, I'd make sure that I've got something to eat on it. Things that I would just give a bit more thought to, he wouldn't give that thought at all. And then he'd be very quick at saying, of course you can eat something there. And I'd be like, well, actually, I can't.
Do you think there's a way that, for obviously mostly it'd be healthcare professionals watching today, so how do you think that can be improved? Is there a way that can be improved and to really sort of integrate families and friendships more into these journeys?
Yeah, I think what might even help is perhaps in terms of the people involved, like Lorraine and I were actually chatting with BP there. That made a massive difference, BP actually being present. So he would pick up a little bit more from her as opposed to me, although she's saying the same thing. It just came from someone else. And I used to feel that dropped a lot better. So maybe almost like, I don't know, a family group session, a drop-in thing where BP had definitely bought into it, but it would have been good for him to sit around with the health profession actually explaining it to him as well.
What's interesting with your story as well is obviously having had breast cancer previously. Do you think that sort of made the diabetes less of an important thing in a way in the eyes of other people?
I think there were a lot of things, Anthony, that played a massive part of our position in particular, because I think when I was borderline diabetic, it was on the other side of being a breast cancer. I was always told that I was borderline, and at some point when I hit about mid-40s, I would hit it. So I was quite aware of it myself, and BP was as well. But then, like you say, as soon as I got my breast cancer, nothing could top that. It was almost like, God, you've got that, so this is just a little thing we can deal with. And it was almost like it was pushed aside. It was like, you've overcome so much. But that's what happened even with the health professions, which I felt was very much like that. It felt like every time I went in back to entertain the idea that if my HbC is at the lower end, what am I doing? What could I be doing to try and bring it down completely? It was almost like they didn't want to entertain it. It was like, Mrs. Hirani, you've been through a lot. And I thought, well, yes, I know that. But now how can I get rid of this?
Michael was one of the doctors that was really involved in this. And Michael, it'd probably be good just for you to have just to hear your side of things in terms of creating that sort of healthy lifestyle for the long term. And how do we sort of communicate the value of metabolic health? Just be interested to hear your side on and your thoughts on Amita's story.
Yeah, hi Amita. It's nice to see you.
Hi, Michael. Thank you.
You're looking really well. I'm sorry it's not in person, but I guess this is a good substitute. So
yes, it is.
yeah, no, I really enjoyed your film, and huge congratulations for all the effort you've put in. And I just had a picture actually of as you were talking about having just watched the films and yourself talking about that sort of relationship with BP. I had this picture of you sort of being a rally car driver and sort of. And BP's in the back seat and, loving the ride and having a lot of fun. And you're saying, look, BP, I need a navigator. You need to be sitting next to me and reading me the route. And every time these corners come up, you need to be kind of pointing me around them. And he's just off, staring out the window and imagining his next game of golf. And I just, so I think as a patient, you clearly are in the driving seat. And that to me as a healthcare practitioner, that is, so encouraging when we see that. Because I think when we do see that, we see huge leaps forward, and so you're in the right place from the outset. I think what can be more challenging is when the patient with the condition sits in the passenger seat and the family member brings them along and they seem to be driving. That brings up different challenges. So I think your particular situation is probably, I think in my personal experience, tends to have the better outcomes. So, I think you're doing all the right things, trying to get BP to understand that, you need a co-driver, you need a navigator. And I think that perhaps the other, in terms of sort of communicating that metabolic health, how, the value of that. What's interesting is, and perhaps a question for you, Amita, is did anyone sort of at any point kind of connect the cancer and the diabetes? I know, Anthony, when you were going through the initial work with your dad, it turned out I think that he had a renal cancer. Is that right?
That's right. He did. Yeah.
Yeah. So there we've got two people with diabetes, both with cancer, and I think there's definitely an association there. I think we're not implying causation, but did any health professionals kind of say, did they make connections or draw, and see your health as a sort of holistic thing?
No, they didn't actually, which is really quite bizarre because I think it definitely crossed my mind. It didn't cross theirs. And their question, strangely enough, when I went and had my very first appointment and consultation with my oncologist, the first thing he said was, you're a borderline diabetic. You do realize, type 2, you do realize that once you have your first session of chemo, you will go into full-blown diabetes. And I said, and I must be honest, at that time, I probably was no different to any other health profession, where I just said, well, like, what else are you going to throw me? I've had everything else. So yeah, okay. But I almost felt like, let me deal with one thing and then I'll deal with that later, because I didn't have control over it. But nobody actually spoke to me about that, Michael. So that's interesting that nobody spoke to me, but it definitely crossed my mind.
Because I think sometimes, when people are dealing with the diet, we talked a little bit with Rob about what the meaning of the diagnosis was to him and how it was just such a blow, and actually coming to terms with that sort of label, if you like, and trying to move out from the label. And I think, sometimes what you had is potentially two labels, isn't it? Pre-diabetic and cancer. And I do wonder whether we, as health professionals and as a system, could actually take a step back and say, actually, there's two things going on, but maybe the solution for both of them is common. And actually, there isn't double the work to do. It's actually, there's half the work to do. We can put you on, help you sort of, you're obviously a very motivated person. You want to be healthy. So perhaps with a few pointers, we can point you in the right direction, and that will help. The same work you've got to do on diet and nutrition will actually point you in the same the same improved outcomes for your diabetes and for your cancer. So, I mean, do you think, Amita, that that would have helped at that time to understand that actually, just because there were two diagnoses, there wasn't necessarily two different approaches? Do you think that would have been
absolutely? I think
I
think one thing that came across a lot, Michael, was how they were quite disconnected. So the oncologist wasn't very connected to my doctors. So it was very much me driving that side of it. I know I feel like I'm always pushing people, but I really want people to be connected if they're looking after me. And it was always like, so has the report made it back to my doctors? Have you got this? And now do you have this? And it was me keeping an eye on my diabetes, not them telling me that I should be watching it. It was just that that was the only first hint I was given. So I felt there was a lot of disconnection. It was very much like I was being looked after by a breast cancer unit that was getting the odd letter maybe every 2 to 3 months from the oncologist, but very much a summary, not of what they'd discovered. That was dealt with as and when I had my chemo. But so that kind of disconnection and really nobody really supporting you through it all, Michael. It was very much like, you're on this road now let's just get this done, and that's one box ticked, and then let's just leave you out there because you are so lucky to be here. I think initially, in Lorraine's defense as well, was she didn't know how to deal with me. She really didn't know how to deal with somebody that has got a vegetarian diet.
That was a big thing, because whenever we talked about food and stuff, she was probably on like, Amita, we need to just test it. And I was like, well, how different is that to what I'm doing already? So I felt very much like, okay, but we were doing it together. That was the difference. Although she wasn't aware of it, what was good about it was I was being able to go back to her and say, oh, that didn't quite work. I got a spike there. I wonder whether this would work. And then it was about us trying to change the recipe or do something to see where I was getting the spikes. Yeah. But it was very much us learning together. Yeah. Chickpeas being one of them. And chapati flour is another one. It was like, put a bit of almond flour in and see if that works. Well, actually that worked. I'd never considered putting almond flour into our chapatis because it's a very, I don't know what the right word is, but it's quite a dense flour. So I didn't know what else I could have put into atta, which is the chapati flour. But it was those kind of conversations. So I think it felt very much like Lorraine was listening, and having her there at a phone call away or an email away was just really good.
I remember one of the things was it was kind of giving you those little projects to do. So I remember with the blood sugar monitoring, you were kind of testing it after. I remember you kept cherry tomatoes in the car and things like that, and you were trying that, and even they were causing spikes. And then like you say, the chickpeas were a big thing, weren't they? Because you were eating those quite a lot. And I think then it was the language. So one of the things, when AstraZeneca commissioned these films, one of the things they were really interested in was the language that's being used by healthcare professionals and how much of an impact that can have, especially in such short consultation times. And I think you were quite sort of encouraged by some of the responses you got from Lorraine. Like once things started to improve, then it was it was that positivity of finding the positives as opposed to just looking at you still haven't hit your your sugar numbers. They were starting to come down. It was sort of acknowledging that and recognizing it.
It just felt like I was doing it for so long. That's the other thing, Michael. It felt like I'd really cut back on so much, but I wasn't getting the rewards at the bloods. And I think Lorraine was the one that kept me on track. Whereas I think if she hadn't really touched base with me, I could have easily have gone back into, is this really working? And the support, I think, in fairness, I didn't have my GP support me right at the beginning, but at the about 6 months in, and he started seeing the HbCA1 going down, he said to me, Amita, we'll give this about another 2 months, and then I'm sorry, but we're going to have to put you back on the metformin. And I went, no. I said, I'm going to do this for another 6 months, and then we need to have a conversation, but we're not going straight back on the meds. And it was like me taking back control of saying, I'm not going to go back down your route. We still need to discuss it at some point. I don't want to go just back onto the meds because you thought that was the answer. I think it was me taking back control. It was actually that point, Michael, that I felt like I was taking back control of my own health. Because going back to BP, remember, there's only myself and him at home, and we've got an empty nest now. But it means that we're actually just battling with each other all the time. And this doesn't leave you. Does that make, it's just constant.
No,
and that, I think that's the bit that's quite wearing as a couple or as a person that's going through it, is the constant someone watching you like a hawk all the time, waiting to see where you're slipping up. And it doesn't matter where you're out and about or anything, he'll be the one that pipes up straight away, whereas I'll do it discreetly. I'll always look up the menus before. I won't make a big deal about them at the dinner table. I'll just choose what I want and not talk about it being a low carbs alternative or anything else. I just order it because I do want to feel normal. But then BP will often look at it in front of maybe 6 or 7 people and quite comfortably say, well, I don't think there's much on here that you can eat. And that just puts you down straight away. But he thinks he's encouraging me, remember? He thinks by saying that he's encouraging me. And I'm saying, no, that doesn't help me at all. So
do you think,
I don't know.
Do you think, I mean, we talked about sort of family sort of support. Do you think if your surgery had offered a Zoom call with, say, 3 other couples, so 8 of you in total, or maybe 10 in total, or other family combinations, however, obviously each family's in a slightly different situation. Do you think he would have seen his role, alongside other people in a similar position to him? And do you think he would have been able to learn accordingly? And maybe that part of the solution lies in the concepts of sort of group support and group kind of encouragement and motivation.
Absolutely. I think that would have really helped us. I think anywhere that would have pulled BP in without him feeling like, here she goes again. Because I am a dog with a bone with certain things. And this is my thing, which I really won't let go of. And I think I just get really annoyed that I've done so well to get this far. So please just ask me if you don't know the right words, but don't just bring me down, because then that's the other thing, Michael. It puts you out for the whole day. So we need to hear it as a couple. We need to hear it as a couple, because I need to hear it from other people as well. And I'm not saying I've got it all right. I need to hear it from health professions about what I'm doing and that's wrong as well. So if we went to a group session, it would be really good that we both get to hear.
Yeah, I think sometimes, I mean, sorry to interrupt.
No, not
I think we sometimes talk about the sort of a conducive to the behaviour change that you're trying to pursue.
Mm-hmm.
And I think you're right. It's not just you've got diabetes partly because of possibly your genetic predisposition. You spoke about other family members having it.
Yeah.
But it's also the food environment in which you live, and the social environment, and the home environment, and so actually the solution has to take all those into account. And I think sometimes, talking to other people who have had a diagnosis of diabetes, there's a sense of they're the solely responsible for it, and actually, and you can roll that out, to the sort of more, the supermarkets where they put chocolate bars at the end of the aisle as you're queuing up, and it's. Yeah, and I think so. It's trying. How can we change our environment? And I think the environment is primarily our home, isn't it? And it's so. I think so. Having that sort of environment that actually supports you. So in a moment of weakness late at night, when you just feel like a snack, if there is no flour in the house, then you can't make a chapati.
Exactly. Yeah, something like that. But it's,
and And I think so. I'm hearing that it's about the solution lies not just in the individual with the diagnosis, but in the whole family, isn't it? And so we need to address that. Yeah. I think there's much more movement within the NHS, and sort of further afield, and certainly functional medicine, where community sort of group sessions where you have a health coach or a GP or a nurse, or actually working with a lot of people, then that's eminently more scalable. So, because one of the things that I think we find as a challenge is having the resources to do that.
Yeah.
I think in some of my other roles where I sort of do as well as my sort of NHS family medicine, the roles I have into looking more of a functional medicine route, which is looking for root causes, of common. So for example, we talked about, could the breast cancer and the diabetes be related? Obviously, we need to treat the breast cancer with, with surgery, with the right medication. But underlying that, is there something we can do in terms of diet, lifestyle, nutrition for you that actually reduces the risk of reoccurrence of breast cancer, reverses the diabetes, and I think one of the issues with that is it's individualized and personalized medicine, which at one level is what you're asking for, isn't it? You say I need that level of support that understands me and who I am, and of course that's incredibly intensive use of resources. That's a lot of time of quite expensive, highly trained people, nurses, doctors, and actually, which we don't have a lot of. So how can we so I think sort of group work is more and more seeming like the sort of ideal solution, where you have one clinician working with 10 people, then and you can pretty much, I'm sure that the challenges you had, although not identical, will probably be very similar to the challenges someone else is having. And actually at the end of we've all learned from each other, and actually probably the healthcare professional is learning as much about managing the behavioural changes.
I totally agree.
And Michael, do you think this pandemic has opened up opportunities there? I mean, obviously you're now conducting these a lot of your consultations. I know this morning you're kind of on consultations with patients. And so, do you think it's allowed you to do things in a different way, and we've now got the options to do that, maybe include family members and things like that?
I think it's interesting, isn't it? I think we're still seeing people face to face. I think we are. So there's nothing like, there's certain things you have to see people for and examine for. I think it has certainly moved, I think, the technology on in terms of kind of communicating via phone and Zoom. I think, yes, I think it has. I mean, I think the bigger pictures, I've got lots of thoughts on about it, which probably aren't that relevant here. But I think what is interesting is actually we've got a sort of infectious disease that has actually changed the world. And for some people it's pretty devastating. For a lot of people it's not. But for the people who it is devastating for, also tend to be the ones who have poor metabolic health. And what I am a bit disappointed on it, the solution hasn't really, from our political leaders, we haven't really heard much about the solution. I mean, to be fair to Boris, I guess he has admitted that if he was a little bit trimmer, he probably wouldn't have suffered so much. And I think he's correct in that. But I think, that I would like to hope that one of the long-term positives that come out of this is a real sort of motivation from individuals and from healthcare itself, that actually, we've got another epidemic going on, or pandemic of poor metabolic health. And where poor metabolic health meets a really vicious communicative or communicable disease, such as a virus like COVID, then you've got your worst case scenario playing out in front of us. So I think, I think on one level, yes, there's a few sort of positives in terms of how we communicate, but I think there's a lot of negatives. We've become a lot more isolated, which I think is a disaster. And I think one of the, coming back to the sort of, if you look at, breast cancer, diabetes, there's lots of evidence that actually outcomes, if you put people in support groups, there's a study that you put pregnant women in support groups and there's 30% less preterm births just because they're in a support group with other mothers. How do you explain that on a sort of medical basis? There's more to us than our biochemistry. We're
it's almost like there's something to the sort of immediate environment in that respect, isn't there? When you've got a support group, or I think that's in lots of ways, Ian and I recognise as what we did for our dad. We sort of almost created this, almost a false environment around him that was sort of protect. You got all this sort of communication coming in. You talked about the end caps in the supermarkets and things like that. It's exactly that, and it sort of, we didn't allow that, and so we sort of protected him from that until he was at a point where he could see a way forward for himself and actually wanted to continue that lifestyle for himself. So I think you're right. There's but isolation. We're hearing from people all the time at the moment that.
But I think
certainly the mental health.
The technology is key. I think one thing I will take forward from this is the fact that people are more comfortable with sort of, people hadn't heard of Zoom, possibly the majority of people before COVID, but they do now. So the thought of joining 12 people on a Zoom call from the comfort of your living room on an evening, I think is going to be far easier to sell to people than it was before. And especially if you say, well, look, at week 4, we all get together and we meet up. And for those who couldn't be on the call, we've recorded it. And here's, you can catch up. And so I think that is going to be hugely powerful for people going forward.
So just to finish, Amit, it'd be really good just to hear from each of you, really, in terms of your top couple of points, really. If you were going to sort of take from your own experience, what would be your takeaway points for people that, there's, like I say, mainly healthcare professionals watching. So what would be your advice to them, Amita, first of all, in terms of what they could do or say to a patient, just very simply?
I would say possibly look at them very individually. Don't look at them as just a number on a diabetic sheet, because I think when they look at you, it's very much, I've got, this is another type 2 diabetic patient. Look at them as a person and see how, if they are having conversations about wanting to change their lives in the way they want to take back control, then encourage them to try and see what the other options are. have other, don't just go down the one route. Really look at the person for the person they are, because I know there's not going to be that many emitters out there, but they do need to see somebody encouraging to see that. And that's where I think the groups would help, is that if they had them in the surgery, they could actually relate to somebody that they might see in the village, or they might even catch up with every week and see, oh, wow, somebody that did it 2 years ago has still managed to keep the weight off, as I do with Jeff. And Anthony, I do that with your dad all the time. I always think, well done, look, he does that, and look where he is now. Okay, the cameras are on him, but it's only his determination that's got him that far. And it's got all the support around him that supported him like that. Because I think you and Ian will both agree as well that it's not easy to support him when you're not living with him. But to check in with him, when you check in with him and you know that he's either got some emotions going on, other things going on in his life, those are the dip points where you need the support the most.
Yeah.
And
saying that, I think with my dad, it might have been more difficult if I was living with him. But no, I know exactly what you mean. Though.
Yeah, but I think those are the kind of things that I think credit to you guys that you took control of that. But I just think that not everybody's got that though, Michael, have they?
No.
Not everybody's got the support around them. Not everybody's in a position where they haven't got the children to look after. I'm at a different stage in my life where I think I have been able to put more time and effort into my health at the time that the health actually hit me, if you get what I mean. I think the cancer was the wake-up call. The diabetes was possibly a little bit of a back burner for a short time, because it took me a while to recover from just what the chemo had done to me. But what I'm saying is I think that is everything has to be then considered, Anthony. It's not one fits all, that's all. And not to just be sent off with a load of pamphlets or flyers to say, oh, go on, get on with your life, and we'll just up your glitz every so often, or we might just give you a bit more metformin, but you'll be all right.
Would you agree with that, Michael? Is that a fair assessment of what can happen in general practice, and what would be your advice?
I think so. I suppose my advice to patients, to people who are pre-diabetic or diabetic, and they actually want to take, like Amita's done, take control of their situation and improve their diabetic control or reverse their diabetes. I think it's about sort of personal responsibility. So if you are that person who wants to take that personal responsibility, I would say once you've made that decision in your sort of mind and heart, then I think the first thing to do is to find allies. And there was a great bit about the whiteboard with BP where Amita said, look, there will be no one in the kitchen. If you don't help me, so although ultimately you as that individual have got to take the responsibility, but draw in other people into your orbit who are willing to not take the responsibility, but share it and encourage you and challenge them. Say, look, if I don't get this wrong, it's not just me who it's going to affect. It's everyone around me, and we need to find a common solution. And I would extend that then to the healthcare practitioners. So find someone in your surgery, or someone or who can actually be part of that solution for you, and go to them. And I think sometimes the majority of patients now, I don't blame patients for this. I think sometimes the medical model creates dependence on the medical system. So patients they come to us and look to sort of us. They look at us as being responsible for their outcomes, if you like. And so we feel a bit overburdened by that. So we think, oh my goodness, there's no way this person's going to, I can't, how am I going to help this person? I can give them medication. But if you find someone and say, look, I'm willing to make this, I'm going to work really hard at this. I'm not, you're not, I don't expect you as my doctor to be completely responsible for me at all, but would you just be interested in me? And I've got a few ideas about how things might work. Can you just monitor me? Just see whether I'm being successful. I just need you not to be responsible completely for my outcomes, but just be part of the journey. And you've got access to blood testing. So would you mind actually, my HbA1c is shocking, and I'd like to test it in 3 months rather than 6 months. Would you mind doing that? And I think most clinicians will say, yeah, of course. And I just think to other people who've had bad experiences, don't be put off. Just keep at it. Keep sort of, trying to open those doors and trying to get other people on board. And I think we're all, we've all come through a scientific training. We're open, or should be open, to the evidence in front of us. And I think that's what changes people's minds when they see the improvement. We're not there to sort of deny what we see in front of our eyes. So I think, and you've experienced that yourself. So yeah, well done.
Yeah, I think it's really important, Michael, because I do think that if, not all the public, I don't think negatively of the doctors at all. I just wanted someone to sit there and just say, let's give this a go with your support. I wanted their support all the way through it. I wasn't prepared to go alone, but I just think, and I totally get it, for all the emitters that want to do this, there's probably 1,000 that don't. And I've seen that within our own family, which is really quite scary. There are members of our family now that we still sit around the table today, Michael, which is really interesting, who are very well educated, who are doctors and from the medical profession, who are taking metformin and taking the type 2 diabetes meds, and will say, why are you depriving yourself of a gulab jambu on Diwali? And I'm saying, no, because it's not good for me. And they're like looking at me going, but Amita, you've only got to take one metformin and one glycoside, and then you can eat what you want. And I went, where is the sensing? And it's absolutely mind-blowing that there are, it's not even, I think years ago I used to say with my mum and dad, it was because of the communication side. I think there was a lack of communication, of understanding the language correctly, to the conversations we're having. But I can sit around a whole table of family members who've got type 2 diabetes who will happily pop a couple of extra pills that day to have a ras malai or a gulab jambu or a jalebi, which is like the Indian highlights of their year.
How do we create more emitters then?
Oh God, you don't want more meters, you really don't. BP will tell you that. Please, no more emitters.
I think the good thing is, Amita, I think with your story going out there soon, so this will be released very soon, people will be able to watch all 3 episodes, is just, seeing those patient stories. The more of them you can get out there, the more patients you will have going to the doctor, not just, what medications can you give me, but actually, this is what I want to do with my health. I want to make it better. I want to improve things. And so I want to make changes, and I just need you to support me, exactly as Michael said. And I think that's all we did, with our dad. We went along with him the first time with the GP. We actually changed his doctor because we were getting such sort of negative vibe initially. And we changed the doctor, and then we sort of took this plan of, this is everything we've done. I said, this is what we want to do. We want to get the HbA1c down to here. And we're noticing X, Y, and Z about different foods. And so that's sort of empowerment. But I think it all starts with engagement, and obviously that comes generally out of inspiration and overcoming whatever barriers are there. So, but yeah, I think you shouldn't underestimate what a big part you've been in that. You could be a very big part in that.
Inspiring.
Well, one thing I would say, Michael, and I'm really intrigued to know that wherever I've seen anything about type 2 diabetes, about taking back control, there's very few Indian people out there, and yet we're the highest. This is what's like, it would have been great for me to watch someone that had an ethnic background like me to be able to reverse it. So I'm hoping that somebody that does get to see my film will be able to look at it and think, wow, she's got a diet like ours, because that's our biggest, I think that's the biggest battle normally with everybody. Even it doesn't matter about generations. I think everyone's like, oh, well, they don't know because we have a different dietary requirement. And I think, no, it's for us to take back control of what we do know. You can't push everything onto the doctors because they don't know. And yes, they might not know what we're eating in our homes, but what about our responsibility? It's going back to what you're saying, Michael. You've got to be empowered by what you're doing. You can't push everything back to the clinical professions and just say they've got to sort it because they must have a med for this, or they should have the knowledge because they've been. It shouldn't be like that. It should be like, I'm hoping, that's the thing I'm hoping, is that somebody's going to see this film and think, I can relate to this. I can relate to it, whether it be, the Afro-Caribbeans are the highest type 2 diabetes, as well as Indians, South Asians. So there must be something there in it. And that's only when it becomes relatable to you.
one of the key moments for our practice was showing the Fixing Dad hour-long film to our nursing staff and doctors. I think we were all pretty much on board at this point, but we were like, how on earth are we going to do this? And watching these two brothers kind of encourage, push, persuade, cajole their dad through this. I think people just, thought they were inspired that, this is possible. And although it wasn't really about a medical model, it was, I think people could see that as clinicians, we have a role to play in this. So when people come in inspired, we can be receptive and we can say, yes, this is possible. Of course you can do this. Have you watched Ian and Anthony's dad? Because he did it, and so can you do it. And we can help you. We can cheer you on as you do it. So I think, so there is that sort of taking responsibility, as an individual, but being inspired to do so. And I think, as you say, how do we, that value of that metabolic health, so as we're all, digging, so I get why people, don't want to, it's not about restricting or, sort of making people eat a boring diet. It's about saying, look, there's an amazing diet, a way of eating you can have. And guess what? It comes with great metabolic health, which doesn't come with diabetes, and it comes with less cancer, and it comes with less heart disease and less strokes and less dementia. What's not to like? And these guys have done it. Go for it. And sort of having that sort of setting before people that sense of hope and inspiration, and and let's all cheer on while they do it. So I think that's that's what I want to see more of in my career in the next 20 years. So
yeah, I agree.
I think that's probably a brilliant place to leave it, actually, Michael. You've both summed up really well there from the patient side and the doctor's side, so thank you. Something we've learned working with patients is that we need a reason to sustain our behaviours, a goal. And sometimes it's a bigger reason to stick with a goal than just weight loss or type 2 diabetes reversal. So often we ask people, what else do you want to do? Or what else could you do if your health was better? 47-year-old Sandy Silk from Gloucester had tried to lose weight many times and had attempted many types of weight loss plan, always finding that life got in the way. Last year, she was diagnosed with type 2 diabetes and her doctors wanted to start her on medication for the condition. Sandy refused, instead choosing to take measures to improve her condition herself. She decided to follow an 800-calorie shakes diet, which she had seen in the news. This year, Fixing Us partnered with Nestlé Health Science to create a 3-part series, following Sandy's 12-week journey using an 800-calorie total dietary replacement. In this session, we'll be talking to Sandy about the challenges on her journey so far, and also about her bigger goals for the future. We'll also be speaking to Gemma Durbridge, Senior Brand Manager at Nestlé Health Science, about why they wanted to support this project, and how an 800-calorie total dietary replacement can make goal setting easier and more manageable for some patients.
I phoned up to get the results and was told quite casually over the phone, oh yes, you have diabetes. Didn't really quite know what to say or what to do. You're sort of left to your own devices, really. Guilty and ashamed, humiliated, and as if you've got something that you could have prevented and done something about it. It's the general embarrassment and stigma. Nobody really likes to talk about it. I feel that I was quite young when I was diagnosed. I think that's partially a genetic thing. I want to prevent the idea of complications, to do something to just reverse it, really. I know that it can be reversed. My family would be delighted if I could get to a diabetes-free point.
I'm not sure they believe at the moment that I could do that, but I think they would be delighted. Yeah, that'd be amazing. Do you want to come and take part in this? Ant, do you want to take part in this? No. I work for a local green energy company. I've been there for 7.5 years. You'll have a portal to log in to book the appointments. The biggest obstacle to good health is a lack of time. If I had more time, I could invest that time in focusing on good health. I'm really looking forward to it. I really am. At the beginning, I'm just going to see how the next 7 days goes. My last HbA1c was 62 and I need to get that under 46. Yeah, looking forward to the results. I think it's good that you have this entire replacement so you haven't got to worry about preparing stuff for yourself. The dietitian was saying, you know, if you get really hungry when you're in work, have sort of half of one in the morning, then have your lunch and then have maybe the other half, but that counts as a meal to be counted within the 4 throughout the day. Somebody's birthday today, so this is birthday treats in the office. In my head, I can't have like a glass of wine or anything nice like that till November, which seems like a long way away, but if I can reach November and say that I haven't got type 2 anymore, then that will be the best outcome. It's been a long week heading home. I have some concerns about what my guys are going to think and do about this new plan that I'm on, whether they'll take it seriously. Not such a pretty picture today. Feeling tired, hungry, annoyed. One of those days where when I came in, everybody was asking me what feels like really ridiculous questions. Away in tonight, 14 stone 4. When you get home and people, you know, going on about pizzas and this and that, yeah, not very good. I had to message the coach this afternoon because I was on the verge of cracking. I like the fact that I can get support from Karen at Oviva, the dietitian, because you can ask all kinds of questions. Day 12, I need to pop into our surgery and give the doctors the sort of list of blood pressure readings that I've been taking, but now I've got this app. They are handily on there. We're involved in lots of things in the local area too. I'm heavily involved in our local rugby club, which is Stride Rugby. I think it first started when I was asked to help in the kitchen one Sunday. You know, Aidan had come here for a bit of a tryout. People that I know, some of my friends, particularly those at the rugby club, are giving me a lot of support with this, and that's really appreciated.
You've just left.
Rugby's it's a whole family thing, and we call it rugby family, don't we? And this sort of applies to friends we know at other rugby clubs as well. So the first couple of weeks were, well, a challenge. It's really convenient in that you have these shakes that you just, you know, there's no sort of querying what you're going to have. This is my dedicated cup to the new plan. Saturday morning, day 16. Just having this vanilla shake this morning. Adding this week's weight loss onto my Insta. I find it quite helpful when people are giving me encouraging comments. Yesterday was weigh day. I had another £3 gone, so £8. Having attempted to lose weight before, never quite got to losing a whole entire stone, so that was a massive breakthrough moment for me. Very happy.
To reverse this is our main goal, main aim, and hopefully for
a healthier future.
A healthier future. Oh.
Stop.
It's been a real privilege to work with Sandy and her family for the past 3 months or so. And as always, we've seen a real journey which has been the rough as well as the smooth. And in this session, we're going to talk about how and why we should set goals with type 2 diabetes to not only manage but also improve the condition. So we're going to look at how a short-term low-calorie plan can be a big part of this and actually make this more achievable and goal setting more manageable. So it's a real pleasure, Sandy, to introduce you in person today and just to hear a little bit more from you in terms of the 3 goals that you set in the process. So reducing the weight, reducing your blood glucose, and even climbing a mountain as well. So what was it? Just we've got a lot of healthcare professionals that will be watching today. What was it that made you want to improve rather than just manage the condition?
I didn't want to take the medication, and I knew that it was possible to do something about it without the medication. Admittedly, the online sort of suggestion to apply was, obviously at the right time. But yeah, I definitely didn't want to go down that road of meds at all.
And I think one of the things that you said had sort of prevented you in the past was the time factor. So you're very busy, obviously, in your everyday life. Do you want to just tell us a bit about, your life? And obviously we've seen a bit on the film there, but what was it that sort of prevented you from setting those big goals?
I think perhaps time just sort of escapes you, doesn't it? You don't really realise how many years go by. And then when I sort of sat and realised I've actually had this condition for nearly 6 years now and not really done anything much about it, perhaps has sort of little vague attempts, different diets and things, but it wasn't really anything proper. And I think it's about having the support and guidance of people that know what they're talking about, because lots of people will say, oh, try this, try that, try the other, and you can try these things half-heartedly. But I needed something a bit more commitment. I guess maybe my kids are a bit older now and perhaps don't need me around quite as much as they did when they were younger. So I guess that was part of the spurring motion.
Because that's a big factor in your life, isn't it? You've got family around you. Obviously, they're used to you cooking for them, and then you generally sort of sit down and join them for the meals. So how much of a challenge has that been, and how has this program sort of helped you to overcome that?
Well, things are a bit different now. Apart from tonight, I did get offered pasta again, but there we are. Things are a bit different. I think we've all looked towards a lot more of the sort of low carb options that suit everybody. That's really important for this house, is that whatever we make has to really suit everybody, because we're not really in for making 4 different things to suit 4 different people. I can't obviously expect them to go without their carbs all the time, but as much as possible we've tried to sort of mix it that I can have the low carby bits now that we're back on transition and onto food.
Yeah, I was going to say, so just going back a bit, because obviously people will have seen the first film where you're still obviously just starting out, really, or the first 4 or 5 weeks on the diet, so on the total diet replacement. So what how have you sort of managed to mix that in with your life? So having a total diet replacement while everybody else is eating normal food.
Well, you've probably seen from the films, the first few weeks were a bit higgledy-piggledy. It's very convenient because you've got these sachets and that's it. So, you have your 4 sachets and that's it. The first couple of weeks here, when everybody was still wanting to have all the things that we would usually have, I found really difficult. But there are support groups on social channels, and I joined one of those. And even though a lot of these people seem to be in different parts of the world, the idea is still the same. It's all still the Optifast products, and that was really, really helpful. And drinking masses of water.
So obviously, in that's just a bit on the results so far. I mean, obviously from what you've said, you've halved, you're halfway on your HbA1c to normal from where you were.
Yeah, that's right. So in the summer it was 80. Well, my daughter says it was 85, but on my little Fixing Sandy board here it says 83. But either way, 83, 85 was like way too high.
And obviously you're aiming now to sort of spur on from here. Is that's the goal over the new year?
Yeah, no, I want to get down to sort of like below 40 if I can. That's where we're heading. I've kind of like had enough of my relationship with my doctor. my relationship with my doctor is perhaps broken down a little bit, and yeah,
Well, it's interesting that you say that, because I mean, it's been a bit of a theme today, because lots of people have had, you know, issues with the way they communicate with their doctor. And what in your experience, what's been the problem there? Is it communication? Is it the way, or is it just do you feel unsupported? What is it with that?
I think they're just interested in medicating, and you know, if you've got a problem, it's sort of medicate. And I'll say to him, well, I'm doing this. So when I told him I was doing this very low calorie diet, he said, oh, what is that, very low carb? And I said, no, very low calorie. And he said, oh no, you must mean low carb. And I was like, well, no, I mean low calorie, what I've said. But it's just been quite difficult, I guess, with lockdown as well. So we've been having telephone conversations, so not even Skype or seeing each other. I think I've perhaps pestered him quite a little bit over these last 12 weeks about blood pressure going up and down and this, that, and the other. And because we're like a really small little local town, I actually sort of see him in Sainsbury's and stuff, and it's a bit weird. But yeah, he's just fixated on medicating.
It's interesting because we were talking to Professor Roy Taylor in an earlier session about this problem, that sometimes, you know, patients, the power isn't really in the patient's hands. So if the doctor does say to them, well, you know, just get on with, just lose weight, and you know, they don't necessarily give you anything practical or anything to follow, then it can be quite restrictive. You can't really take control yourself. But you've pretty much done that, haven't you? So I mean, you must feel like you've taken control in a way that, if without this plan, you probably wouldn't have necessarily,
yeah, I don't think I
done
would
it in that
have
way.
got this far without that plan. At the beginning of the year, so it was, I'm not sure if it was January or February, he said to me that I've wasted 6 years and that I have to start taking this medication because I'm going to get complications. He's a little bit alarmist, my doctor. He's a bit sort of like, you know, if you don't take these tablets, you're going to have your leg cut off. And, you know, I'm sort of like, all right, thanks. And a couple of other things he said, it's almost quite negative. He'll sort of say, you know, if you don't sort yourself out, you're going to have a stroke. And I'm not really sure that's the most encouraging thing to say to somebody who's just lost 1.5 stone and is quite pleased with that. So yeah, we have, like I say, I think our relationship's breaking down a little bit.
And this is it. This is what I mean. The overarching theme of our track is around patient engagement. It's about actually, you know, how do you engage people in their health and then keep them engaged in their health, you know, longer term. And it's very easy to lose people, I think, just giving too much fear, or or you know, the other extreme is that you see these kind of really good news stories on Instagram and things, but people don't necessarily identify with it because they don't see the struggles. Whereas I think in your journey, the good thing about this is that we're sort of going to be showing everything you've been through and the struggles as well as the high points. And, you know, yes, you've achieved massive things there, but it's been a journey. It's
been a challenge, and still a way to go. I think I spoke to him again about a different problem a few weeks ago, and I could kind of hear in his voice the huffing and puffing. He's like, what does she want now, you know? And I just thought it's not really my fault that the surgery is still refusing to see people. You can see nurses, but you can't see your GP even still now. And then I obviously had this other sort of scare with this endometrial polyp, and I tried to speak to him about that. And he's just like, just get off my phone, Mrs. Silk. Do you know what I mean? Just do one. Well, that's how it comes across. And I'm sure he doesn't mean it like that, but that's how it feels.
Yeah, it's been this sort of extra weird time, hasn't it, with the pandemic, and it's been a bit of a difficult time in that respect as well. But it's probably a good place to bring Gemma in. So, you know, in terms of it's interesting. Obviously, goal setting is not necessarily an easy thing when you've got a condition like type 2 diabetes. But why is it, Gemma, that you know, Nestlé Health Science wanted to support this project and get behind it?
I think it's really everything that Sandy has said is so inspirational, isn't it? In the way that people can take back control almost of their health through nutrition. rather than, having to resort to medication, like Sandy was saying, which is a lot of the time people's biggest fear. They don't want to have to rely on that for the rest of their lives. And we've seen it happen so many times, people gaining control of their health, losing a lot of weight. So we just wanted to share those sorts of stories, really. And when you watch Sandy's story, it's just amazing to see how someone can almost turn themselves around. And we wanted to share that because I think a lot of people, and I think you said it, Anthony, a lot of people don't think it's possible, and they can't relate to it because you see all these crazy things in media and online, and you think, oh, I'm never going to get to that point, it's too far away for me now. But actually what Sandy's shown is it's hard, yeah, it's challenging, but actually it's doable. And so we just were really keen to share that, really.
And how do you think this kind of, the TDR, we call it the total dietary replacement, do you think that can, ease the burden for patients and actually make that goal setting a bit easier, at least for that short period?
I mean, it's certainly showing that way, to be honest, with the trials and the pilots and the studies that we've been involved in. I think the way that TDRs work and products like Optifast, the reason they work and are successful is because it does take away that choice and it makes the whole thing manageable. So you don't have to think about food as much. Like you'd wake up in the morning, or what can I eat? What's healthy? What can I have for breakfast, or what can I have for lunch that I know is good for me? And it's really hard because you're constantly focusing on food. And what a TDR does is it takes away that choice, really. So you've got certain flavors, you've got certain formats you can choose, and that's the only choice you need to make. And then the rest of your time can be thinking about the other parts of your life and your water intake and things like that, rather than being totally consumed by what you can and can't eat.
Sure. Yeah. So, I mean, you mentioned the trial projects there. So, what are the kind of trials that you're doing? Is this with the NHS in the UK?
So we've done a few different studies with different areas, but one of the things we're working on at the moment is the exciting NHS England pilot that they've just launched. So it launched in September, and it's basically taking the same program that Sandy's been on, with the same support mechanism, but they're offering it across the country to 5,000 patients, people with obesity and type 2 diabetes. And it's just looking at how this program can work across a multitude of different people using different support mechanisms. And Optifast has been chosen as one of the preferred products within that pilot. So it's going to be going on for about 2 years. We've already started seeing people enroll on the program, and we're really excited to see kind of how that comes out, really, and what that looks like. Lots of Sandys out there, I think.
Brilliant. It was interesting because Roy was showing us a diagram earlier for people once they're in remission, or they've improved their blood sugars, just the differences that happen to the pancreas. You actually see like the actual graph, as they start to lose the weight, just how it improves the pancreas is unbelievable. Inside the body, it has huge impacts. All right. Now, so in terms of your, it's brilliant, obviously, Sandy, the journey you've been on. Now, in terms of longer term, I know you're talking about sort of, this is a project, an ongoing project for you now, isn't it? So you're going to be sort of monitoring your blood sugars more closely, really looking at keeping things in the right direction now.
Yeah, no, definitely. I think realistic targets. So particularly as this year has been a bit of a challenging year for everybody, and you have to try and remember to be kind to yourself. So when there have been occasions pop up, like it was my husband's birthday and we weren't locked down, so we could go out for dinner, of course I was going to take that opportunity. But it's about being a lot more mindful now. So in my head, I'm sort of thinking, February, March, if I can be down to sort of 42 or below by that time, although we did also speak about this thing and maybe doing it in 6 weeks' time. I think I'll have my actual surgery check on the 18th of December, so that'll be interesting to see what that looks like then.
I mean, something that I think should bring up here, because I was talking to another doctor earlier today, Michael Baslington, and he said something he's quite passionate about is that if a patient comes to you and says, do you mind if I have an HbA1c on 3 months because I've been making some efforts with my diet? rather than 6 months, as it usually be 6 months. He doesn't see any reason why anyone would not do that. If you've got if a doctor's got an engaged patient, someone that is interested in their own blood sugars and wants to see what's happening, then you really, as long as you're not doing them every week, obviously, but to give someone that opportunity to really, to add to their project, you really should do it.
No, I think our surgery, had we not been in this weird COVID situation, it would have been fine. But they just weren't interested. They were just like, yeah, December, you have to come back then. And I said, well, I've been doing this, really intensive diet, and I really would like to get a test. And they were just sort of like, no, no. But normally our surgery are pretty helpful. And the nurse who I think took this test for me to give me the high result in the summer, I think she would have certainly been quite open to me doing that. But I can't really sort of start marching in and giving their sort of instructions when they are having this ridiculously difficult time and they want everything to be done online. So they made me sign up to do everything online, and then I went in to book the blood test. They were like, oh no, we've taken that facility away, you can't do that. So I was like, lots of wasted time. But now I realise that you can get these things from that company.
I'm going to need to go to my
I
talking
got
points
mine
up
from
the top
last
there
week.
in just a minute, all right? So
I now realise
just
it's
don't touch the
pretty
screen
straightforward,
once
just
I'm
sort
on.
of order your own.
Okay, we're still
which
going.
is, again, I think
I'll
it's
just
a bit
tell
of
you on
taking
here
control.
once we come out to
I'm
the
not
logo.
sure how seriously
So
people take diabetes type 2.
I'll just I'll do 3,
within
2,
these
1,
surgeries,
and
apart
then
from
start.
giving you the standard, twice a year, this and that, and rub your feet.
Well, I might
to
just
see
send
if
you a
feel
message.
anything.
What I'll do, I'll just send you a quick
think,
WhatsApp once you're ready
I
to
think you
go.
have to take control.
Once you're live.
Just put go, yeah. Just put go.
I'll tell you when you're live.
And alongside, obviously, the blood sugar and the weight goals, and you obviously started walking a lot more as well. So I know in your next film we're going to see a bit more of that. But just tell us a bit about that and how it's sort of how the other ladies are doing as well.
You'd find it hilarious, to be honest. So for somebody like me to sort of start announcing they want to go up penny fan actually made quite a lot of people really laugh.
Yeah, sorry, I'm just turning off the other one. I didn't realise
so
I
when we
had that
did this sort of practice walk, and then I realised that I was nowhere near fit enough to get a penny fan yet.
Can you hear me
We went
okay?
off on this huge
we got you. That's
walk,
great.
sort of
Sorry, I
uphill,
realised I had
down
the other
dale.
the
For me,
speaker
that
part,
was
the
quite a long
normal
old
on.
walk.
Okay.
Luckily,
Ian, are you going to
someone in the
text me a
group
go
that knew
when
what
I'm
they
on?
were doing.
Yeah,
so
I'll
we had a
text you
proper
a
route
go
sorted
as soon
out.
as you're.
I attempted another walk
live.
last weekend, but you
We're
can
still
only
going
do
at the
this with
moment,
one
but as
other
soon as it's
person
after the
now.
logo,
So me and my friend Nikki, we headed off up over these hills. No idea where we were going, even though we live here. We got very lost.
Joe,
We were trying
nice
to
to meet
get
you,
to
by the
this
way.
viewpoint that we know is really
Ian.
high. We didn't
think we
quite
met
get to
before.
it. We're not sure where we were. We saw some lovely things, but we still to this
all
day
been a
aren't
bit
exactly
hectic.
sure
We lost
where
you
we
over there.
went, but we know our
Yeah, I
Fitbits
think,
told us we
he
did
might
8
have
miles.
frozen again. Yes.
So that was that.
That's the main thing.
Okay,
Did
well,
8 miles. Just
Yeah,
don't know where.
you first, and then
it's really good fun in a group, but now this is lockdown 1+1, but hopefully
Okay, well, all I
after
can do
some
is
of the
wait for it.
second
Obviously,
things
his
will be a bit
laptop's gone
more
again by the looks of it.
normal again. Yeah. I've got Friday off,
Might
and
be
I'm
a
planning to
clash
go on another
If not,
venture somewhere, but I
I'll
think
come
I'm
back
going to
to him after
download
Festival
OS
Info.
Maps. So we know
but
where we
I'll
are.
do it. I'll start to introduce him. Brilliant. If you can bring him in. So I suppose Gemma, you probably don't get to see the patient journey this close up as you've been able to this time with the film. So how has it sort of been, and how's it so I'm going to impacted you just watching that through? Is it Joe coming out?
It's been really good actually. It's been an eye opener. So we get told a lot of
So is it straight
information
after
from
this logo
patients and from
goes?
people going on these programs, and you get
Careful.
the odd anecdotal story about
Saying
this
goodbye, okay, they're
happened,
saying
but
goodbye,
actually
Ian.
to watch Sandy's story has just been great, and it's given us that extra level of information. So when we are talking about the product and looking at how the product
you're
can
just
help
doing your
people in
outro.
different situations, we can then build
Ian,
those
I don't
benefits
know. Can you
into
just
that.
make
So
sure you communicate with Joe on
watching
that other feed?
Sandy going to work
He's saying
and
something
having
now.
to prepare the shakes there, and looking at in
She does it
your
start.
kitchen and in your office, and how you're doing it there, and it's just quite interesting
Right,
to
Sam?
see them in real life. I know it sounds a bit strange, but
He's telling us
being
to-
used properly, and it just makes you think about it differently and brings it all to life.
Live now, it needs to go.
Yeah, and this is it. And I think for patients as well, Sandy, you sort of can't.
Sorry for a few
You
technical
can't
issues in there.
underestimate what an
We've
inspiration this
talked a
could
lot
be
today
people,
about
because it's,
how we engage
you don't
patients.
see many of these
So
journeys
let's talk a little bit
firsthand
about
with
the
all the
why
obstacles
for
and
our
the barriers
clients.
in there. So I think I'm going to extend a warm welcome. It's really looking like Joe Delahunty, really inspirational. Global head of we've had really good feedback from the people that have seen it so far, and hopefully we'll get a lot more. I'm hoping Joe's going to be online with us in just a moment. Be very proud of yourself in terms of what you've achieved already. Very exciting client
Doing
for
this
us at
diet
Fixing Us.
has really demonstrated
And we're looking forward to getting
to me
started
how
on a
much
three-part journey with
our whole
Essentia.
lives revolved around eating and drinking and socialising, because I think I've mentioned this a couple of times. I've been so sort of bored. I'm like, what do I do now then? So I've been doing really weird things like jigsaws because I don't know what else to do. And it just has shown us how much of our lives were all about meeting up with friends, going for lunch, going for dinner, eating this, eating that, cooking, having people round, all of that. And of course, none of that's been happening for the last 12 weeks. So, yeah, that's been, we realise now just how sociable we were. But the convenience factor of, this measured item is, which if it's a bar, you can cut it in half, have some of it then, have some of it later. Just sorts it for you, doesn't it? So you don't have to, But yeah, flavour wise, fine.
Yeah, it takes the worry away, doesn't it? And the convenience. I really liked actually in the first film where you were cutting the bar up and saying, oh, I'm going to have a bit now and then I'm going to have a bit later. And I think it's tips and tricks like that other people would really benefit from, because it can be quite daunting and think, oh, I've got to eat this then and I've got to eat that there. But it is flexible still. It's not as rigid as you can make it very rigid, but also you can flex it as much as you want. I think that often helps people with their goals as well.
And just find something to do. Like, I was sort of flapping around after 2 or 3 weeks going, what shall I do? What shall I do? I've got nothing to do. All I can do is sit here and drink water. What am I going to do? I think before you start taking the shakes, make a plan of things to do, like put some films down that you want to watch, or depending what time of year it is, plan to go out and about. Obviously we did go out quite a bit in the summer, but as lockdowns got worse, but definitely make a plan of things you want to get done, or use your time so you're not completely just sort of sat there going, oh my god, I'm really hungry and all I can do is drink water. Making a plan for other things outside of the food.
That's a really good idea, actually. I think the movie thing, that's really a really good idea.
Box sets, Netflix, all of that. Write it down what you want to do and do it.
Yeah,
Brilliant. No, it's really good. Thanks so much, Sandy, and thank you, Gemma, for your time. It's been brilliant, and I think obviously a lot of healthcare professionals watching. So, if there was one message you'd want them to take away, what would that be, Sandy, to a healthcare professional?
Give your patients a chance to express themselves and encourage them to take control. Yeah, that's what I would say. Yeah.
Brilliant. No, that's a great note to leave it on. Thanks very much. Thanks so much for your time. Yep. Come on. Well, I'm sorry again for the technical issues today. We're going to go straight into our final sum up here. We started out today talking about reimagining patient engagement. Well, let's try and reimagine the world of patient power. We were really fortunate to hear from the brilliant Professor Roy Taylor on the significance of putting power in the hands of the patient. Let's imagine a world where global pandemic might even be an incentive, an opportunity even, to go on a health journey in the way that John has over these last 9 months, and to take control of our own health. We talked to John Neary and to Con O'Neill about how we can engage with chronic conditions in a pandemic, and actually to potentially use this time to focus down on health risks and opportunities to not only improve general health, but also to actually improve our chances in the face of a viral pathogen. Imagine a world where, dare I say it, the only Jeffs we see are the lovable, stubborn characters of my childhood and not the statistics that Dr. Scott Murray describes, the 30 patients every minute who are dying from a heart attack or stroke. If we recognise and understand those barriers to patient success, we can hopefully avoid some of those risks. Imagine a world where people understand the value of their metabolic health and prioritise this within their families. We heard from Dr. Michael Baslington about creating healthy longevity. It's really not all about how long we live, because we are getting better and better at keeping people alive, but it's also important to shoot for better quality of life along the way. And we need to translate this to get creative in the way we talk to patients and reimagine the way we communicate this more effectively. So let's imagine a simple and effective goal setting process, taking away the complexities and finding simple plans and goals to set. Sandy's story that you've seen just now really shows how simple this process can be in an overly complex environment. And finally, let's imagine better ways to work together. We didn't get to hear from Joe Delahunty, Head of Communications at Ascensia today, but what we were about to talk about there in our final session was the big difference between engaging patients and engaging with patients, and the importance of really having a genuine take on that. By working with organisations, patients, healthcare professionals and industry, we believe we can build a better world together, which is why we'll go on doing what we do. We really hope that Fixing Us's conference shows that this reimagination is absolutely possible. And lastly, I just wanted to bring my dad back in for a minute, if possible, to ask how it feels for him to really look at how he's contributed and obviously influenced so many other journeys that have obviously come out of Fixing Dad as it's become Fixing Us. I think we may actually have Joe that we can bring back in now.
Yes, sorry about that, Anthony. I had a bit of a technical issue which I haven't actually managed to fix on my computer, but I've managed to join from my phone in rather quick time.
That's perfect. That's perfect. I was about to round up without you. That's really great that you're here.
Yeah,
I'm so pleased. So just we've talked a lot. We talked a lot about how we engage patients today, Joe, and
yeah.
Let's talk a bit about the why, for our clients. So, first of all, extend a very warm welcome to you. Joe is Global Head of Communications for Ascensia Diabetes Care and for PHC Group. Ascensia are a new and very exciting client for us at Fixing Us, and we're looking forward to getting started on a three-part journey with Ascensia in what we hope will be a much happier, it's got to be a more straightforward new year with more face-to-face events, hopefully.
Yeah, definitely.
So welcome, Joe. Thanks for joining us.
Thank you.
Let's start by perhaps talking about patient engagement. I mean, why is it that you want to engage with patients?
It's a good question. I think I've been listening to a lot of the discussion today, which has been really, really fascinating to hear, and there's been some really great examples. But let me tell you a little bit about our perspective as a company, and do let me apologize to everyone for the kind of slightly strange camera view as I'm having to rest my mobile phone against a laptop. It's not quite as I had intended. So for those of you who know us, Ascensia Diabetes Care is a global diabetes company. It was the diabetes business that was part of Bayer and then was carved out at the beginning of 2016 and sold on from Bayer. And our core business is blood glucose monitoring. And as an organization, we're actually focused entirely on diabetes. And our employees are really passionate about helping people with diabetes. It's part of our company mission. Our company mission says that we want to empower people living with diabetes through innovative solutions that simplify and improve their lives. And I mention that because that really speaks to why we engage patients. I mean, the ultimate objective of patient engagement is to benefit and improve the lives of people living with diabetes. And that's clearly what we believe as an organization, but should be, I think, the objective of anyone who's looking to engage with patients or do any activities that engage with patients. And I guess the way we try and look at it is that there are kind of two camps, really, two kind of classifications of these of patient engagement activities. There are the ones that engage directly with an individual about their own diabetes care. So that those are the types of activities that provide education, or even just the provision of products and solutions that we have. They are designed to engage patients in their own diabetes care. And I guess that type of engagement is really most effective when you're enabling a patient to engage in their own health. And I think that's one of the beauties of some of the work that you do, Anthony, at Fixing Dad and Fixing Us, is that the videos really help people engage in their own healthcare and tell them something and share experiences that help them to engage themselves, rather than just telling them something. And I guess the mistake that some companies make is to do that and try and tell patients or individuals with a particular condition something, rather than helping them to engage in their own condition. So that's kind of one group of activity, let's say. The other group that I would kind of refer to are the ones that help us do our job better as a company. And I know that a lot of my colleagues from the diabetes industry, or the medtech industry in general, will be doing the same types of things. But there are plenty of things that we do that help us to learn more and understand more. Things like education sessions where we can learn from the diabetes community, involving them in development and helping us to create better products and solutions, helping us to build reputation as a trustworthy, ethical and supportive company, and a company that is a real partner for the diabetes community. And I think that's also important, just as important as those activities that directly engage an individual in their care. And I guess one thing I would add is that I received feedback from a patient advocate who told me that there should be nothing for us without us. And I feel that's a really easy and a very clear way to look at it. There shouldn't be anything that we are doing as a company, or that anyone really is doing in this area, but for a patient, for a person who has a particular condition, without involving someone who has that condition in it, so that there is that way of checking, understanding, and getting that input. So just a very useful thing to live by.
That's really great, and it obviously fits very much with Fixing Us and what we find that inclusion, I think, is so important. I think in healthcare, sort of corporate healthcare communications, you do see a lot of sort of retrospective looks on a patient health, or you see those success stories. But I think we talked previously, didn't we, about how those sort of corporate communications, there's a big difference between engaging with patients and engaging patients in their health, as you spoke about there. Yeah. So what do you think is important within patient engagement? And
one thing I want to start with actually is a bit of a reaction to what you were just saying. Sometimes there's a bit of tokenism, and I think that's what we've got to try and be very careful of, is that you will have an activity that is, let's say it's a multidisciplinary group that's been brought together by a company, and they suddenly realize that there's no patient involved. You've got a lot of different physicians and clinicians and payers and other stakeholders, but the person with diabetes has been missed. And there is a risk that sometimes you kind of wedge that in, and also assume that person can speak for the entire community. And I guess that's one of the points I would start with, is that diversity is really important. And I heard one of your speakers earlier talk about this, and the fact that don't view a person as a number, view them as an individual. They have individual experiences, and there are many different experiences out there, and patients are all different. And it is important to try and engage multiple different patients. Now, it's not, as a company, it's not going to be feasible to get every different type of person with a condition represented, but at the same time, we can probably do a bit bigger effort and do more than one. I think that's probably the message here. I think if you look at it, the experience of a person with type 1 diabetes who lives in London is going to be very different from a person who lives in India and has type 2 diabetes, in terms of how they access the care, the technology they're able to get, what they have to pay for it. All of that will be different, and I think it's very important that there is some diversity and some a variation in experience that you have there. I think when you're engaging patients in some of those activities that I talked about, that second group of activities that really we engage them as a company on to try and understand more, learn more, and do a better job. Respect the fact that patients are the expert in their condition and what it's like to have that condition. I may be an expert. I'd like to say I'm an expert in corporate communications. Hopefully, I am, given what my job is. And clinicians are experts in treating diabetes, but often they are not the experts in having lived with it, lived with a condition. And your dad, as a perfect example, is an expert in living with type 2 diabetes and what it is like to actually have it. And I certainly am not an expert in that. And we need to try and use that expertise to help us do a better job. And then I think you look at the sort of the things that are pretty typical that you would expect in this area. I think integrity is important, making sure that you are engaging patients in a way that where the information you're providing is fair and balanced, that you're respecting their independence and giving them an opportunity to maintain that independence and be independent rather than compromising it in any of what you're asking them to do or any of the ways that you're working. And transparency, making sure that it is very transparent how you're engaging, who you're engaging with, and the reason for doing that and the purpose of the collaboration. And I think that the final kind of key point on this is around shared purpose. It sounds like it's very difficult, but actually I've been pleasantly surprised that when you try and do an activity, it is much more straightforward to actually find a shared purpose. There is generally a symbiotic relationship between an individual who has a condition and the company that is trying to develop a solution that supports them. There are needs on both sides, and there is usually an opportunity to find a common interest and a shared purpose that doesn't compromise either party and actually helps everyone out and makes it just really beneficial for all involved.
It's really interesting you say that, because we find that symbiotic relationship really does develop, and just so many organizations that we've worked with where that's really come through. Obviously with the Fixing Challenge, we work with Prudential on that, and just in terms of the goals, you find it does sort of permeate. It's almost like a culture thing that comes through, but it is very common. Yeah, you'd think it would be worlds apart, but actually I think everybody does want the same thing. I think Scott said it, Dr. Scott Murray said it in one of those sessions. Everybody does want patients to get better, and
exactly
we all want. So there are permutations of that and different things involved, but I think definitely that's a great sort of starting place, isn't it?
Yeah, and if you keep that as your guiding principle, I mean, it's hard to go wrong. If you keep that, your guiding principle is what you're doing, and I was mentioning our mission as a company, and there are other companies that do a great job of stating their mission as well. It's not just us. But if you're very upfront and you really stick to that as your objective of engaging with individuals with a particular condition, then and that's why you do it, is to at the end of the day, make their lives better. You're on very solid ground. I do think there are probably a couple of other things that are worth keeping in mind, and are probably the nuance to some of the engagements. Things like using the right language, and that's particularly important in diabetes, is using language that is motivating, empowering, and supportive. And I'm sure that your dad, in his diabetes journey, has come across people who've made negative assumptions and described them in a negative way that have actually really been demotivating and made it really difficult for him, when actually it would be much more it would be very possible to have encouraging, empowering, and supportive language around that. Stigma is another big issue. I mean, there is an assumption in society in general, but through many people, I won't say society in general, because there are people out there who understand this, but there are also many people out there that assume that if you have type 2 diabetes, you brought it on yourself, and that it's because you put on weight and you've not taken care of yourself. And that really isn't the case. There are so many factors in there that make it a very complex and very difficult condition, and difficult to try and change behaviors that might address some of that. And so some of those assumptions and stigmas there need to be kind of thought about and addressed in both in society, but also from companies as a way of sort of leading the charge on that.
It's very interesting, the language side of things. I think we realised quite early on that when, I think especially when doctors have such a small amount of time quite often with with patients. The use of language can be just so key. Just I think that the messages they go out of that surgery with can be just worlds apart, really, depending on who they see and the timing and what sort of mood the healthcare professionals in. All those kind of things can really impact. And I think just being mindful of the language we use, and as family members as well, and friends, I think it can have a massive impact on patients and their direction. So I think anything supportive, so any sort of inputs that are supportive, Essensia's products and services, and anything that's sort of adding to that and sort of giving momentum, as opposed to just that sort of static, you're stuck in this condition. It adds to that narrative, and it's kind of really building that up for patients, isn't it? Which brings on to the next talking point, really. So what sort of how do you sort of physically engage with patients? Give us some examples of how that works with Essensia.
Yeah, and I've kind of alluded to a few of them, but let me kind of touch on a couple and give a few more details around it. And again, we're still learning. We learn new things every day about how best practices and things that we can do better each time we do a particular initiative or engage with patients. I mean, there's definitely a consultation aspect to this, which I was referring to before. That can be in terms of product development, which I can say a few words on in a minute, but also when something's getting closer to market, actually testing it and even looking at marketing campaigns sometimes. I mean, there are some examples, and actually we had a recent example where we were partnering with an organization who released a booklet that we had supported, and unfortunately that organization had not thought through what the cover image would look like, and it had not been kind of gone through the proper channels of review within that organization. And actually it's the kind of thing that if that had been shared with a member of the patient community, they'd have picked up on it right away. But I think it was done in a little bit of a vacuum and was a really unfortunate. And I think it's just a great example of you can never, you should always try and ensure that patients are involved in these types of activities. Advocacy is another big thing that we try and work on. What advocacy can take lots of different meanings and descriptions. The way I view it is us trying to understand some of the issues within the diabetes community and finding ways to partner with them to try and address some of those issues. And we've done that mainly online, actually, in social media. So we've been running what we call social media summits, where we work with a number of bloggers and online online champions in diabetes, online influencers, to discuss certain topics that the community think are important, not ones that we think are important from a business point of view, but things that they feel need a discussion. And that's where some of the topics around mental health and stigma and language have come from that I was mentioning before. And we facilitate a discussion with them. We look at ways in which we can partner to try and fill the gaps that are there. And we've had some great examples where we've been able to do that. There was an example where it was clear that the people with diabetes could do with some additional support around looking at backup planning and what technology they needed should their kind of original base set of kit fail, and what they need to take with them on holiday or take to work. And so we used that a group of advocates to try and help us build a guide on backup planning. The same type of activity, we were looking at helping to promote the fact that mental health is a key complication of having diabetes, and just raising awareness of this. And so those other campaigns that are either communicating directly to patients or providing some education are also things that we've tried to do as part of advocacy work. And then the other area is really educating our employees. We try and have a monthly speaker from the diabetes community that comes and shares their journey and actually helps our employees understand more about what patients have to go through and what their lives are like. And as a result, it helps us to to understand about the way that we should be building solutions for them. I mean, it is that simple. That helps our product development. It helps our guys in distribution understand the best way to get products to people. It helps the people in website design understand the way to build a website. So it can be really multifaceted if you listen to individuals who have the condition and the people that you're trying to help.
It's really interesting what you say there about advocacy, because and you'll see from all the patients that have spoken today, they all become quite confident speaking, and they've been featured in journeys, but it's really what's key is I think there's almost a missed trick with the whole advocacy piece, because they all want to go on and sort of talk about what the issues have been, what how things could be improved, and also just give hope to other patients that might be like them. I think you mentioned Amita, with her journey in terms of the diversity thing, and she actually felt that there just wasn't anybody from the South Asian community that she could see as an advocate and engage with. Whereas hopefully now for other people, they'll see Amita's journey, and it will give them that relevant sort of journey to inspire them.
Absolutely, and I guess that's a really good way to bridge into some of the great work that we want to do with you guys, because the journeys that you working with us on, and I've seen some wonderful examples. I hadn't seen all of them, but I've been fascinated watching with great interest today, and as I've seen some of the additional ones, and that resonate. Building a journey like this, the reason it works is because it resonates. It's compelling, it's believable, and it helps people to understand that condition. It shows them that there are others out there having the same struggles and successes, not just struggles. They're having the same successes, and that they're not alone in trying to manage their lifestyle and manage their life with diabetes, and that can be enormously powerful.
Sure. Yeah, we're really hoping, and we're looking forward to getting started. And I think whenever we start on one of these journeys, we know that although there are similarities, there's often a whole new group of people that one journey can open up to. So there's always that individuality, and I think it sounds like an obvious thing, doesn't it? Let's treat each patient as an individual, but it's not always as obvious and as simple as it sounds. I think we can easily sort of group things together and aggregate things, whereas actually, there's much more power in those individual patient stories. And journeys. I think it's that the journey along the way is the important bit. It's not necessarily the before and after snapshot.
And I think that's you raise a very important point there, is the journey's key here, and that's again why the patient journeys I think are so compelling and powerful, because they follow somebody over a long period of time, and actually you only will get certain things will only come out in that period of time, and you can only really see either progress or challenges, and it's the format that you have developed is very unique to that, and you're showing things that people want to study but maybe necessarily haven't been able to study. As I say, it's a very unique way of showing it, and there is a balance to be had. I mean, we've said you want diversity in the type of patient that you see and the experiences that you get, but I feel that if you've got a whole journey, there's going to be something along that journey that is relatable to an individual. They're not going to have had exactly the same journey and exactly the same experience, but I feel if it's done well and if it is in a way that is engaging, there's likely to be something along that journey that somebody can relate to, and I guess that's where the power comes from. We're not expecting everyone who watch it to go, that's exactly my story, but I'd like to feel that there are some elements that everyone can relate to and feel that resonates with them and what they've done.
Yeah, absolutely. And interesting again as well, just to come back on what you said about employees within the company, we often find there is this dual effect, because obviously the employees are interested from the point of view of their own products and service and bringing relevance to that and actually making it real. But also the employees themselves, because obviously everyone has their own health journey that they go on. Everyone is on a health journey of some kind, and we've done, I think some of our works, we've worked with people like Transport for London, and we've sat in front of 200 managers, and a lot of them have had metformin for diabetes in their pockets. It's that sort of I think everyone can get involved in the journey, because I think everyone, if you've not got poor health yourself, you'll know of someone who is in poor health. It's kind of that, it's just that prevalent today, isn't it?
Of course. I mean, it is that prevalent today that I think most people, certainly in the UK and other sort of European and North American countries, will either either have a family member or will at least know someone who has diabetes. It is that common now that everyone is going to almost everyone is going to know someone. And then I think also I guess as you look at type 2 diabetes particularly, some of the factors that are of relevance and important are things that we're all, I guess, the majority of us trying to address and try and maintain as part of a healthy lifestyle. And again, coming back to the point I made earlier, that is not linked to any form of blame, but I think it helped people to relate to the fact that if you've got somebody in a journey who has type 2 diabetes, who is trying to make some changes to their lifestyle to help to improve their health, I think we can all relate to that. It's definitely going to be the same factors that most people would be out there looking to try and address.
Absolutely. Well, we hope so. And I think we've seen some really good questions come in today. And I think people have hopefully been inspired or taken some inspiration from some of this. And in solving that sort of patient engagement challenge, it's not a one-day thing, but hopefully today's been a sort of step towards it. But we're really, really grateful to have you on today, Joe. Really appreciate seeing you. And I'm really looking forward to working with you.
Yeah, no, I'm really excited. I mean, I think I'm really keen to show what is sort of an unfiltered journey of the challenges and successes of a person with diabetes, and really use that. And again, it comes back to the opening point and the questions that you asked me at the beginning, Anthony, about why do you engage with patients? I think it all comes down to that ultimate objective. If we can keep as our ultimate objective, our North Star, that we are trying to benefit and improve their lives and make things better, whether that's in the solutions or the information that we provide, then I think we're on a very solid footing. And I think we can, I'm equally as excited as you. I think we can create something really, really interesting. So hopefully people listening will watch this space and see what we come up with.
Yeah, absolutely. And this time next year, we might be playing somebody else's journey, which be really relevant.
Exactly.
Great.
Good stuff.
Brilliant. Well, thanks so much for your time, Joe, and we'll speak again soon. Thank you.
Okay.
Thanks for your
Thanks
time.
a lot. Take care.
Cheers.
Thanks,
Bye-bye.
everyone. Bye.
So I think we'll move on now to the final. We did do a little sum up, and then we came back to Joe. So I'm just going to finish really by extending that hope that today's conference has shown everyone that this reimagination of patient engagement, in tackling patient engagement, is absolutely possible. So finally, I'm hoping we can just bring my dad back in for just a moment. He's been sitting in the wings since the last session, just to talk about really how it feels for him. So Dad, how does it feel to have started all of this thing and being the inspiration that sort of led to so many more journeys in the long run?
Well, I mean, I remember you saying to me years ago when we first started this project, how I could actually be an inspiration to other people. When things started to go right for me and things were, I was starting to feel better, I realized that, yeah, this could possibly be. And when I got the reaction from other people, things they were saying to me, and it made me realize that, yes, anybody who makes that choice to change their life, you can be an inspiration for other people, and it really does work. You can do this.
Yeah. Were there any sort of main points that came out today? Obviously, Professor Roy Taylor had a huge impact on us at the beginning, didn't he?
Oh, absolutely. I mean, I always remember my visit up there and some of the things he told us, obviously with the fact that he actually diagnosed my cancer as well at the time, and it massive sort of impact on the way things went for me. And the whole thing it's just been a roller coaster. Really, really has.
I think what's so interesting, I'd like to bring you in now because it comes back to this for us. I think so much of what people identify with are the relationships and the kind of emotion and everything that goes around that. So, for us, it's always been a family journey, but for all of those other journeys that we've shown today, it's been a similar thing. And even when people haven't necessarily got support in the family, you do see all the arguments and you see the frictions, which are just real life. And I think we've sort of been through all that ourselves, haven't we? But with your, how do you feel to see all these organisations and industry, as well as the healthcare professionals and the other patients, industry coming in and supporting these journeys? How do you feel on that?
Well, I think it's just absolutely amazing that we can do that. We can have this effect that can be seen by not only other people, but as you say, major industries that can really make a difference. But they, come on board with this sort of thing and help us along the way. Or there is no end to this. We could literally change the world. I know we can. It may sound corny, but I really do believe it.
No pressure, yeah. No, I think this is it. It definitely has. Fixing Dad has grown up. It's become fixing us, and we want to be as inclusive as possible. So thanks, Dad. Thanks for your input today. I want to really thank everyone so much for their involvement today. Some great people who we're really in awe of in this sphere of patient engagement and healthcare generally. We want to thank everyone who's really contributed to the event. Say a big thank you to all of you who have logged in and watched our track today, and I hope you've enjoyed or taken something from at least one of the sessions. And I want to say a huge thanks to Giant as well for the platform. We've enjoyed almost every minute, a few glitches along the way, but thank you everybody, and let's carry on tackling the patient engagement challenge together. Thank you.